હા
પેલા બંધ કરી ઓડિયો
ઐશ્વર્યા દીદીનું છે.
એવું ચેન્જ
Hello. Good morning to all. Good morning to all of you. Sir, am I audible?
Yes, audible.
Yes, sir. Sir, am I audible? Hello. Good morning, all of you. Sir, am I audible?
Yes, sir, you are audible, sir. Sir, can we start, sir? Start, okay? Sir, can we start, sir? Good morning to our judges. Welcome to Hall F, everybody. We'll start with the first presentation today.
Hello. Am I audible? Hello, sir. Am I audible?
Yes, sir.
So, good morning, all of you. Welcome, Isacon 2021. We are starting our first session of today, that is paper presentation. For this session, I invite Dr. Dilip Ranparia and Dr. Vijay Narayanan as a chairperson. I request to start this session. Please continue. Dr. Dilip Ranparia,
Yes.
sir, continue this session. Invite speakers and continue this session.
Okay. I would like to invite participants to start the e-paper presentation.
Good morning, everyone. My name is Dr. M. Preeti Kiran. I am from Jawaharlal Nehru Medical College, Kelly University, Belagavi. The title of my paper is Efficacy of High-Flow Nasal Oxygen Therapy in Patients with COVID Pneumonia, which is a retrospective observational study. I would like to take this opportunity to thank my guide, Dr. Manis. Introduction. The COVID disease pandemic, which is due to severe acute respiratory syndrome, has caused a worldwide sudden and substantial increase in hospitalization for pneumonia with multi-organ disease. It can be asymptomatic or it may cause a wide spectrum of symptoms, which ranged from mild symptoms to life-threatening sepsis. In small proportion of patients, it can progress to more severe and systemic disease, which is characterized by sepsis, septic shock, multi-organ failure, apart from causing kidney injury, cardiac injury. And in few patients, it develops severe acute respiratory distress syndrome, which is an important cause of COVID-associated death. The primary strategy in these patients is supportive care, which includes oxygen therapy for hypoxemic patients, in which high flow nasal cannula has been reported to be effective. So the study was done to know the efficacy of high flow in these patients. The high flow provides gas flow which is higher than the patient's inspiratory flow demand, which enables the delivery of a constant fraction of inspired oxygen without dilution by room air. So the objective was to find out the efficacy of high flow nasal cannula by comparing the risk of invasive mechanical ventilation between two strategies of oxygenation, which is the conventional way and the high flow in critically ill COVID-19 patients. Here, the inclusion criteria: patients with acute respiratory failure who were diagnosed as RT-PCR positive and who were older than 18 years and who were supported by high flow standard oxygen therapy were chosen. We excluded the patients who already had primary pulmonary disease and whose GCS was low and who had respiratory acidosis in the first ABG done and who were already intubated at the ICU admission. Source of data: the data was collected retrospectively from our medical records of our hospital of all the patients who were admitted to ICUs in between March to June 2021, and this is a retrospective observational study. The criteria for standard oxygen therapy in our study is when a non-rebreathing face mask was applied to the patients at a flow rate of 6 liters per minute or more, and the flow rate was adjusted to maintain an oxygen saturation of more than 92%. For high flow, patients who needed standard oxygen therapy of more than 10 liters per minute to maintain saturation more than 92 were put on high flow. And then the patients were entered into two groups: standard oxygen therapy group and high flow group. And then these parameters: invasive mechanical ventilation after ICU admission, death at day 28, 60, ventilator free days, and mean length of stay were calculated. Here, the acute respiratory failure was defined as if the respiratory rate was more than 25 per minute and for standard oxygen of more than 3 liters per minute was required to maintain saturation more than 92%. Worsening respiratory failure was defined as respiratory rate of more than 40 breaths per minute, lack of improvement in signs, and if the patient developed more tracheal secretions, and if there is a respiratory acidosis. Intubation criteria: it will be based on clinical characteristic, the increased respiratory rate, worsening of respiratory status, high respiratory muscle workload, and arterial partial pressure of oxygen if it is decreased. And statistical analysis: mainly for continuous variables, we use mean and standard deviation. For discrete variables, we represented it by median. And the association between the outcome, clinical and demographic characteristics was calculated by chi-square test. And for discrete variables, Mann-Whitney U-test was done. Results: out of the 136 patients who met the inclusion criteria, standard oxygen therapy was given to 58 patients and 78 patients were on high flow. Out of 50 patients, 28 patients were intubated, and out of which 12 patients improved and 16 patients died in the standard oxygen therapy group, whereas in the high flow group, 26 patients were intubated and 13 improved and 13 died. Coming to the values: invasive mechanical ventilation, 28 patients were intubated out of 58, which was 48%. In the high flow group, 26 patients were intubated out of 78 patients, which was 33%. Death at day 28 was 20% in standard oxygen therapy group, 10% in high flow group. Death at day 60 was 20% in standard oxygen therapy, 12% in high flow group. The ventilator free days mean was 13.8 in the standard oxygen therapy group and 19.6 in the high flow group. Mean length of stay was 28 for standard oxygen therapy group and 20 in high flow nasal cannula group. Coming to the gender, in both the groups, the p-value was not that significant. Coming to the comorbidities, the p-value was not significant. Coming to that, there are day 28 and day 60. Although it was less in the high flow nasal cannula group, statistically it was not that significant. When we compare the outcome, improved and expired group, the outcome was better in high flow nasal cannula group and it was statistically significant. Coming to the ventilator free days and mean length of stay, it was statistically significant. Coming to the discussion, most of the studies on high flow and severe COVID patients were either case reports or expert opinions. Few studies like Demiol et al., he conducted a retrospective study to know the efficacy of high flow with COVID-19 patients who were admitted in ICU. They studied around 379 patients, out of which 146 patients received high flow, and these patients had a decreased requirement for invasive mechanical ventilation. So they concluded that high flow was effective, which is consistent with our studies as well. And Giordirello et al., he conducted a cohort study in patients in 2009 when the world faced the influenza H1N1 pandemic. And he said that the high flow is an effective way for early treatment in these patients also. Then a study conducted Bonat et al. On the efficacy of high flow nasal cannula in COVID-19 patients concluded that it was associated with a lower risk of intubation. And here he studied 138 patients, out of which 62 patients received standard oxygen therapy and 76 patients received high flow nasal cannula, out of which 46 patients were intubated in standard oxygen therapy group and 39 in high flow group. These results also were consistent with our findings. So to conclude, from a study, we conclude that the use of high flow nasal oxygen COVID-19 patients with acute respiratory failure was associated with a lower need for invasive mechanical ventilation. I would like to thank, these are the references. I would like to thank Isacon for giving me this opportunity.
No, judges, you may ask questions.
Hello everyone, good morning. Myself Dr. Umar Santoki, second year resident in Anesthesia Department at AMC MIT Medical College, Ahmedabad. Here I am presenting my paper, which was a comparative study of different uses of rocuronum bromide for intubating conditions and hemodynamic stability for general anesthesia in pediatric patients. Endotracheal intubation is of paramount importance in general anesthesia, requiring the relaxation of laryngeal musculature that leads to total inactivity of vocal cords. Out of all the relaxants, succinylcholine has been the drug of choice for the intubation since introduction. Doses of 1 to 1.5 milligram per kg provide the excellent intubating conditions in 60 to 90 seconds. Considering the side effect and contraindication associated with succinylcholine, opted for the search for a new non-depolarizing neuromuscular agent, which is a rocuronum bromide, which is a new aminosteroidal neuromuscular blocking agent related structure to vecuronium. Rocuronum bromide, when given in 2 to 3 times of the ED95, is said to produce excellent and good intubating conditions in 60 seconds, similar to those opting with the succinylcholine, but with the excellent cardiovascular stability. Rocuronum bromide, being a non-depolarizing agent, is devoid of adverse effects that are seen with the succinylcholine. Main advantage over the other currently used drug of this kind is fast onset of action, which could render the rocuronium bromide the muscle relaxant of choice for the rapid facilitation of the taken intubation. Present study was done to compare the effect of different doses of rocuronium bromide for endotracheal intubation at 60 seconds and to compare the effect of three doses 0.6, 0.9 and 1.2 milligram per kg of rocuronium bromide in facilitating tracheal intubation in various surgery in pediatric patients divided in the three groups of 20 patients each. The study was conducted by taking the 60 randomly patients, selected pediatric patients for various surgery. Patients belong to ACE grade 1 and 2 and aged between 2 to 12 years, divided into three groups of 20 patients each. Group A contains the rocuronium bromide 0.6 milligram per kg, Group B rocuronium bromide 0.9 milligram per kg, Group C rocuronium bromide 1.2 milligram per kg. Group allocation was done by the randomization table, computerized randomization table. Patients excluded were patients with the difficult airway, patients with the neuromuscular disease, patients on drug known to interact with the neuromuscular blocking agent, renal and hepatic disorder, and known allergy to drugs. Written informed consent has been taken, and patients were thoroughly examined generally and systemically. Patient in the operation theater, patient was monitored with the ECG monitor, pulse oximeter, peripheral nerve stimulator, non-invasive BP cuff. Randomization group allocation was done by the computerized randomization table. Pre-medication patient was pre-medicated with injection glycopyrrolate 0.004 milligram per kg IV and injection midazolam 0.02 milligram per kg and injection fentanyl 1 microgram per kg IV 5 minutes before the induction of anesthesia. Patient was induced with the injection thiopentone 5 milligram per kg IV slowly and injection rocuronium bromide according to group allocation at the time of the intubation of injection of rocuronium bromide noted. In group A 0.6 milligram per kg, in group B 0.9 milligram per kg, in group C 1.2 milligram per kg. Patients were ventilated with 100% oxygen with the face mask at 60 seconds after the completion of the rocuronium bromide injection. Laryngoscopy was done and patient was intubated with the well lubricated cuffed in endotracheal tube of appropriate size. Bilateral breath sounds check and equality of EtCO2 check monitor applied after fixing the tube. Anesthesia was maintained with the O2, N2 and sevoflurane and injection rocuronium. Per patient's heart rate, blood pressure, ECG, watch for any adverse effect like the anaphylactic reactions, rash, eczema, urticaria, and bronchospasm. At the end of the surgery, patients were reversed with the injection glycopyrrolate 0.01 milligram per kg and injection neostikin 0.05 milligram per kg. After recovery of spontaneous respiration, oropharyngeal suction was done, and after return of adequate muscle tone and power with the cuff reflex. Statistical analysis was done with the ANOVA with the Kruskal-Wallis test. Here's the table showing the comparison for the jaw relaxation, vocal cord position, response to intubation and intubating conditions between the group A, group B and group C. Here was the discussion that neuromuscular blocking agent are required for the smooth endotracheal intubation during the general anesthesia. There are maximum chances of a hypoxia, regurgitation and aspiration after the induction of the anesthesia and before the tracheal intubation with the cuff endotracheal tube. So muscle relaxation should be such that it facilitates the early intubation to decrease the chances of the hypoxia and regurgitation. Succinylcholine is a depolarizing neuromuscular blocking agent which has been gold standard since its introduction. Dose of succinylcholine is 1 to 1.5 milligram per kg provide the excellent intubating conditions in 60 to 90 seconds with the short duration of action. Unfortunately, it has many side effects because of which it has fallen in disrepute. Other non-depolarizing muscle relaxation like the etiquette macedonium have adverse effect like the histamine release and slower onset of action respectively. In search of alternatives, non-depolarizing muscle relaxation rocuronium bromide has emerged which has a rapid onset of intermediate duration of action depending on the dose. Patients were divided into three groups. Group A received 0.6 milligram per kg of rocuronium bromide, Group B received 0.9 milligram per kg, and Group C received 1.2 milligram per kg of rocuronium bromide. Demographic data shows the age, weight, sex, and age grading duration of surgery were comparable in each group. Patient was pre-medicated with glycopyrrolate, midazolam, and fentanyl. Group A 0.6 milligram per kg, Group B 0.9 milligram per kg, Group C 1.2 milligram per kg. After 60 seconds of giving rocuronium bromide, intubating conditions conditions were assessed and patients were intubated. In group A, 60% patients had excellent, 25% patient had good, and 15% patient had poor intubating conditions. 85% patient has a clinically acceptable intubating conditions. 15% has a clinically unacceptable intubating conditions. In group B, 85% had excellent and 15% had a group good intubating conditions, and 100% patient had clinically acceptable conditions. Group C, 100% patient had excellent and clinically acceptable intubating conditions. So rocuronium bromide in dose 0.9 to 1.2 milligram per kg seems to be adequate for the trickle intubation at 60 seconds, and 0.6 is inadequate for the patients for intubation at 60 seconds. From the above study, it is evident that rocuronium bromide does not cause any significant changes in heart rate, blood pressure, and following intubation conditions in clinically administered doses. In the present study, no adverse side effect had been reported in the doses in terms of staple SpO2, ECG, ETCO2, and hemodynamic parameters. My conclusion was 0.9 milligram per kg and 1.2 milligram per kg of rocuronium provide the clinical acceptable good intubation conditions in comparison of the 0.6 milligram per kg in pediatric patient. Here are some references.
Thanks, Dr. Uma, for nice presentation.
Sir, you may ask questions, sir. Dr. Dilip, you may ask questions, sir.
Thanks, Dr. Uma, for nice presentation.
Thank you, sir.
Good morning, everyone. Myself, Dr. Deepu, and my co-author and my PhD guide is Dr. Anila Malde. And we did a study to compare efficacy of landmark versus after-surgery inguinal neoadjuvant blocks children undergoing herniated. Inguinal hernia is the most common pediatric pathology, which is revived by herniopathy. Post-operative pain is the main concern in pediatric age group. Peripheral block requires lesser drug volume and the concentration than a caudal block with lesser side effects. So peripheral block can be given either by landmark-based or levochi carrier. But landmark-based had disadvantages of larger volume of drug requirement and systemic toxicity, high failure rate, and complications of colonic perforation, pelvic hematoma, femoral hematopathy, and malfacial deposition. Levochi block has advantages of requirement of lesser volume, real-time imaging of drug composition, lesser side effects, higher success rates, parents and fraction. Van et al. Published a systematic review and meta-analysis of randomized control trials in 2015. They found that Levochi neohypogastric, now block, and chances of dominance being blocked are associated with improved perioperative analgesia in patients following inguinal surgery compared with landmark-based techniques. However, only 4 studies could be included in this meta-analysis. Out of 4, only 2 studies were included. Our aims were to compare the intraoperative and the postoperative analgesic efficacy of landmark and Levochi neohypogastric block. Objectives were assessment of intraoperative requirement of additional analgesics, assessment of postoperative pain by glass score, assessment of postoperative requirement of rescue analgesics, assessment of adverse effects like motor blocking, nausea, vomiting, hematoma, and thyroid injection. So our study was a prospective observation study done in a tertiary care teaching institution from the period of November 2018 to 2020. It was approved by the Department of Review Board, Institution Ethics Committee and University. And study was registered in clinical trial registry in India. And the study population included all children scheduled for internal amniotomy under general anesthesia between age group of 3 months to 12 years. And sample size was 70 children done by consequent convenient sampling method. Inclusion criteria: 3 months to 12 years old children electively posted for unilateral internal amniotomy. Age grade 1 and 2 of both genders, and parents giving valid information. Exclusion criteria of who had coagulopathy, infection of the cytoplasm, known allergy to drug used in the study, clinically important cardiac, renal, hepatic, and neurological diseases. And the sample size estimation, actually we took a reference in the study conducted by Wilshi and Hannover. They had 2 groups, and each group contained 50 children. One group was facial click group, which used 0.3 ml per kg or 0.25% levothyroxine. Because you had a group used 0.25% levothyroxine, the volume was given as both the nurse and the liquid anesthetic solution. And they found that the volume required for USG guided block was 0.1 ml per kg, whereas facial click group required 0.3 ml per kg. And the intraoperative rescue analgesia requirement was higher in the facial click group, and postoperative pain was less in the USG guided group. The difference was statistically significant. So we used power and sample based calculated version P.0.43, and alpha error of 0.05, and beta error of 0.2, and sample size was 29 in each group. And we considered 10% dropout rate, so it was decided to take the sample size as 35 in each group. Statistical analysis. For continuous data, independent sample t test used to compare the continuous variables exhibiting normal distribution. If not normally distributed, were represented as median IQR and were analyzed using handwritten U test. For categorical data, chi-square or a Fisher exact test was used, and p-value of less than 0.05 was considered significant. And methodology under standardized general anesthesia, including 2 microgram per kg container with IG without muscle relaxation. Blocks were given. Those who received the landmark technique was grouped in group L. And the technique used was landmark technique, but used a double combo technique. And the line drawn from anterior superior spine to the umbilicus, divided into lateral 1/4 and middle 2/4 for the point of entry, using tightly gauge dual blunted needle perpendicular to the skin, and 2 pockets appreciated. One was external oblique and another one was internal oblique. And 0.3 ml per kg or 0.25% busulfan injected above the transverse abdominis fluid. Those who received alpha flow and position. Position initially 3 layers identified: external oblique, internal oblique, and transverse abdominis. And in ilioinguinal and iliohypoplastic nerves, they are seen close to one another as 2 small round hypoechoic structures with a hypoechoic border in the plane between internal oblique and transverse abdominis. And using 22 gauge needle, 0.2 ml per kg or 0.25% busulfan was deposited around the nerves in the transverse abdominis plane with a real-time imaging. Efficacy of the block. And intraoperatively, 15 minutes after the application of nerve block, more than 10% increase in the heart rate or blood pressure occurs during the surgical incision, then it was considered as inadequate block. Aliquots of fentanyl 1 mics per kg is given by mobile, and postoperative pain assessed by flax score, and postoperative rescue analgesia given by mobile. And we used rescue analgesia of fentanyl 0.5 to 1 mics per kg, flax score was more than 4, and if required, additional paracetamol 50 mg per kg IV was also given. Assessment of adverse events like motor blockade, assessed by Bromack scale, vomiting, hematoma, the function side by parameters monitored by heart rate, blood pressure, ETCO2, SpO2, movement in response to surgical stimulus, percentage change in heart rate and blood pressure after block, intraoperative requirement of rescue analgesics, postoperative flax score, post-op requirement of additional analgesics, and pain relief. So, total number of head anatomy happened during study year was totally 306, and considering inclusion and exclusion criteria, and those who received caudal block, and some patients were not given block due to time and did not give consent. Totally, we included 35 each group with no dropout rate. And the both groups are comparable in terms of month, age, and weight, and sex. The comparison of effectiveness of block intraoperatively, and intraoperative hemodynamics were same, and there were no difference between the groups in terms of this percentage change in heart rate and BP, and the requirement of IV fentanyl. Actually, in landmark based technique, 11 children required rescue analgesia, and USG based technique, 4 children required rescue analgesia. The difference was not statistically significant. Comparison of time taken for first post-op rescue analgesia. In landmark-based block, 50% of the patients required rescue analgesia post-operatively at 120 minutes, compared to USG-based group required for rescue analgesia at 405 minutes, and the difference was statistically significant. And other studies done by Wilski et al. And Nan et al. They compared the patient group and the USG guided group. Wilski et al. Found that amount of local anesthesia in USG group compared to patient group was lesser, and intraoperative additional analgesic requirement was higher in the patient group, and postoperative analgesic requirement is lesser in the USG group, and the difference was statistically significant. Nan et al. Found that intraoperative hemodynamic changes was higher in the traditional group, and increased inhaled sevoflurane concentration was higher in the traditional group, and the pain score and the recovery time was lower in the USG group compared to the traditional group, and the requirement of postoperative rectal acetaminophen was lesser in the ultrasound group compared to the landmark group. The stance of our study in our institution, we follow the patient up to 24 hours, which allowed to access the entry time to total post of day 1. Limitations are study. Our study was not a randomized controlled trial, and the depth of anesthesia using biospectral index or entropy was not monitored. We have not counted the cost requirement of inhalation reagent. We used injection fraction 2 mics per kg IV as a pre-medication, which may be masking the inadequacy. Conclusion: UIG-directed ilioinguinal and iliohypogastric nerve block has the advantage of providing longer duration of post-op analgesia with less volume of local anesthetic, perhaps because the deposition of local anesthetic close to the ilioinguinal and iliohypogastric nerves compared to the anesthetic. So these are my references, and thank you.
Thanks, Dr. Gitu. What are the other alternatives you can use for a block? Adjuvants.
Other than local anesthetics, sir.
Yeah.
As an adjuvant, we can use Dexa. Steroids we can use, sir. And for local regional blocks, we can use soda picot also, and fentanyl and normal.
Okay.
Good day to everyone. I would like to present a randomized study comparing intravenous infusion of lignocaine and dexmedetomidine on intraoperative hemodynamic stability and post-op analgesic requirement in patients undergoing laparoscopic abdominal surgeries. So, these are the contents. So in the era of modern medicine, minimally invasive surgeries have gained a lot of precedence due to its advantages like less pain, less trauma, and decreased duration of hospital stay. Pneumoperitoneum and carbon dioxide insufflation is associated with increase in serum catecholamine levels. So modern anesthesia practices aims to attenuate this sympathetic discharge and maintain hemodynamic stability perioperatively. Dexmedetomidine, being a selective alpha to receptor agonist, reduces catecholamine release by 90% and causes decrease in the heart rate and blood pressure, along with decreased systemic vascular resistance. Intravenous lignocaine has an analgesic, antihyperalgesic, and anti-inflammatory effects due to its sodium channel blockade and inhibition of N-methyl D-aspartate receptors. So the goal of our current study will be to compare and evaluate the effect of using intraoperative lidocaine and dexmedetomidine infusions on hemodynamic stability, recovery profile, and duration of post-operative analgesia requirement, and rescue analgesics in patients undergoing laparoscopic surgeries under general anesthesia. So aims and objective. Primary objective is, as mentioned previously, to compare the efficacy of both the drugs intraoperatively and post-operative, any opioid and opioid requirement and recovery profile in laparoscopic surgeries. Secondary objective, to observe if there is any adverse effects. So this is a randomized control study that was done done from November 2019 to May 2021 in hospitals attached to Bangalore Medical College and Research Center. Based on this formula, we have received a sample size of N is equal to 31. 62 patients were allocated and were randomly divided into two groups based on random numbers that is generated by computer program. Double blinding was ensured, and the two groups were Group L, which received preservative-free lidocaine 1.5 mg per kg bolus 10 minutes before induction, followed by an infusion of 2 mg per kg per hour. Group D received an IV dexmedetomidine 1.5 mg per kg mics per kg bolus, followed by 0.4 mics per kg per hour infusion. The inclusion criteria is patients who gave consent, patients who underwent surgeries between 18 to 60 years of age, and laparoscopic surgeries, and ASA grade 1 and 2. Exclusion is patient who refused to give a written consent, hypersensitivity to the drugs, and patients with systemic illness such as uncontrolled diabetes, hypertensive disorder, neurological disorders, patients with known hepatic and renal dysfunction or any cardiac dysrhythmias, and emergency surgeries. Institutional ethical committee clearance obtained, informed written consent was taken, pre-anesthetic evaluation was done, and patient was explained about the VAS course. Then pre-medication was injection alprazolam 0.5 mg and Rantac was given on the night. All patients were kept NPO and an 18 gauge IV cannula secured and fluids were started. All standard ASA monitors attached, baseline systolic, diastolic, mean arterial pressure, heart rate and oxygen saturation were recorded and when subsequently recorded till the end of surgery, and pre-medicated with glycopyrrolate, midas and fentanyl, and 10 minutes before induction, bolus dose of lidocaine 1.5 mg per kg and dexmedetomidine 0.5 mics per kg was given to patients allocated to respective groups. Pre-oxygenated with 100% oxygen for 3 minutes, induced with injection propofol 2 mg per kg followed by vecuronium. After 3 minutes, intubation done and maintained with 70 to 30 mixtures of nitrous oxide and oxygen and 1 to 1.5% of vecuronium boluses. And after induction, before pneumoperitoneum, the infusions were started and stopped till the end of and continued till the end of pneumoperitoneum. Patients were mechanically ventilated, and after completion of surgery, residual neuromuscular blockade was antagonized with neostigmine 0.5 mg per kg and glycopyrrolate 0.1 mg per kg IV. So in the post-anesthesia care unit, sedation score was assessed using the Ramsey sedation score. Pain was assessed. When the VAS score was more than 3, or when patient requested analgesia, we gave injection paracetamol 15 to 20 mg per kg as a rescue analgesic. Duration of post-operative analgesia was noted. Total analgesic consumption over 12 hours were noted. So any adverse effects like hypotension, bradycardia, nausea and vomiting were recorded. Data was entered in MS Excel, and MS Excel software was also used for evaluation. Categorical data represented as frequencies, discrete and continuous data expressed as mean and median, and categorical data chi-square test was used. Quantitative data, student t-test, p-value of less than 0.05 was considered significant. This is the age and gender. So from this we can infer that gender, age, BMI, anesthesia time was similar among both the groups. Now coming to heart rate. From this graph, we can elicit that dexmedetomidine had a lower mean compared to the lignocaine mean, which dexmedetomidine showed a mean heart rate value of 73.93 plus or minus 25 and 69.19 plus or minus 22 and 65.93 plus or minus 19 at 15, 30 and 60 minutes, which was significantly lower when the lignocaine group. Hence, from this, we can elicit that p-value was significant at all points of time. Hence, dexmedetomidine group had a stable heart rate intraoperatively when compared to lidocaine. Whereas coming to mean arterial pressure, dexmedetomidine group had a better regulation of mean arterial pressure throughout the study. And whereas VAS scores post-operatively were comparable between both the groups, p-value of more than 0.05. Ramsey sedation scores were also comparable between the two groups. Paracetamol consumption, though the post-op VAS scores were comparable between the two groups, rescue analgesia requirement was lower in group T, p of 0.05. Less than 0.05. Ruchi Kumari et al. Conducted a study to know the effects of perioperative infusions of lidocaine and dexmedetomidine on postoperative pain, and then they concluded that both the drugs were a good adjunct to laparoscopic cholecystectomy. However, postoperative recovery profile was better with dexmedetomidine, which is in conjunction with our study. Whereas Katharina Bellica also studied the efficacy of dexmedetomidine infusion as an analgesic during laparoscopic cholecystectomy and concluded that dexmedetomidine is safe and effective in improving analgesia. This was also used in conjunction in ours, with also concurrence with our study, hence concluded dexmedetomidine provide a better intraoperative stability. From this study, we can conclude that perioperative infusion of lignocaine and dexmedetomidine had a similar postoperative recovery profile, but dexmedetomidine group had a reduced requirement of rescue analgesic. However, dexmedetomidine group provided a better attenuation of hemodynamic stress response intraoperatively. No adverse effects were seen in both the groups. These were my references. Thank you.
Hello.
Hello, sir.
Hello. Hello.
Hello.
Dr. Mukesh Shukla. Hello. 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 Hello.
Shruti?
Hello, sir.
Yeah.
Yes.
Have you included non-hypertensive cases in your study?
Sir, we have we included non-hypertensive and hypertension, which is well-controlled cases, sir. Only ASA 1 and 2.
What was your observation who are already on beta blocker?
Sir, beta blockers, we have seen like in a few patients had bradycardia, sir, in dexmed group. So, but was controlled with atropine. And when patients were on beta blockers, we tried avoiding using dexmedetomidine in them, sir.
Okay.
Hello. Dr. Mukesh Shukla. Hello. Excuse me, sir. Hello.
Yes, sir. Please go ahead.
I want to ask that candidate when she has stopped the dexmedetomidine infusion.
Sir, once the pneumoperitoneum is released, I have stopped the infusion of dexmedetomidine and lignocaine both.
Okay, okay. Thank you.
Yes, thank you.
Thank you, Dr. Shruti.
Yeah, thank you, sir.
Who is next?
Good morning, everyone. Myself, Dr. Neha Dwivedi, and I'm going to present my paper topic on the comparison of sensory and motor blockade characteristic with the hyperbaric bupivacaine in the spinal anesthesia with and without IV dexmedetomidine in adult patient undergoing infraumbilical surgery. Preferred anesthesia technique for the most of the lower umbilical surgeries and the orthopedic procedure, that is subarachnoid block. In comparison to the general anesthesia, in the regional anesthesia, patient remained awake throughout the procedure and no active airway management was required. The technique is simple to perform and also more reliable in compared to the other neuraxial block. Most commonly used drug for the subarachnoid block, they are lignocaine and the hyperbaric bupivacaine. Bupivacaine is more potent than the lignocaine and also having longer duration of action. But once the effect of the drug wear off, we need other medication to provide postoperative analgesia like NSAID and the opioid to prolong the duration of the block, which is sensory and motor block, to provide and also to provide adequate postoperative analgesia. We actually many drugs they have been used with the subarachnoid block. These drugs are fentanyl and clonidine. Intrathecal dexmedetomidine prolongs both the motor and the sensory block. It also has nociceptive action for the both visceral and the somatic pain. It acts by binding to the presynaptic fiber and the postsynaptic dorsal horn neurons. Prolongation of the sensory and the motor block. It may result from the synergism between the local anesthetic and the alpha-2 adrenoreceptor agonism. Dexmedetomidine produces sedation as well as anxiolytic effect by binding to the alpha-2 adrenoreceptor in the locus coeruleus, which diminishes and inhibits the sympathetic activity. IV dexmedetomidine, it hasten the onset as well as prolong the duration of the subarachnoid block. Intravenous dexmedetomidine, it is usually given initially as the bolus followed by the maintenance dose. But the single dose of the IV dexmed, it can also provide adequate sedation during the short procedure under the spinal anesthesia. The supraspinal level of the analgesia and the sedation, it is due to modulation in the descending noradrenergic pathway originating in the main noradrenergic nucleus or the centers locus coeruleus. The supraspinal action of the dexmedetomidine, it could explain the prolongation in the spinal analgesia after giving the IV dexmedetomidine. The spinal level of the antinociceptive action, it seems to be through the substantia gelatinosa in the gray matter of the spinal cord, which is lamina 2 of the Rexate. It closes the gate at the dorsal horn to the stimulus, which is coming from the periphery A delta and the C fiber, which are responsible for the pain pathway. Also inhibit the release of the nociceptive humoral transmitter like the substance P and produces hyperpolarization of the cell membrane. This mechanism is effectively suppress both the neuronal firing as well as the neurotransmitter noradrenaline at the nerve terminal. When we give intrathecal route of the dexmed, this all mechanism, it could explain the mechanism of action of the dexmed by the intrathecal route. Postsynaptic activation of the alpha-2 adrenoreceptor, it results in the sympatholytic effect. Because of this effect, hypertension and the bradycardia, we observe after giving the dexmedetomidine. The hypnotic and the supraspinal analgesic effects of the dexmedetomidine, it is mediated by the hyperpolarization of the noradrenergic neurons, which suppresses the neuronal firing in the locus coeruleus. Material and method. Total 60 number of the patient were selected and 30 in the age group. 2 groups were made. Group C is the control group, which is also called as we can also call the normal saline group, and group D is the dexmedetomidine group. So 30 patients in the age group were randomly assigned. Patients were administered tablet alprazolam 0.25 mg and the ranitidine 150 mg night prior surgery, as well as the tablet ranitidine was repeated on the morning of the surgery with the sip of water. In the pre-op room, IV access using 18 gauge intravenous cannula was secure and the infusion of the ringalactate was started at the rate of 8 ml per kg per hour. Then patient was shifted to the OT after explaining about the study, again explaining about the study and after taking the consent. Once the patient was shifted to the OT, all the ASA standard monitors were attached: heart rate, non-invasive BP, ECG, respiratory rate, end-tidal carbon dioxide, and oxygen saturation. The baseline parameters were recorded. Now the subarachnoid block was given in the sitting position using the midline approach via 25 gauge spinal needle after confirmation of the free flow of the clear CSF. Hyperbaric bupivacaine, it was administered and the volume of the drug was 2.8 ml, which was around 14 mg. Patient was subsequently positioned to the supine. After that, oxygen supplementation was started using the face mask at the rate of 6 liters per minute and the hemodynamic parameters were recorded. Till now, this procedure was seen for the both group D and the group C. In the group D, after making the supine position within 2 minutes of the within 2 minutes after the administering the subarachnoid block, in group D, we gave 0.5 mg per kg dexmedetomidine infusion diluted in 50 ml of the saline, normal saline, and for the duration of 15 minutes. While in the group C, 50 ml of the normal saline was infusion was started for the 15 minute. Now, in the both group, changes in the hemodynamic parameter, onset of the motor and sensory blood, it was recorded. The hemodynamic parameters throughout the surgery were recorded at the certain interval. Sensory block, it was assessed using the spirit soak swab, and the motor block, it was assessed using the modified Bromage scale. Sedation was assessed using Ramsey sedation scale, and the post-operative pain assessment was made using the visual analog pain score. Here is some graphical representation of hemodynamic parameter as well as the total duration of the motor and sensory block. When we see the graphical representation, we see the two colors. One is the orange one and another one is the blue one. Blue one is the group D, which is the dexmedetomidine group, and orange one is group C, which is normal saline group or control group. Here we can see in the heart rate and the systolic blood pressure, the recording for the blue one, which is group D, is slightly lower as compared to group C, which means the hemodynamic parameter throughout the surgery, which was recorded at a certain interval, it was slightly lower in the group D. Same for the diastolic blood pressure as well as mean arterial pressure. Now, when we see the total duration of the blocks separately for the sensory and the motor block, total duration of the sensory block in the group D was 170 minutes, while in the group C was 124.86 minutes, which is a mean value, and total duration of the motor block in the group D was 144 minutes, while in the group C was 122 minutes. When we say about the onset of the sensory block was earlier in the group D than the C, but when we but in the motor block assessment, the onset in the group D and C, it was almost at the same time. Now, when we have already discussed the hemodynamic parameter, in the group D, the hemodynamic parameters, systolic BP, diastolic BP, and a mean arterial pressure, as well as heart rate, they were lower side as compared to group C, but there was no requirement of the injection atropine for the which I was supposed to give in the episode of bradycardia, or injection mefentramin, which I was supposed to give when there was hypotension. Mean value for the post-operative VAS, it was observed to be 0.84 plus minus 0.26 and 2.77 plus minus 0.37 in the group C and group D respectively. The difference was observed to be statistically significant. The mean value for the Ramsey sedation score, it was observed to be 3.29 plus minus 0.24 and 2.16 plus minus 0.14 in the group C and group D respectively, which was statistically significant. The post-op Ramsey sedation scale value, it was observed to be 2.72 plus minus 18 and the 1.63 plus minus 0.18 in group C and group D respectively, which was also statistically significant. So the conclusion of this story is the present study evidently showed that the IV dexmedetomidine as an adjunct to the hyperbaric bupivacaine in the subarachnoid block, it prolonged the duration for the both sensory and the motor blockade, and also the time of the request of the first rescue analgesia. It also provided arousable sedation without respiratory depression as well as a stable hemodynamic profile throughout the surgery, means perioperative as well as post-operative period. Thank you.
Hello everyone. My topic is efficacy of preoperative turmeric lozenges in addition with budesonide nebulizer on incidence of postoperative sore throat. A double-blinded randomized placebo-controlled trial. Postoperative sore throat incidence following tracheal intubation is 21 to 65%. It occurs mainly by two mechanisms. One is airway instrumentation causing mucosal injury and irritating effect of a foreign object in the trachea and upper airway resulting in inflammation. Turmeric is derived from the rhizome of plant Curcuma longa and has an active ingredient of curcumin. Studies demonstrated that it has following properties, that is antioxidant, anti-inflammatory, analgesic, and antimicrobial. Turmeric lozenges are found to be useful in the treatment of sore throat caused by common cold, submucous fibrosis, and many others. Our aim is to study the efficacy of preoperative turmeric lozenge and budesonide nebulizer on the incidence of postoperative sore throat. Our primary objective is to assess and compare the incidence of postoperative sore throat at 30 minutes, 2 hours, 6 hours, and 24 hours post-extubation. And the secondary objective is to assess and compare the severity of postoperative sore throat by 4-point scale and 10-point numeric rating scale. Methodology: after getting ethical committee approval, informed consent and preoperative evaluation. Our inclusion criteria was patients under ASA 1 and 2, age 18 to 60 years, patient undergoing general anesthesia with orotracheal intubation. Exclusion criteria was history of preoperative URTI or LRTI, history of preactive airway, pregnant woman, anticipated difficult airway, and more than one attempt at intubation, perioperative steroid use, and surgeries on the airway, neurosurgery, are done as emergency or lasting more than 4 hours. We recruited 100 patients and randomized into two groups. Group B received placebo lozenge on the previous night and morning of surgery 1 hour before intubation, and Group BT received turmeric lozenge on the previous night and morning of surgery 1 hour before intubation. All patients received pre-medication according to the institutional protocol. Budesonide nebulizer 10 minutes before induction of the anesthesia in the preoperative holding area. General anesthesia with endotracheal intubation according to the discretion of the attending anesthesiologist. Presence of post, severity of post in 4-point scale as well as in the 10-point numeric rating scale was assessed at 30 minutes, 2 hours, 6 hours, and 24 hours post-extubation. These are the study parameters which I told earlier. 24 hours post-extubation, if the severity of sore throat belongs to grade 3 or NRS more than 6, patient will be referred to ENT and their orders will be followed. We calculate our sample size based on previous study done by Chen et al. By using statistics and sample size pro app, reporting a 72.5% incidence of post for a 50% reduction in the incidence of post with the turmeric lozenge using power of 90% and alpha error of 0.05. We calculated the sample size of 78 patients, that is 39 per group. To meet our dropouts, we recruited 50 per groups. These are the statistics we used in our study. Results: demographic profile, there is no significant. In our study, we found that incidence of postoperative sore throat at 30 minutes, around 36% developed sore throat who received placebo lozenge, and 14% in turmeric group with a significant p-value of 0.011. At 2 hours, 34% in placebo lozenge and 14% in turmeric lozenge with a significant p-value of 0.019. At 6 hours, there is no patients developed sore throat in turmeric group, whereas in placebo group, around 18% had, with a significant p-value of 0.002. At 24 hours, 2% of the patients received placebo lozenge had sore throat, whereas no in turmeric group. Based on severity, post after 30 minutes, grade 0 around 64% in placebo group and 86% in turmeric group. Grade 1, whereas 16% in placebo group and 10% in turmeric group. Grade 2, 14% in placebo group and 4% in turmeric group. In grade 3, only 6% in placebo group and 0 in turmeric group with a significant p-value of 0.044. After 2 hours, grade 0, 66% in placebo and placebo group and 86% in turmeric group. Grade 1, 24% in placebo group and 14% in turmeric group. Grade 2, 6% in placebo group and nil in turmeric group. After 6 hours, there's a significant decrease in turmeric group, that the severity becomes 0, 100% of turmeric group and 82% in placebo group. Grade 1, 12% in placebo group, 0 in turmeric group. with a significant p-value of 0.007. After 4 hours, it is not significant. Numeric rating score, it was not significant over 24 hours. Discussion, our study finding shows that the incidence of postoperative sore throat was lower in the turmeric group, suggesting that turmeric has additional anti-inflammatory properties to steroid nebulization, and the severity in terms of pain and discomfort was also less in the initial postoperative period. In the turmeric group, the duration of the post was also significantly shorter, as evident by the postoperative NRS and 4-point scale. We concluded that the administration of 100 mg of turmeric lozenge at night and 1 hour preoperatively, in addition with budesonide nebulization, decreases the incidence of and severity of postoperative sore throat in patient undergoing general anesthesia with endotracheal intubation. These are the references. Thank you.
Hello.
Hello, sir.
Yeah. Was it palatable for all the patient, turmeric lozenges?
Sir, sorry, sir.
Was it comfortable, turmeric
Yes, sir.
lozenges?
Yes, sir. It was, yes, sir. It was tasty.
Produce any nausea, vomiting like things?
No, sir. No, sir.
Okay.
Actually, during intubation, the smell is good, sir, actually.
Okay. Thank you, Arun Kumar.
Thank you.
Very good morning to all of you. The title of my presentation is Comparison of Dexmedetomidine and Butorphanol as Adjuvants to Levobupropion in Epidural Anesthesia for Hip and Lower Limb Surgeries. My name is Dr. Ankita Atri and the co-author of my study is Dr. Ajay Gupta. Introduction. Epidural anesthesia, a regional anesthetic technique, offers superior pain relief and early mobilization, especially when local anesthetic is combined with an adjuvant. The local anesthetic that I took was levobupropion and the adjuvants were dexmedetomidine and butorphanol. Aim was to compare the hemodynamic, sedative, sensory, motor and analgesic properties of dexmedetomidine and butorphanol as adjuvants to levobupropion in epidural anesthesia. After taking the consent and the approval from Hospital Ethical Committee, 90 patients were selected for the study, and the patients were kept fasting after the pre-anesthetic checkup, and pre-medication was given. Only ASA1 and ASA2 patients were included in the study. Procedure. Patients were randomly allocated into 3 study groups, each comprised of 30 patients, and epidural anesthesia was given in L4, L5 space, and an epidural catheter was inserted 5 centimeters into the space. And the three groups were group L that received 19 ml levobupivacaine with 1 ml NS, group LD 19 ml levobupivacaine with dexmet 1 microgram per kg in 1 ml NS, and the last group was group LB that received 0.5% levobupivacaine 19 ml with butorphanol 10 microgram per kg in 1 ml NS. Sensory blockade was assessed every 5 minutes for first 30 minutes and every 15 minutes for the rest of the surgery. We calculated the time of onset of sensory block at T10, peak level of sensory block, time to reach the peak level, and the duration of the sensory block from the epidural injection till the regression of sensory level to S1. Degree of motor blockade was assessed with modified Bromage scale, and the grading of sedation was evaluated by using Ramsay sedation score, and the regression of motor and sensory block was also assessed. Pain intensity was assessed every 30 minutes with the help of VAS score. Duration of analgesia was taken as time period from the onset till the VAS of 4. And after that, rescue analgesia was given through the epidural catheter, which was kept for 24 hours in the postoperative period. Heart rate, BP, SpO2 were monitored continuously every 5 minutes for first 30 minutes and then every 10 minutes till the end of the surgery. Side effects were noted. Observations and results. The demographic variables were insignificant between the three groups. The onset of sensory block was earliest in group LD as compared to three groups, and it was highly significant. Highest level of sensory block, that is T5, T6, was obtained in 80% of the patients in group LD, and the result was found to be highly significant between the three groups. Time to reach the highest level was also earliest in group LD. Time to attain maximum Bromage score was also earliest in group LD, and it was found to be highly significant between the three groups. Regression to S1 was maximum in group LD. Complete motor regression to Bromage 0 was also maximum in group LD. Sedation used was assessed by using Ramsay sedation score. 60% of the patients in group LD showed score of 3, and most of the patients in L and LB had sedation score of 2. Hypotension was seen in 10% of patients in group LD, 2% in LB, and 2 patients in group L. Bradycardia was seen in 1 patient in LB, 3 patients in LD, and 1 person in L. And results were statistically insignificant. Nausea, vomiting in 6% of the patients as compared to 3% in LD and L. And it was found more in LB as compared to LD and L. The result was insignificant. Shivering was seen in 1 patient in L and 1 patient in LB, and not observed in LD. In our study, we conclude that dexmedetomidine is a better adjuvant than butorphanol when added to epidural levobupivacaine, as it produces early onset, long motor and sensory block, better sedation, and stable cardiorespiratory parameters. Thank you.
Dr. Ankita?
Yes, sir.
Yeah. How was your experience with intrathecal epidural butorphanol in terms of nausea and vomiting?
Sir, vomiting and nausea was more with butorphanol as compared to dexmedetomidine.
So what you have used for prophylaxis?
So I had used ondansetron.
Okay, only ondansetron.
Sir. Thank you, sir.
And what about bradycardia?
So bradycardia was seen more with dexmedetomidine as compared to butorphanol. Yes, sir. But the results were insignificant.
What was your lowest criteria to give atropine? Heart rate?
Sir, heart rate less than 50.
Okay.
Yes, sir.
Hello everyone, I'm Dr. Mamta. My topic is comparative evaluation of ease of intubation in sniffing and elevated sniffing position. Sniffing position has been the benchmark of teaching for a long time during DL. It has been reported that sniffing position provides no advantage over simple head extension for glottic visualization except in obese patients. On the other hand, simple technique of further neck flexion over SP may improve the view at the glottic aperture. So we planned this study to compare SP and ESP position with regard to ease of intubation using intubation difficulty scale as a primary objective, and secondary objectives were assessment of mask ventilation, modified Cormack and Lane grading, laryngoscopy, and intubation time. It was a prospective randomized comparative crossover study. It was done in Tertiary Care Institute from March 20 to June 21. Inclusion criteria was 60 patients of either sex aged more than or equal to 16 years, ASA 1 and 2 grade. Exclusion criteria was upper airway pathology, edentulous or loose teeth, mouth opening less than 3 centimeter, height less than 140, BMI more than 35, and history of OSA. Sample size was calculated as 60. It was calculated on the basis of a previous study, taking a sample size at 5% level of significance and 95% power, coming out to 18 patients in each group. But primary outcome had a non-normal distribution. So keeping in mind the period of study, non-normal distribution, and number of patients reporting to our hospital, we decided to take 30 patients in each group. Patients were randomly allocated into one of the two groups by a computer-generated list of numbers. In group SP, ETI was done in sniffing position. In group ESP, it was done in elevated sniffing position. Sniffing position was made by doing the horizontal alignment between the suprasternal notch and the external auditory meatus. Elevated sniffing position was made further placing a pillow below the head 4 centimeter beyond the sniffing position. In group SP, initially ESP was made and mask ventilation was assessed using hand scale. Then DL scopy was done and patient's airway was assessed using modified CLG grade. 4 centimeter heart pillow was then removed while Foley drips were left as such. Again, DL was done. Modified CLG was noted in sniffing position now. Now ETI was done and IDS was assessed. In group ESP, reverse was followed. Other parameters observed were time taken for laryngoscopy, time taken for intubation, total time. If endotracheal intubation cannot be completed after 3 attempts, an alternative method to secure the airway was used. Stats was done using SPSS version 16 and R programming. Quantitative variables and qualitative variables were expressed using suitable tests. Coming to the results, all the patients were analyzed and there was no dropout in the study. Demographic profile and the air assessment was comparable between the groups. This is the table 4 showing cross tabulation of the CLG grading from elevated to elevated sniffing position. Here 19 patients showed improvement in by 1 grade and 4 patients in 4 patients grade was similar, while in 7 patients showed grade by improvement by 2 grades. In from EA elevated sniffing to sniffing position, 11 patients showed deterioration by 1 grade, 6 patients showed improvement, and 13 patients had the same grade in both the positions. This is the comparison of mean value of intubation difficulty scale in group. Her average overall IDS was less in ESPS compared to the SP. Results of the present study show better IDS score, improved visualization of the glottis, and improvement in CLG and further flexion of the neck over sniffing position during DL. A study conducted on 7 fresh human cadavers using straight laryngoscope rate reported that increasing head elevation significantly improved the POGO score. Gudivada et al. And Albrani et al. Also examined the changing of the head position on the laryngeal view, and they found the same results as in our study. In contrast, Adnet and his colleagues compared laryngeal exposure in SP and simple head extension and found no significant difference between the two positions. Prakash et al. Reported SP superior to simple head extension with regard to ease of intubation. Crossover design helped to remove their individual variations, but it was also associated with the extra airway manipulation. There was no complication of the airway that can be attributed to extra airway manipulation. Limitations: it was a single center study, relatively small sample size, blinding was not possible. Further, all patients had BMI less than 30, so result cannot be extrapolated to obese patients. To conclude, elevated sniffing position provided more favorable intubating conditions than the sniffing position, and mask ventilation was equally successful in both the positions. These are the references. Thank you.
Good morning, everyone. Today's my topic is evaluation of preoperative renal function after administration of hydroxyethyl starch in orthopedic surgeries in elderly patients. Coming to the introduction, hydroxyethyl starch consists of large starch molecules which are substituted with hydroxyethyl groups to prevent degradation. There are many studies which are conducted on critically ill patients to evaluate the renal function after administration of HES. But most of the studies are conducted on a particular group and they implied the results to the all colloids. In our present study, we are concentrating on 6% hydroxyethyl starch with 135.4 on renal function. Our primary aim was to determine whether use of fixed volume of hydroxyethyl starch caused any changes in perioperative renal function. Secondary aim was to assess hemodynamic benefits. This is a prospective observational study. Patient aged above 60 years attending to the orthopedics for surgeries were included in this study, and they are divided into two groups, HES group and normal group. HES group received HES and the normal group received crystalloid group, and patient on renal replacement therapy and chronic renal failure are excluded. Preoperative blood urea, creatine, hemoglobin were assessed for all the patients. A fixed volume of 7.5 ml per kg of hydroxyethyl starch given to the HES group. The remaining group received crystalloid. A drop in mean arterial pressure less than 65 mm Hg was maintained or managed with fixed bolus of 4 ml per kg of fluids. If there is no response, phenylephrine was given. Blood urea creatine was recorded at baseline 24 hours, 48 hours, 72 hours, and at the time of discharge. Data were analyzed using SPSS 21 and expressed in mean and standard deviation, and all baseline parameters are normally distributed. Period t-test was done between baseline and respective intervals of urea and creatine values. A total of 844 patients were analyzed, and there is a statistically significant difference in intergroup comparison of highest mean and least mean of mean arterial pressure was observed. And if you are looking at the intergroup comparison, the mean arterial number of patients with intraoperative less than 65 mm of Hg mean were 7.5% in HES and 17.9% in crystalloid group, which is statistically significant. And at the same time, mean arterial pressure least and highest were 74.6 in HES, and which is nearer to the 65 in crystalloid group, which is statistically significant. Coming to the blood urea, baseline blood urea levels in HES is 29.68, which is comparable with 24 hours, 48 hours, and 74 hours, and discharge. And number of patients with doubling of blood urea levels were 0 in HES and crystalloid groups. At the same time, number of patients doubling of urea creatine values are 0 in HES and crystalloid groups. And compared with the mean and standard deviation, they are comparable. There is no doubling of creatine observed with HES and crystalloid groups. Coming to this discussion, the sympathetic blockade following neuraxial blockade leads to a drop in mean arterial pressure. If not addressed, leads to long-term effect, which was showed in Newham et al. Showed there association between intraoperative blood pressure and delirium. And at the same time, Beckham showed that mean arterial pressure less than 80% have associated with postoperative morbidity, which include multiple organ dysfunction, which includes oliguria and also renal failure. So maintenance of adequate systemic blood pressure and cardiac output is essential to maintain a perioperative renal to prevent perioperative renal dysfunction. Our limitations are clinical usefulness of creatine for timely diagnosis and assessment of AKI is limited, and there is a GFR will decline before the creatine levels. Coming to the conclusion, the present study results have shown better hemodynamic stability compared with the crystalloid group, and the less number of patients in HES group showed a drop in mean arterial pressure. These are my references. Thank you.
My topic for e-paper was comparison of onset of action, intubating condition, and recovery characteristics of the cis-tetracurium and rocuronium. Since the discovery of neuromuscular blockade revolutionized the practice of anesthesia by providing good intubating condition, and in addition, they reduced the anesthetic requirement. The present study was undertaken to evaluate rocuronium, that is a near-ideal neuromuscular blocking drug, with a newer neuromuscular blocking agent, that is cis-tetracurium. The aims and objective of the study was the primary objective to study the intubating condition of both the drug at a dose of twice into ED95 and to compare the onset, duration, and recovery characteristics of both the drugs. And the secondary objective to study the hemodynamic effect and to study the adverse effect. It was a prospective, comparative, double-blinded, randomized control trial undertaken in 60 patients of ASA grade 1 and 2 undergoing abdominal surgeries. The sample size was calculated from the previous study by Adams M. et al. And found to be 26 patients, but it was finally decided to include the extra subject, that is 30 patients in each group. Technique. Randomization technique was sealed envelope system that was coded as group A or group B. After thorough preoperative assessment and intraoperatively after attaching the routine ASA monitors, induction was done. After the loss of consciousness, the neuromuscular monitoring carried out by TOF simulation. For intubation, group A was given the injection rocuronium at a dose of 0.6 mg per kg and injection cis-tetracurium was given in group B. The onset time of neuromuscular blocking drug was assessed by the Cooper scoring system, that is by jaw relaxation when it was scored as 3 and TOF count was 0 to 1, and maintenance dose when given when TOF was 2. That was the duration of action. At the end of the surgery, the TOF count was 4 and ratio was 0.9 and patient was extubated. That was the recovery time of the drug. The result was in group A, the onset of action was found to be 2.4 minutes, and group B, the onset of action was found to be 4 minutes. And duration of action in the group A is 36 minutes, and in the group B was 47 minutes. And recovery time in the group A was 45 minutes, and the group B was 57 minutes. Onset of action was assessed by the Cooper scoring system in group A at 1/22, that is 2 minutes. Most of the patients had good intubating conditions. While in the group B, at 4 minutes, most of the patients have the good intubating condition. In view of intraoperative side effect, in group A, patient has pain on the injection site. So in discussion, the mean onset of action by subjective and objective assessment was significantly shorter in the group A as compared to group B. This is in agreement with the hypothesis that onset of action is proportional to potency of drug. The lower the potency, lower the shorter onset of action, that is the rocuronium. Our study the results were similar to previous study. And in view of clinical duration of action, group A was significantly shorter as compared to group B, and result was similar to previous study. And recovery time is also shorter in group A as compared to group B. So rocuronium in the dose of 0.6 mg per kg has shorter onset of action, clinical duration, recovery time, and provide excellent intubating condition as compared to the equipotent dose of the cis-tetracurium 0.1 mg per kg. Thank you.
A very good morning to all. This is Dr. Shweta from Nimans, Bangalore, and my study is titled Factors Predicting Difficulty in Accessing Pain Clinic Services During COVID-19 Pandemic in Patients with Trigeminal Neuralgia, Post-Radiofrequency Ablation, and Retrospective Study. So the recent recommendations for chronic pain during a pandemic suggest trigeminal neuralgia as a semi-emergent condition. But the follow-up of these patients post-therapy was restricted due to the closure of pain clinic services at our institution, travel restrictions, fear of contracting COVID-19 infection by the hospital visit. So here we have tried identifying the factors predisposing to these difficulties in patients. At our institute, the pain clinic services were closed from March to December 2020. So we had telephonically contacted 121 patients who underwent RFA in the past 5 years in the month of December and Jan. Out of 121, 76 were accessible telephonically. Demographic, socioeconomic factors, clinical factors, literacy status, distance to healthcare system, and the current health status were noted. Thus, collected data were analyzed descriptively and the correlations were calculated between the predictors for the difficulty. So out of the 76, 36 patients, around 47.3 patients had difficulty in accessing either medicines or consultation. The mean age of the patients was around 57.56 years. Sex distribution remained homogeneous. Around 37 patients had very good to excellent health as reported on a self 5-point Likert scale, and they did not access the healthcare system. And the remaining had statistically significant higher difficulty in accessing the services. Around 38 patients had mild or no pain after treatment and they did not access the healthcare system, whereas the other patients had significant difficulty in accessing the healthcare system. The recurrence rate was known to be 47.4, but with a lower pain scores in comparison to the pre-treatment scores, of which 32 patients, that is around 88% patients, were successfully treated with medicines and the mean NRS scores were 2.08 on the telephonic follow-ups. There was a negative correlation between the literacy status. So the literate groups had higher difficulty in accessing than the illiterate groups. And on the further analysis, there was no difference between the literacy status and the income status. But the patient with low income status and traveling from outside the state had statistically significant difficulty in accessing the services. With the further post-hoc analysis, it was observed that patients with higher pain scores had 2.339 times the higher difficulty in accessing either the medicines or the consultation, and so was the health status and the literacy status. However, the rural or the urban living of the did not make any difference. Along with that, the interstate travel in the low income groups, they had significant difficulty. So the clinical factors are not the sole factors that one has to look at while treating trigeminal neuralgia patients post RFA in a pandemic. In addition to the poor health status that is shown to be the strongest predictor, the literacy status of the patient should also be noted. Probably the self-reporting of the pain symptoms are better in the literate groups, and irrespective of the economic status, so all the patients had significant difficulty. But the patients from the low income groups and requiring interstate travel probably required an additional financial aid to assist, and they had more difficulty in accessing the clinics. And the distance from the institution to their place of dwelling did not came out to be significant. Probably the travel restrictions and the continuous lockdowns were at different time points between the states, and the healthcare services were available at their end. So to conclude, in a COVID-19 pandemic, the socioeconomic factors, the literacy status, in addition to clinical factors, are to be overlooked while treating chronic pain patients. Thank you.
Thank you, Dr. Sweta. It was a unique topic you have selected.
Thank you, sir.
Have you done online consultation of patients?
Yes, sir. Like first we started with the telephonic follow-ups, then that was later taken up by the telemedicine. So then we could do the online consultations as well.
But
And
illiterate people were able to understand your language?
Actually, sir, there was a lag time from the time, we tried accessing them and them coming, like arranging for their phones and, accessing them for the telemedicine and all that required some time. So that is the reason directly instead of going to telemedicine, we started with telephonic. So telephonic, since most of them, like they could manage with the mobile phones, like altering the doses of the medicines, that actually helped them. So when they came down for the follow-up on telemedicine, so we could actually make out that the scores were very less and most of them had mild pain. So that actually had helped them, sir.
Okay. Nice work done by you.
Thank you, sir.
Thank you, Dr. Sweta.
Thank you very much. Okay, sir.
Hello everyone. Today's topic is comparison of preoperative nebulization with ketamine and magnesium sulfate on the incidence and severity of postoperative sore throat in adult patients undergoing surgeries under general endotracheal anesthesia. Postoperative sore throat is a usual complication after endotracheal intubation resulting in significant anguish and annoying to the patient. Incidence of post in various studies is varying from 21 to 65%. Post is due to localized trauma to the mucosa during laryngoscopy and intubation leading to aseptic inflammation of the pharyngeal mucosa, which might cause significant postoperative morbidity. Ketamine and magnesium sulfate attenuate post by its action on peripheral N-methyl-D-aspartate receptor antagonism. Ketamine has been used as a gargle, but it is difficult to perform because of its bitter taste and requires patient cooperation, and large volume of drug is used, hence risk of accidental aspiration. There are the non-pharmacological and pharmacological methods. Nebulization mask and nebulizer were used. Aim of the study is to evaluate the effectiveness of nebulized ketamine and magnesium sulfate on the incidence and severity of postoperative sore throat at various intervals in patients undergoing general endotracheal anesthesia. Objectives: to compare the effectiveness of nebulized ketamine, magnesium sulfate, and normal saline on the incidence and severity of postoperative sore throat at various intervals in patients undergoing general endotracheal anesthesia, and to study the complications of the drug, if any. These are my inclusion and exclusion criteria. Sample size was estimated up to 33, but considering the dropouts, we had 35 in each group, so a total of 105 patients. They were randomly divided based on a number table in an opaque seal envelope into 3 groups. Group K received ketamine 50 mg, Group M received magnesium sulfate 250 mg, and Group C received normal saline. A total solution of 5 ml was made. Standard anesthesia protocol for induction and maintenance of anesthesia was followed for all the patients. After intubation, the ET tube cuff pressure was maintained up to 18 to 20 centimeters of water. While extubation, if there is excessive bucking on the ET tube, they were excluded from the study. Postoperative sore throat was monitored at 2, 4, 8, 12, and 24 hours postoperatively on a 4-point scale. 0 is no sore throat, 1 is mild sore throat, complaints of sore throat on asking, 2 is moderate sore throat, complaints of sore throat on themselves, and 3 is severe sore throat, change in voice or hoarseness associated with throat pain. Statistical analysis was done by chi-square testing. This is my consult flowchart. Results: significant reduction in the incidence of postoperative sore throat in ketamine group at various intervals was observed. Postoperative sore throat is a complication in patients undergoing general endotracheal anesthesia, resulting in patient dissatisfaction with the quality of care. N-methyl-D-aspartate receptors are found in the peripheral nervous system. These receptors have a role in nociception and inflammation. So, NMDA receptor antagonists like ketamine and magnesium sulfate have anti-nociceptive and anti-inflammatory effect, thus reducing the incidence of post. In present study, we observed there is significant reduction of post at 2, 4, and 8 hours in the postoperative period in ketamine group. Aditya et al. Found significant reduction in post in the immediate postoperative period in ketamine group. In study conducted by Ahuja et al. Observed decreased incidence of post in ketamine group at 2 and 4 hours postoperatively. Patients were alert, calm, and no complications were observed in the patients due to the study drug. And like hemodynamic changes, drowsiness, nausea, vomiting, delayed recovery, or postoperative hallucination. Concluded saying preoperative nebulization with ketamine significantly reduces the incidence of the postoperative sore throat at 2, 4, and 8 hours in patients undergoing general endotracheal anesthesia. Magnesium sulfate, though, reduces the incidence of sore throat, but not statistically significant. These are my references. Thank you.
Yeah, Dr. Sweta.
Yes, sir. Good
Yeah.
morning, sir.
Yeah, good morning. How was your experience with adrenaline nebulization? Have you used it ever?
Adrenaline nebulizations we have not used, sir. Like post-operative sore throat, no, sir. We have used only ketamine and magnesium sulfate for post-operative sore throat.
Why magnesium sulfate was selected for study?
There are few studies. Ketamine and magnesium sulfate act similarly, sir, with N-methyl aspartate receptor antagonism. So we compared those two groups, and there are many studies saying magnesium sulfate also reduces the incidence of post-operative sore throat, and both being having they do not have any adverse effect over the bronchial trees. Sir. Both are bronchodilators to some extent. So we used both of ketamine and magnesium sulfate.
Have you seen any adverse effect with magnesium sulfate during your study?
No, sir. We did not find any adverse effect as such because of magnesium sulfate. There are no any toxic effects.
Okay. Thank you, Dr. Sweta.
Thank you, sir.
Respected everyone, today I'll be talking on my study, comparison of standard weight-based and theorem-based dimension-based selection of IGL in pediatric patients, a randomized control study. The study was conducted under the guidance of Dr. Rupa Ma'am at KIMS. Supraglottic airway devices are increasingly being used for airway management in both elective as well as emergency conditions. Weight-based selection of the size of the device seems to be the standard technique, but this may not be possible in immobilized or unconscious patients. Hence, in this study, it was hypothesized that the first-time success rate of insertion of IGL based on thinner size eminence will be similar to weight-based method in pediatric patients. Aim was to compare the weight-based method with thinner eminence dimension-based method for IGL selection in pediatric patients. Primary objective was to compare the first attempt success rate of IGL insertion. Secondary objectives were to compare the number of insertion attempts, ease of insertion of IGL, ease of insertion of gastric tube, and to assess the complications. The study was conducted on 74 pediatric patients of ASA physical status 1, 2, 3, or 5 or 6, age between 6 months to 15 years post procedure. December 2019 to December 2021, the study is registered under CPRI. Inclusion and exclusion criteria being these, the study population was divided into two groups. In group A, IGL was inserted based on weight as per manufacturer recommendations. In group B, IGL was inserted based on the thinner eminence size. Long axis was measured from junction point of the thumb to wrist curl, and the short axis was measured from the lateral end of the thumb to the first hand line. A day prior to the surgery, allocation consignment of the two groups was done by closed envelope technique. Routine investigations were done as per institutional protocol. Routine standard monitoring included SpO2, NIBP, CO2, and ECG. Patients were pre-oxygenated with 100% for 3 minutes after pre-medication. Intravenous propofol was used as induction agent and muscle relaxant used for atracurium. The lubricated IGL was inserted by standard technique. Successful placement of the IGL was confirmed by observing the chest expansion of positive pressure ventilation, absence of audible leak, auscultation of bilateral air entry, and square wave intradal ETCO2. Primary outcome was first attempt success rate, secondary attempt success rate, failure of insertion. Secondary outcome were ease of insertion of IGL and rise tube and complications. After the completion of the surgery, neuromuscular blockade was antagonized with IV nifstipine and glycopyrrolate, and complications were recorded. Sample size was calculated using this formula after conducting a pilot study at KIMS. Considering the droppers, 37 patients were recruited in each group. Here are the results. Pre-operative demographic characteristic and ASA grading of the patients were comparable without any significant difference among the study group. The first attempt success rate was 97.4% in group A, 91.4% in group B patients without any significant difference with p-value of 0.358. Ease of insertion of IGL was comparable among study group. Ease of insertion of rise tube was comparable among study group. There was no significant difference among the study groups regarding blood staining of the device. None of the patient had complications of laryngospasm, hypoxemia, coughing, or gagging. Coming to discussion, this study shows that thinner dimension-based method is also effective as weight-based method in determining the required size of the IGL in pediatric patients. Previously, OCFR et al. Had conducted a study and suggested that the thinner eminence size fit into the weight-based size of this IGL, and so the landmark can be used as a practical tool to assess the appropriate size for pediatric patients. It is a routine practice by the anesthesiologist to choose the size of the intratracheal tube based on the size of the little finger of the child. Hence, although size selection of weight basis is applicable to the majority of the patients, the weight guidance should always be considered in conjunction with the clinical assessment of patients' anatomy. Limitation of the study were analysis is also required to test the feasibility of the method in adults and infants under 6 months of age. The technique of IGL insertion may not be applicable in patients with congenital abnormalities. Conclusion: the present study showed that the proposed 3 eminent size based method is equally effective in determining the size of the egg in children. Therefore, it can be used as proxy for the required size of the IGL in children in emergencies when weight of the patients cannot be assessed. Here are the references. Thank you.
Good afternoon, sir.
Good afternoon. Yeah, Dr. Lata, I couldn't see exclusion criteria. What were exclusion criteria?
Yes, sir.
Because of fast scrolling of
Sir,
slide.
ASA physical status 4, 5, and 6 were the exclusion criteria, sir. And patients who did not give consent for the patient guardians who did not give the consent for the studies, sir.
And airway examination, regarding airway examination, any exclusion criteria?
Sir, if the patient had any congenital abnormalities and facial deformities, even those patients were excluded from the study, sir.
What about obese patient, obese child patient?
Yes, sir. BMI more than 35 were also excluded from the study, sir. Yes.
Okay.
35 kg per meter square. Even those were excluded from the study.
Okay. Thank you, Dr. Lata.
Thank you, sir.
Swati from Pondicherry. My paper is on lower limb arterial changes following femoral artery cannulation for pressure monitoring and observational study. Femoral artery cannulation is a routinely performed procedure for pressure monitoring in patients undergoing cardiac surgery, along with the cannulation of radial artery in most of the centers. The need for femoral artery cannulation in every case has been in debate. By conducting this study, we decided to seek out the vascular changes as a sequel of transfemoral cannulation in patients who undergo cardiac surgery. Recently, radial artery cannulation for pressure monitoring is widely being used as it is found to have fewer post-procedural complications and had a better long-term outcome. It has its own limitations, including difficult accessibility owing to smaller diameter, anomalous branching patterns, and tortuosity. Intraarterial blood pressure measurement is more accurate than measurement of BP by non-invasive means, especially in the critically ill patients, and it helps in rapid recognition of blood pressure changes that is vital for patients on continuous infusions of vasoactive drugs. Cannulation of femoral as well as radial artery has been routinely done for pressure monitoring in coronary angiography and angioplasty. Various studies have been conducted comparing the usefulness and complications of transfemoral and transradial cannulation, but these studies have been conducted in the setup of PCI. Limited research has been conducted for the same in other cardiac surgeries. Thus, this study seeks to assess the arterial changes following transfemoral cannulation in these cardiac surgeries. Aims are objective to estimate the lower limb arterial complications in adult patients undergoing cardiac surgery following transfemoral cannulation for pressure monitoring with Doppler. This study was conducted at Sri Manakal Medical College and Hospital, Pondicherry, the Department of Anesthesiology. It is a prospective observational study. All patients above the age group of 13 years who underwent cardiac surgery from November 2019 to June 2021 form the study population. 60 patients with ASA 1, 2, 3 of age more than or equal to 13 years undergoing cardiac surgery were chosen based on the inclusion and exclusion criteria mentioned below. Sample size was calculated using OpenEpi software using the previous study. Inclusion criterion: all patients of age more than or equal to 13 years, patients with ASA criteria 1, 2, and 3, patients undergoing elective surgery, and patients who undergo CABG. Exclusion criteria: patients with congenital heart disease and undergoing emergency surgery. Study procedure: after getting prior informed and written consent and assent from patients preoperatively, the lower limb arteries were examined using 4D color Doppler, Volusan S6. A 13.6 megahertz high frequency linear transducer was used. We assessed for the presence of arterial wall thickening and calcifications, plaque, thrombus, luminal narrowing, and spectral pattern. Patient was shifted to OT on the day of surgery, and standard ASA monitors were attached, and a 16-gauge venous cannula was secured over the right hand. Under strict aseptic precautions, left radial artery was cannulated, and transducer was connected for beat-to-beat pressure monitoring. Then the patient in Strendlenberg position, right IJV was cannulated with 8.5 French triple lumen catheter following Seldinger technique. The patient was then induced and intubated using appropriate size ET tube and connected to ventilator. Under aseptic precautions, right femoral artery was then cannulated using standard technique, Seldinger catheter over guide wire technique. Immediate postoperative examination for bleeding was done. On the 8th postoperative day, lower limb arterial assessment was done for the presence of wall thickening, pseudoaneurysm, and traumatic AV fistula, wall injury with leak, plaque dislodgement, and spectral pattern with the help of Doppler. The presence of infection at the access site was also assessed by local examination and temperature monitoring. These are the list of variables and the measurement plan for the same. Statistical analysis was done using SPSS version 24.0. All results were considered significant if p-value was less than 0.05 with the 95% of confidence interval. Results pre-operative and post-operative lower limb Doppler examinations were performed in 58 patients who underwent coronary artery bypass graft from November 2019 to June 2021. Of this, 51 patients were male and 7 patients were female. Age group, most of the patients belong to the age group of 50 to 60, forming 55.2 percentage, and more than 60, 22.4 percentage people were. And most of the patients were found to be either normal or overweight, and only 2 patients belong to obesity. Comorbidities, 12 patients had type 2 diabetes mellitus, and 8 of them had systemic hypertension. Out of 58 patients, 7 patients had preoperative vessel wall calcification, that is 12.1 percentage, whereas the remaining 51 had normal vessel wall condition. The p-value was found to be 0.998. It was not statistically significant. Evaluating these patients into the postoperative period, we found out that there were no change in the vessel wall calcification. 5 patients had a preoperative Doppler finding of atherosclerotic plaque formation. Remaining 53 patients had normal vessel wall. The p-value was found out to be 0.998. It was not statistically significant. In the postoperative period, we found out that there was no dislodgement of plaque in these 5 patients. Discussion: with increasing age, the occurrence of atheromatous plaque formation, thrombus formation, and wall calcification increases. Thus, it becomes essential to observe the arterial changes post-cannulation. It has been determined that post-femoral artery cannulation, there was no significant changes in arterial wall calcification with a p-value of 0.998. In those patients with preoperative low limb arterial atheromatous plaque formation, it has been observed that there was no dislodgement of plaque in the post-operative period with a p-value of 0.998. Conclusion: from our study, we found out that there were no significant changes between preoperative and postoperative lower limb femoral arterial Doppler studies. Thus, we conclude that femoral artery cannulation for pressure monitoring in patients who are undergoing cardiac surgery is not associated with any serious or long-term complications. These are my references. Thank you.
हाँ करने ज्वाइन किया थी सर निकलेंगे ज्वाइन में
Hello, good morning everyone. Am I audible? Hello.
Yes, audible.
So now we move forward and go to the next session. In this session, the topic is ONCO anesthesia. I invite to Dr. A. Rudra, that is not our Dr. Bhavna Patel. Are you there? Okay. Dr. Komal Shah. I like to invite Dr.
Hello everyone, I am Sohan Solanki and I will be speaking on the perioperative management of CRS HIPEC. So I declare I have no conflict of interest. So in this lecture, I will be speaking on the primary peritoneal malignant cancers and peritoneal mets from these cancers, about the CRS procedure, HIPEC procedure, and the perioperative management of HIPEC, CRS and HIPEC, and the complication related to the CRS HIPEC. So as the name suggests, the cytoreductive surgery is the reduction in the disease load from the body, and it mainly refers to the abdominal pelvic cancers. And these diseases are the either primary peritoneal cancers and peritoneal mets from the GI and the gynec cancer. And traditionally, these were considered to have an incurable disease and a poor prognosis. But Dr. Paul Sukubecker showed that the surgical removal of visible tumors combined with the repeated chemotherapy can actually increase the quality of life and the survival in these patients. So CRS HIPEC is now the standard treatment for the peritoneal malignancy cases, and it is a complex surgery, and the perioperative management depend on the health status of the patients, disease load, the surgical factors, the intraoperative events, and the chemotherapy drugs used for the HIPEC. So what is the rationale for the hypex? So after for the CRS, the CRS can be done because the peritoneal is a completely resectable organ, and all the microscopic disease load can be removed from the body. And generally, these patients don't have a distant metastasis from this abdominal disease. For the hypex, which is intraperitoneal chemotherapy delivered at high temperature directly into the abdomen after the CRS, and it has a rationale because they have a better penetration into the tissue because of the raw surface. And the most important thing is that the heat and the chemotherapy, they have a synergistic effect to kill the cancer cells. About the chemotherapy, the most commonly used drugs are the carboplatin, cisplatin, mitomycin C, oxaliplatin, and the adriamycin. And these all drugs, they have a huge synergy, they have a good penetration into the tissue after surgery. And the most important thing is that they are non-cell cycle specific drugs, means they can kill the cancer cell in any stage of their cell cycle. For the patient selection, so these patients should be either primary peritoneal cancers or patient with the peritoneal mets from the GI and gynec cancer, and there should be no disease outside the abdomen. Sometimes the disease may present into the pleura, which can be resected along with the abdominal surgery. And these patients should be having a good performance and the physical status. For the perioperative management of CRS hypex, we published this first international consensus guideline in 2019, and we came out with the complete perioperative protocol, the preoperative, intraoperative, and the postoperative protocol, and the management strategy for the CRS hypex. So about the pre-op assessment and optimization part, so all these patients should be counseled for a long surgery and adverse outcome because the patients may or may not have a good outcome. These patients should be especially seen by a consultant anesthetist who is actually present at the time of the surgery. All the recent lab investigations should be done a priori, and we always do a 2D echo for the cardiac evaluation because these patients undergo a large fluid shift during the surgery. About the prehabilitation or the optimization part, these patients should be optimized nutritionally. Anemia management can be done. This should encourage for the physical exercise and the chest physiotherapy. For the type of surgery, the type of surgery and about the stage of surgery, the stage of surgery can be divided into 3 parts: the CRS phase, the hypex phase, and the reconstruction phase. In the CRS phase, the disease is decreased from the body by surgery. In the hypex phase, in which the chemotherapy is given into the abdomen for around 90 degrees at 41 to 43 degrees centigrade by a specialized pump, and which is run by a perfusionist. And in the reconstruction phase, the bowel anastomosis is done. The patient is subject to the recovery of the ICU. For the time course and phases, you will see that the patient having a CRS phase, hypex phase, and a reconstruction phase. And you see which H0 phase. H0 phase is actually start around 30 minutes to 1 hour prior to surgery, prior to hypex. So it actually this H0 phase is start of when we actually starting preparing the patient for the hypex phase. So we passively decrease the temperature up to 35 by just switching off the warming device in the fluid warmer. Again, we have to prepare the chemotherapy drug in a carrier solution. We have to calculate the body surface area of the patient for the chemotherapy given. You see the H1, H2, and H3 phases. So they are, you see that when you see the temperature, so the temperature rise steeply up to H1 phase and then rise slowly up to H2 phase, and then it becomes plateau up to the H3 phase, and then comes the reconstruction phase. For the disease, how bad is the disease, or how much is the disease load present in the body? So Dr. Paul Sugarbaker came out with this scoring system. This is called the peritoneal cancer index, in which he divided the abdomen into 9 equal quadrants and 4 areas onto the small intestine. And they give scoring of 0, 1, 2, and 3, and they given 0 scoring when there is no tumor in any particular quadrant. Score of 1 is given when the tumor size is less than 0.5 centimeters seen. Score of 2 when the tumor size is between 0.5 centimeter to 5 centimeter. Score of 3 when the more than 5 centimeter tumor is seen in particular area. The minimum scoring is 0 and the maximum scoring is 39. The more the scoring, the worse the outcome, and the less the scoring, the good outcome. But in a case with like pseudomixomapide, where actually this PCI scoring really doesn't matter because they are anyway have a good outcome with the high PCI also sometimes. About the surgeon's role, so they have come out with another scoring that is called the completion of the cytotoxic scoring with is called the CC0, 1, 2, and 3. So they are given the scoring of CC0 when they remove all the disease load from the body and there is no peritoneal staining exposed after the complete exploration. CC1 when the tumor of less than 2.5 millimeter is remaining in the body, and CC2 and 3 when the tumor load of more than 2.5 millimeter is remaining in the body. But if there is CC2 and CC3 surgery is done, so that means it is an incomplete surgery and there will be no benefit if we give HIPEC after CC2 or CC3 type of surgery. For the intraoperative management, so the standard this general anesthesia is given just like any major abdominal surgery. So thoracic epidural analysis can be given if there is no contraindication to epidural placement. For the maintenance of anesthesia, the inhalational or the TIVA can be given as per the choice. But one study showed that inhalational anesthesia is actually better in HIPEC patients in terms of the long-term outcome, long-term outcome in these patients. For the monitoring, all the standard monitoring are used, like PTCO2, ECG, blood pressure. For the invasive blood pressure monitoring is done because this patient may have the large BP fluctuation into the in the intraoperative period. The core body temperature is mandatory because the patient also undergo the temperature fluctuation from hypothermia into the CRS phase to hyperthermia during the HIPEC phase. Cardiopulmonary monitoring is also needed because the patient may go under the large fluid and the blood loss and the large fluid shifts. And CP monitoring may or may not be needed, but if we need a vasopressor, it is good to have a central line in place. We should also be doing the blood gas and the lactate monitoring because the hyperthermic phase, they always the lactates are increased in that period, and also because of the patient is having some hypoperfusion, then you may have a high lactate intraoperatively. In the CRS phase, we always use the fluid warmers and blanket warming blankets to keep the patient in the normal thermic phase. For the hemodynamic and the fluid therapy, so like I already told you, the advanced hemodynamic monitoring should be done if the patient is having a high disease load, the patient is having a bad cardiopulmonary comorbidities, or we are expecting a major fluid and the blood loss. And about the fluid therapy, so fluid therapy can be given by a goal-directed strategy. So goal can be anything like the stroke volume variation, pulse pressure variation, stroke volume, or so on. And the balanced solutions are always better than the Thomas line. And if you want to give colloids, so albumin is the colloid of choice because the starches are really bad for the kidneys and all. And we should be always doing some intraoperative investigation to see the hemoglobin and the coagulation factor because the patient may have a major blood loss into the intraoperative period. This is the HIPEC source, so you can see that we are using the this arterial line monitoring and apart from other standard monitoring, we are also using the cardiac monitoring. This is the abdomen during the HIPEC phase. You see this the pump using for the pump used for the HIPEC. For the hemodynamic monitoring in the CRS phase, the hemodynamic management is done based on the blood and the fluid loss and with the goal-directed fluid therapy, just like any other major abdominal surgery. In the HIPEC phase, we need to give a large amount of cold fluid to keep the temperature in check. So the cardiac output, cardiac index, and the stroke volume rise exponentially. That can lead to hyperdynamic circulation. And hyperthermia during the HIPEC phase can increase the lactates and also with sugar. So that high lactate and hyperglycemia will be there because of the hyperthermia. And because of the post-diuresis and the high urine output, patient may undergo into the hypokalemia. In the reconstruction phase, this hyperdynamic circulation may continue for at least 24 to 48 hours. So I told you about the H0 phase in the hypex. So this is the at the end of the CRS phase, around 30 minutes to 1 hour prior to surgery. So we do passive hypothermia up to 35 degrees centigrade by just switching off the warming devices and cool warmer. Remember, we are not doing active hypothermia; we are doing only passive hypothermia. We should be making OT ready for the hypex phase by arrangement of the cold fluid, body surface area calculation, and the protective clothing and the mask for all the OT staff. For the chemotherapy, so the chemotherapy depend on the disease and the carrier solution. We should be using either the peritoneal dialysis solution or isotonic saline or dextrocontagion solution. And its volume is around 7.5 to 3 liter depending on the site actor. For the hypex phase H1 to H3, so during this phase, the temperature of intraperitoneal chemotherapy is actually rise from 41 to 43 degrees centigrade. And if you see the temperature of the body, you will see that up to H1 phase, there will be rapid rise in temperature. H2 will be slow rise, and there will be plateau up to the H2 phase. We should be using the liberal fluid of the IV fluids to keep the kidney flushing, and we can also use the goal-directed fluid therapy as per the your hemodynamic goal. And to decrease or to keep the temperature in control, we should be giving the cold fluid mainly at 6 degrees centigrade, and also we can use the cold ice packs over the neck and the big veins, and also the cool air blankets. The goal is to keep the body temperature below 37.5 or 38 degrees centigrade. But if the temperature goes beyond 39 degrees centigrade, then we can ask the perfusionist to decrease the temperature of the perfusate. This is the circuit of the hypex. You can see the screen. You will see that the temperature on the screen. It is the roller coaster. This is the heat exchanger, and these are the inflow and the outflow catheter. About the use output goals, so in the CRS phase, we just keep like any other major abdominal surgery, around 0.5 ml per kg per hour goal is kept. And in the hypex phase, you can aim for a slightly higher use output, around 2 ml per kg per hour. And especially we are giving cisplatin during the hypex because cisplatin is more prone to cause the acute kidney injury in the post-op. So we can give diuretics if the output is not adequate. In the reconstruction phase, in the post-op phase, around 0.5 to 1 ml per kg per hour in output goal is maintained. The post-operative period, so these all monitoring can be continued, and if the patient is undergone the diaphragmatic stripping or diaphragmatic excision, and if the patient is having a pre-operative bad pulmonary system or like a severe cardiovascular comorbidity, patient undergone massive blood loss, or patient is not stable hemodynamically, or is on high vessel pressure support, then these patients should be ventilated electively. And we should be giving a good optimal analgesia into the post-operative period so that the patient have a better recovery into the post-op period. So also maintain a good urine output, so give DVT prophylaxis, and we should be maintaining the strict aseptic precautions just like any other surgery. So one thing we should keep in mind that patient in whom the diaphragm is stripped, and if the patient has undergone the total pyetonectomy, these patients may require higher post-operative fluids because these patients are prone to go into the hypovolemia, especially during the first 12 to 24 hours post-operatively, especially patients with a large pseudomaxima peritoni or malignant peritoneal mesothelioma. We should be doing the lab like CBC because chemotherapy, patient may go into the leukopenia or thrombocytopenia. Serum electrolytes are needed in the post-op period because these patients are prone for the hypokalemia because of the post-diuresis, and the coag parameter because patient may go into the coagulopathy because of the blood loss and the fluid loss. And also we should be doing the blood gas arterial lactors because the patient will be maybe having a high lactate at the end of the surgery just because of the hyperthermia or because of the hyperthermia and the decreased perfusion in the body. And just like any other surgery, we should also encourage the patient for the this chest physiotherapy in such spirometry. After extubation, we should start the feeding accident. About the complications, so about intra complications like any other major surgery, so like major blood loss and the hemodynamic instability. The post-op period, patient may have either surgical complication or this non-surgical complication or both complications. So the surgical complications mainly are either leak or proportional or abscess or infection. The non-surgical complications are apart from other complications which is common in the ICU. This patient may undergo into the acute kidney injury because especially if the patient has undergone cisplatin chemotherapy and also the hyperammonemia and the rebound hypothermia. These are the complications may be having related to the HIPEC. Rebound hypothermia especially happen in a patient with a large tumor in which the patient is having hypothermia during the CRS phase, and then we give the HIPEC phase, HIPEC at a high temperature, and then again patient become the hypothermic. In our hospital, we started this study on HIPEC in 2016, and we have done more than 150 patients, and you can see that our complications, the major complications rate are 21%. Major complications mean the patient with the Cleveland into surgical complications of grade 3 and grade 4. Our ICU stay were around 7 days. Our hospital stay was around 2 weeks. 6 patients means the 4% of the patient died within 1 month, and around 6%, 9 patients died within 3 months. If you see the hemodynamics, you can see that we were able to manage the temperature at reasonably good. To see the cardiac output and cardiac index, they said that the cardiac output and cardiac index increased during the HIPEC phase because of hyperdynamic suppression and remain high for at least 24 to 48 hours. The patient always go into some type of surge, and you see the bit high heart rate with the post-op. So my take-home message for this talk is that the peritoneal cancer is not a death sentence, and it is a high-risk surgery and a high-risk perioperative period. A proper preoperative evaluation and optimization is needed. We should be ready to manage the hemorrhagic shock, and a goal-directed fluid therapy and adequate hemodynamic and temperature monitoring is needed, and adequate renal output, especially during the HIPEC phase, should be ensured, and patients should be giving a proper post-operative. Thank you very much.
Hello.
Hello. Any question on this?
सोन आया निष्कर्ष, सो इधर कोई भी नहीं है, तो मैं ही अभी कोई क्वेश्चन चैट बॉक्स में नहीं है, so
okay.
So maybe next now I'll invite Dr. Josna to speak on one lung anesthesia making it worse. You're welcome, ma'am. Dr. Josna is a well-known figure in onco anesthesia, so will not waste time introducing her. Everybody knows her. So over to you, ma'am.
Thank you, Nishkars. Thank you. Good morning. I am Jyotsna Goswami from Kolkata. I will talk on one lung ventilation, make it work. At the outset, I'd like to thank the organizers for making me part of this great event. And this is my institution, Tata Medical Center, Kolkata. It is a dedicated cancer care center. It has got beautiful ambience with lot of greens, water bodies, and open spaces. I have nothing to disclose. So I'll talk on this outline today. So one lung ventilation can be used either for lung isolation to protect the normal lung from contamination, or for lung separation, which is mainly used for surgical exposure. So to make the one lung ventilation work, we should know what are the problems we may encounter in different phases of one lung ventilation. So to establish the one lung ventilation or OLV, we need to provide adequate lung isolation. During the maintenance phase, hypoxia is the main issue. And after return to two lung ventilation, acute lung injury is the main concern. So you should take care of these issues. So to provide adequate lung isolation, we need to choose the appropriate device which should be placed properly. And we have many choices now, like double lumen tube, bronchial blocker, single lumen tube. And among the double lumen tube, there are many designs and makes are available with us. Rubber shot tube, which has got both right-sided and left-sided. And you can see right-sided tube has got an extra opening for ventilation of the right upper lobe. Then we have univent tube with built-in bronchial blocker. We have Vivaside DLT, which has got a video camera inbuilt into it, which can be connected with the monitor. And recently we have another tube in our armamentarium, anchor double lumen tube. It has got an extra carinal cuff, which after inflation can prevent the entry of the double lumen tube on the wrong side. So once you select the tube, then you have to select the size. And size selection usually based on the sex or height. So in female patient, 35 French and 37 French are used usually. And in male patient, 39 French or 41 French are used. Size can also be selected on the CT finding, like tracheal width or left bronchial width. And then once tube size and type is selected, then it has to be placed into the bronchus. And for that, we need to know our tracheal bronchial tree thoroughly. We all know that right main bronchus has got three branches, one for right upper lobe, then one intermediate lobe, and one for lower lobe. Whereas left main bronchus is only two branches, one for upper lobe and lower lobe. So DLT can be placed either by direct laryngoscopy or it guided by fiber optic bronchoscope. So this is the intubation by direct laryngoscopy. We all know that how to put it. Then after placing the tube, it should be confirmed by auscultation. As it is a blind technique, there can be malposition, which should be confirmed by the auscultation technique. But even if you put the tube with direct laryngoscopy, the position should be checked by fiber optic bronchoscope. Also, bronchoscope can be used to insert the DLT. So for that, we need to know different views of the tracheal bronchial tree. So when the bronchoscope reaches in the trachea, you can see this tracheal view with the tracheal ring. Then as it passes near the carina, you can have this view, opening of the both right-sided and left-sided bronchus, main bronchus. Then as the scope passes to the left main bronchus, you can have this view, both the opening of the lower lobe and upper lobe bronchus. Then when the scope passes to the right main bronchus, this is the view. When the scope passes here, you can see the opening of the right upper lobe bronchus, intermediate and lower lobe bronchus. So this view is very important. And as the scope reaches in the desired position, then the tube should be threaded over it. And once the tube is in proper position, then it should be confirmed by the proper view. And it's a bronchial lumen is in the left main bronchus. So this is the left main bronchus view, both the upper and lower lobe entry. And then the scope is taken out and put through the through the tracheal domain. And then you can have the rhinal view, and you can see the bronchial lumen is going to the left main bronchus. So this is the optimal position of the right DLT, where you need to identify the opening of the right upper lobe bronchus. So this is the mal position. You can see the tube is too much inside. You can see the bronchial opening, and here it is not adequately in, because you can see most of the cuff is outside. So after DLT, we have another device with us, that is a bronchial blocker. Again, different designs and makes are available. This is the ARNT blocker. It has got the word loop at the tip, and through which the scope passes and it guides the blocker at the desired position. We have Cohen flexitive bronchial blocker that has got a proximal control wheel which can guide the blocker in the proper position. We have Fuji uni blocker. We have EZ blocker. EZ blocker, as the name implies, it is very easy to insert. It has got a bifurcated tip, and this part sits on the carina, and both the side goes to both the right and left bronchus. So whatever side you want to block, we can inflate that side of cuff. So it is quite easy to insert. But whatever designs they have, essentially they all have a long shaft and a narrow lumen through it and a cuff at the tip of the blocker. So they all have a different specification and advantages and disadvantages. But the ARNT blocker is available in different sizes, and it also can be used for the pediatric patient. See, this is the left side blockade. This is the right side blockade. Here it is, see, right-sided upper lobe entry is spared. So it is not adequate, we will not get adequate blockade of the right lung. So we need to pull out. And here now it is blocked adequately. So this is the proper position. So both the device has got many advantages and disadvantages. But there is no significant difference in the quality of lung isolation they provide. And both the device has got some advantages which can be useful in specific clinical scenario. Basically, the choice of the device depends on patient safety, surgical need, resources available, and anesthesiologist's preference. But DLT is mandatory during lung isolation and lung resection involving main bronchus. Whereas bronchial blocker is preferred when you anticipate difficult airway, when patient has got tracheostomy or already intubated, in case of children, when you need to give rapid sequence intubation, and when patient needs postoperative ventilation. So after establishing one-line ventilation, our main concern will be hypoxia, which is quite frequent, that occurs in 10 to 24% of cases. So during one-lung ventilation, we cut off the ventilation to the upper lung, but the blood flow continues, which does not take place in the gaseous exchange. So that becomes a shunt. Usually it is 27.5%. But if it is more, then it can cause a gross ventilation perfusion mismatch, causing impairment of oxygenation and hypoxia. Oxygenation can be impaired by other factors like operative lung, positioning, underlying lung disease. So operative lung is also important because we all know the right lung is bigger and bulkier. So if we ventilate the left lung and right lung is not ventilated, the shunt fraction and hypoxemia is more. Again, while lateral positioning, the right upper lung gets more ventilation, and less blood supply, blood flow, like it acts as a waste zone 1. So this drop in blood flow in non-ventilated lung preserves the shunt fraction. But there are a lot of disadvantages of lateral position. The bowel loops comes down, then diaphragm, dependent diaphragm goes up, so it gives up pressure on the ventilated lung. And then again, the mediastinal shift downwards can give pressure on the ventilated lung. And for positioning, we use support. So these bolsters, etc., can increase the compression on the lateral chest wall. So that also, all these factors can cause a compression and atelectasis of the ventilated lung. Additionally, during bad surgery, thoracic insufflation can also give the pressure on the ventilated lung. Then underlying lung disease can also contribute to the hypoxia. During two-lung ventilation in lateral position, if we get poor PaO2, that is an indicator of poor oxygenation during one-lung ventilation. Again, COPD, if it is mild or moderate, that can cause some amount of air trapping and autopip. So that can prevent atelectasis in both ventilated and as well as non-ventilated lung. But in case of severe COPD, it doesn't happen like this. So all these factors can cause hypoxia, but that can be counterbalanced by hypoxic pulmonary vasoconstriction. It is a physiologic response to hypoxia. So drop in PaO2 in alveolar partial pressure of oxygen can stimulate the vascular smooth muscle contraction. And that can divert the blood from the hypoxic part to the ventilated part. It usually occurs in 2 phases. The initial rapid onset within the first 30 minutes and then slower increase up to 2 hours. It can be affected by different factors. The predominant factor is alveolar partial pressure of oxygen, then PbO2, acidosis, alkalosis, temperature, airway pressure, low cardiac output, medications, all these things can affect HPV. Previously, it was thought that inhaled anesthetic agent have an effect on HPV, but recently it's seen that the newer agent like sevoflurane and desflurane, if used in 1 mg, they do not have any effect on HPV. So we should undertake a proper ventilator strategy. We should maintain the two-lung ventilation as long as possible. And preemptive alveolar recruitment maneuver is quite helpful to expand the lung and prevent hypoxia. So tidal volume should be maintained around 5 to 6 ml per kg, PEEP of 5. And recruitment maneuver during the well is also helpful to maintain target peak airway pressure below 35 and plateau pressure below 25. FiO2 should be titrated to maintain oxygen saturation 92 to 96%, and you should accept permissive hypercapnia. So it's seen that 2 major things we should take care of. Firstly, limiting the lung overdistension, and secondly, to maintain lung recruitment throughout the respiratory cycle. So in spite of all these measures, there can be severe hypoxia, and that can be predicted preoperatively in preoperative ventilation perfusion scan if there is high percentage of ventilation or perfusion in the operative lung. Then again, as I described before, during two-lung ventilation, poor PaO2, right-sided thoracotomy, restrictive lung disease, and supine position, all these things can predict hypoxia during one-lung ventilation. So how to manage? So this is a basic instinct of all of our anesthesiologists to increase the FiO2 to 100%. So if you find any drop in oxygenation. So we'll do the same thing here and then look for the cause. There can be mechanical failure or disconnection of the circuit, so confirm the circuit integrity. Then there can be blockage of the DLT secretion, so suck it out properly. Malposition of the DLT can be checked by FOB. Bronchospasm can be treated by bronchodilator. There can be ventilation perfusion mismatch, so minimum interference with HPV is needed. We should ensure optimal cardiac output. We also can use some sort of pharmacological manipulation of the pulmonary blood flow. Then for the ventilated lung, alveolar recruitment maneuver is very much helpful to maintain the lung expansion and prevent the hypoxia. So ARM can be given manually. It can be given by incremental PEEP up to 40 peak pressure for 10 consecutive breaths. And then recently it is described that alveolar decrement maneuver with incremental PEEP followed by PEEP decrement trial is very much helpful to maintain lung expansion. So how it has been given? It is done usually in pressure control mode with I/V ratio 1:1. And the difference between the peak pressure and PEEP should be maintained at 20 centimeter of mercury. Then, 20 centimeter water. And then we start increasing PEEP by 5 every minute up to peak pressure of 40 and PEEP of 20. Then once the peak pressure reaches 40, PEEP should be started decreasing and by 2 centimeter of water every 2 minutes till it reaches the maximum dynamic compliance. That is the individualized PEEP or optimal PEEP. Then you can apply CPAP around 5 centimeter of water to non-ventilated lung. We can also insufflate oxygen to the non-ventilated lung. We can provide high frequency ventilation, and we can also selectively apply oxygen using FOB to the operative lung away from the surgical site. If all these measures fails, then you can ask surgeons to clamp the pulmonary artery to reduce the blood flow to the operative lung. And lastly, we can resume the two-lung ventilation. So if two-lung ventilation is resumed, then it alleviates the transpulmonary shunt and oxygenation improves rapidly. But after return of two-lung ventilation, acute lung injury is the major concern. It is associated with high mortality and interstitial lung disease, excessive fluid administration, intraoperative transfusion. All these things can affect acute lung injury. So acute lung injury happens both in ventilated as well as non-ventilated lung. In ventilated lung, there can be high end expiratory volume and high tidal volume, which can cause volute trauma. Then there can be barotrauma due to prolonged high airway pressure. There can be atelectotrauma because the low tidal volume in the ventilated lung can cause atelectasis, and then repeated recruitment or de-recruitment, like tidal recruitment, can cause lung injury. So lung protective ventilation can take care of all these factors. Then if we use high FiO2 for prolonged period, it can cause release the reactive oxygen species and inflammatory markers, causing oxidative injury. So preventive measure is to use lowest FiO2 to maintain saturation of 92 to 96%. Then if fluid volume, if fluid infusion is not proper, if there's hypervolemia, that can cause lung edema and capillary hyperperfusion. So that can be controlled by minimizing fluid infusion. And then all these things can affect the injured lung alveolar mucosa and release inflammatory cytokines and cause biotrauma. So it's seen that it's described that protective ventilation with tidal volume even less, like 4 to 5 ml per kg with PEEP of 5 to 10 and routine lung recruitment can prevent lung injury. Then recently this RCT, they also, they have given more importance to the driving pressure, not on peak pressure. Driving pressure is plateau pressure minus PEEP, and it should be maintained below 15 meter mercury. And they concluded that driving pressure guided ventilation, along with application of the patient specific PEEP, can prevent lung injury. So in non-ventilated lung also can be affected because that non-ventilated lung is remain attracted for some time, and lung re-expansion can cause injury to the lung alveolar mucosa. Then surgical manipulation, direct lung lavage, they all can release inflammatory cytokines. So there can be damage to glycocalyx, ischemia reperfusion injury. They also release the cytokines and inflammatory markers, and there can be barotrauma. So it's advocated that stepwise increase in PEEP is better than manual recruitment. And also it's seen that the ventilated lung is more compliant. So if during lung re-expansion, the ventilated lung can be over-distended and there can be volute trauma. So to prevent that, it can be possible if we can exclude the ventilated lung from the respiratory cycle temporarily. That can be helpful to prevent barotrauma. But to some extent, biotrauma and inflammation is unavoidable. So to make WellView work, we need to choose appropriate device which should be placed properly to establish one lung ventilation. Then lung protective ventilation strategy is very much useful. Hypoxia is common, which should be anticipated, prevented, and corrected. And then acute lung injury is also common during OLV, but the risk can be minimized by using lung protective strategies, minimum fluid, and minimum oxygen. Thank you. Hello, Shagun, I think you can start.
Ma'am, my recorded presentation is already there. I think that can be
Okay.
started.
Yeah, yes, you can start now. I think that.
Should we continue? Good evening, everybody, and thank you for the invitation to present at this prestigious event. I'm Dr. Shagun from Rajiv Gandhi Cancer Institute and Research Center, and I think we should straight away get on with the presentation. My dear fellow anesthesiologists, a very good afternoon to all of you. I'm Dr. Shagun, a senior consultant at Rajiv Gandhi Cancer Institute, New Delhi. Today we shall discuss the anesthetic considerations for reconstructive microvascular surgeries. Now, what are free flaps? Free flaps are blocks of transferred tissue where the blood supply is re-established at the recipient site using microvascular techniques. Free flaps literally give wings to head and neck surgery. This slide depicts the reconstruction ladder. At the bottom rung, you have primary closure, followed by skin graft, locoregional flaps, distant pedicle rotation flaps, and finally at the top rung, you have the free flaps. The free flaps form the top of the pyramid. Now let's see what makes the free flaps different from other flaps. First, you have the local flaps, where the donor tissue is immediately adjacent to the defect. Here the vasculature is preserved, for instance, nasolabial flaps. Next, you have the regional flaps, where the donor tissue lies nearby but not immediately adjacent to the defect. Here too, the primary vasculature is preserved, as in case of a pectoralis major myocutaneous flap or a PMMC flap. Finally, you have free flaps, where the donor tissue lies remote and away from the defect, and here there is transfer and reanastomosis of the major vessels. For example, in case of a free fibular flap, and here the fibula is taken from the leg and remodeled and refashioned into a mandible. to replace the mandible which has been resected. Now, why have free flaps become so popular? That's because free flaps can be equated to freedom. They give us freedom to increase the size of the defect, allowing expansion of safety margins in oncosurgery, freedom to excise lesions not previously excisable, greater control of the lesion site in the short and long run, freedom to have two teams working simultaneously, one for excision and another team for reconstructive work, and finally, freedom for immediate reconstruction. If locoregional flaps are good, then free flaps are definitely the best because they give you enhanced results like better functional prognosis, better rate of vascularization and healing, decreased reabsorption rate, potential for sensory and motor innovation, and osseointegrated implants, increased variety of available tissues including composite tissues, and use of grafts designed for the defect, and better use of tissue harvested. There is a cafeteria choice of free flaps available to us today. Firstly, you have the muscular flaps, like the DAY-4 flap using the deep inferior epigastric artery, the latissimus dorsi flap using thoracodorsal artery, then faciocutaneous flaps like the radial forearm flap using the radial artery, the anterolateral thigh flap using the lateral circumflex femoral artery, osteocutaneous flaps like the free fibular flap using peroneal artery, the iliac crest flap using the deep circumflex artery, and finally visceral free flaps like the jejunal flap using the superior mesenteric branches and the omental flap using gastroepiploic artery. The major indication for free flaps remains head and neck reconstructive surgery. But recently, in peripheral limb tumors, limb salvage surgery, instead of prosthesis, free fibular flaps have been used successfully. For breast reconstructive surgery, DAY-4 flaps have been used. Similarly, free flaps have been successfully used in major trauma. There exist certain absolute contraindications for use of free flaps. For instance, sickle cell disease, also untreated polycythemia rubra vera, where there is increased flap failure rate due to microcirculatory sludging and hypercoagulability. A left ventricular ejection fraction of less than 40% is also an absolute contraindication. There exist relative contraindications like collagen vascular disease with active vasculitis, where there's increased risk of anastomosis thrombosis. You also have peripheral vascular disease patients where an MRI angiography ought to be done to test for patency of donor vessels in case of free fibular flaps for mandibular reconstruction. Finally, we come to the anesthetic considerations which constitute the heart of this presentation. The major elements of a pre-anesthetic checkup in these patients are patient counseling, rehabilitation, airway assessment, risk stratification, comorbidity treatment, optimization of physiology, cessation of smoking, alcohol withdrawal syndrome, and finally, nutritional assessment. Now, a difficult airway is very common in these patients. Airway assessment gives the diagnosis, whereas airway plan is the treatment. You should ask for a history of airway difficulties, any altered cardiorespiratory physiology. You should ask if there's any impact of surgery on the airway. Would a bag mask ventilation pose any difficulty? Would a supraglottic airway device placement pose any difficulty? Would the intubation be difficult? Would a surgical airway be difficult? Is there any risk of aspiration? And finally, how easy would it be to extubate this patient safely? We should look for predictors of difficult bag mask ventilation like age above 55 years, BMI more than 26, facial hair or beard, edentulous patients, and a history of snoring. More than 2 risk factors indicates difficult bag mask ventilation. On the right side, you can see a patient with a huge mask protruding from the mouth, and below it, you see an image of a patient undergoing stereotactic biopsy with an external fixator in situ, making masking really difficult. Next, we should look for predictors of difficult supraglottic airway device placement like reduced mouth opening, a glottic or subglottic airway obstruction not relieved by SAT, a distorted airway that prevents the SAT from seating properly, and a stiff neck or lungs which reduce lung compliance, and limited neck movement which makes a poor seal. We are all well versed with predictors of difficult intubation given by the mnemonic lemon. Look externally for facial trauma, large incisors, beard, mustache, or a large tongue, and Mallampati score 3 or 4, etc. I shall not delve into it deeper. Next, we look for Murphy and Wall's predictors of difficult surgical airway given by the mnemonic short, surgery on the neck, hematoma or infection, obesity, radiation, and tumor. On the right-hand side, you see a lady with a huge goiter, and below that, there's a lady with virtually no neck. So, these pose a difficult surgical airway. Cancer patients have their own set of radiotherapy woes. On the right side, you see a patient with a radiotherapy cast. Below it, there is a lady with osteoradiodecrosis of the mandible. You see limited net extension, temporomandibular joint ankylosis, severe radiation burns of the neck, ultimately leading to fibrosis and limited extension, hypothyroidism, baroreceptor damage, carotid artery stenosis, and poor wound healing. And now this is what radiation does to your teeth. Other pitfalls include laryngeal stenosis, risk of aspiration, and impaired swallowing seen in patients with a history of laryngeal surgery, 9, 10, 12 cranial nerve damage, impaired swallowing, aspiration risk, and vocal cord palsy seen in patients with a history of neck dissection. You may have trismus, fixed immobile tongue, and a reduced mandibular space in patients with a history of tongue or floor of mouth surgery. And finally, difficult mask seal, difficult nasal access, and temporalis contracture along with TMJ pseudoankylosis may be seen in patients with a history of maxillectomy and craniofacial resection. Besides baseline investigations like CBC, coagulation profile, biochemical profile, ECG, and chest X-ray, we go in for additional investigations based on risk factors and symptoms at presentation, like a PFT in COPD patients. Most of these patients are smokers, so COPD is common. Then we shall do an ABG if the SpO2 is reduced on room air. Then echocardiography ought to be done in patients who've undergone chemotherapy, especially with adriamycin, and coronary artery disease patients. A thyroid profile is a must in post-radiotherapy patients, and a new indication for thyroid profile is post-COVID patients. Choosing the site of vascular access is important in these patients. In case of patients with a radial artery free flap, we avoid the left upper limb for IV line, arterial, and CVP line. That's because the right hand is dominant in most patients. In case of anterolateral thigh flaps, we avoid the left lower limb for IV as well as arterial lines. That's for logistic reasons, because the trolley is placed on the right side and it's easier for a right-handed surgeon. In case of free fibular flaps, we avoid the lower limb ipsilateral to the site of surgery because free fibular flaps are performed in ipsilateral side because better results due to more favorable position of perforators occur if ipsilateral side is used for harvesting of free fibular flaps. According to a head of print version of the expert consensus statement for Society of Head and Neck Anesthesia, awake airway management techniques ensuring spontaneous ventilation should be used. Vasopressors should be used only after correcting other factors causing hypotension like hypovolemia, deep anesthesia, anemia, and electrolyte imbalance. Historically, we avoid vasopressors as a principle of care because preferential vasoconstriction of free tissue offsets the benefits of increased mean arterial pressure. Goal-directed fluid therapy is important because fluid overload can result in an increased risk of free flap failure. Free tissue is especially sensitive to negative effects of edema as well as venous engorgement. A hematocrit more than 25 should be preserved to optimize oxygen delivery to free tissue transfer during the reconstruction. Multimodal pain management is employed. Thrive or transnasal high flow rapid insufflation ventilatory exchange helps in maintaining oxygen saturation by prolonging apneic window in attempts to secure the airway. It has 3 elements: apneic oxygenation, continuous positive airway pressure, and flow dependent dead space flushing. Besides standard ASA monitors like NIBP, pulse oximetry, capnograph, and ECG, core temperature monitor, Foley's catheter to monitor the urine output, an arterial line for cardiac output, stroke volume variation, and serial ABG, a CVP line for hemodynamic status and instilling drugs like vasopressors and potassium chloride if required, a peripheral nerve stimulator, and spirometry loops also help. Since tourniquets are often employed during harvesting of free flaps, it's important to be well versed with the tourniquet physiology. During inflation of tourniquets, the systemic vascular resistance, BP, heart rate, and CVP all increase. The temperature falls in the non-perfused limb, and there's accumulation of anaerobic metabolites like lactate. After deflation of the tourniquet, the systemic vascular resistance, BP, heart rate, and CVP fall. The core temperature falls. There's reactive hyperreperfusion, mixed acidosis, reduced PO2 and pH. There is an increase in PCO2, increased potassium ions, as well as free radicals. Standard anesthetic agents may be used for induction, maintenance, and reversal of anesthesia. GA with either total intravenous anesthesia or inhalational anesthesia may be given. Advantages of TIVA with propofol include a reduced postoperative nausea vomiting, reduced stress-induced vasoconstriction, immunoprotection, anti-inflammatory effect, and an antioxidative effect which protects the flap tissues against reactive oxygen species generated during ischemia and reperfusion. Peripheral nerve blocks are also beneficial in providing both analgesia and a sympathetic block which allows vasodilatation to increase the flap perfusion. Our anesthetic aim should be to maximize flap perfusion, keeping in mind the oxygen flux equation and the Hagel-Poiseuille equation, keeping a full hyperdynamic circulation, increased cardiac output, peripheral vasodilatation, a hematocrit between 25 to 35%, as well as normothermia. To enhance flap survival, we must reduce reperfusion injury by minimizing the ischemic time and possibly with TIVA. Optimize blood viscosity, keeping hematocrit around 30%, and use normovolumic hemodilution. Improve tissue oxygenation, keeping HP above 7 g/%. Maintain flap perfusion pressure, maintaining MAP of more than 60 millimeters of mercury, and prevent vascular narrowing. Aims of CICU care include normotension, normothermia, and regular flap monitoring. Staff should be suitably trained in tracheostomy care, post-operative nausea vomiting prophylaxis with antiemetics, liberal fluid regime, and establishing early oral intake, IV steroids to reduce edema, low molecular weight heparin for thromboprophylaxis, hematocrit between 30 to 35. Dextran and aspirin are no longer given due to lack of proof of efficacy. Early nutritional support is aimed at. Poor pain control results in sympathetic activation, vasospasm, impaired mobilization, and chronic pain. Hence, post-op pain relief is important. These surgeries produce moderate pain, elevated by IV PCM and opioids. Patient-controlled analgesia morphine for extensive resection may be used. Local anesthetic infusions using wound catheters to reduce opioid requirements. Ketamine, dexmedetomidine, gabapentin, parenteral PCM, and NSAIDs may be used. COX-2 inhibitors reduce GI bleeding, but at the cost of increased risk of thrombosis. Post-op respiratory distress may pose unique challenges like edema, intraoral flap, blood or secretions in the airway. Temporizing measures include head elevation, nebulized epinephrine, and high-flow nasal oxygen. Careful nasal endoscopy should be done for feasibility of FOB intubation. The primary plan for intubation may fail, and hence personnel or equipment for emergency surgical airway should be available. A vortex approach should be followed. The Enhanced Recovery After Surgery protocol promises the moon. The ERAS protocol for head neck surgery is a step forward. It needs to be better understood, requires a multidisciplinary approach and commitment of all team members. Here I discuss a 15-element ERAS protocol based on ERAS Society recommendations on head and neck surgery and 2 retrospective studies conducted at MD Anderson Houston and Rush University Medical Center, Chicago, respectively. ERAS protocol gives promising expected outcomes like reduced length of hospital stay and CICU stay, reduced time to return to intended oncological therapy, reduced pre-incisional, post-resection and post-op lactate levels, reduced wound or flap-related complications, reduced CRP and creatinine levels, reduced morphine consumption, reduced post-op nausea, vomiting and constipation, and a reduced rate of readmissions. Further prospective studies are required to see if all this is overhyped. Preoperative patient counseling should include information about extent of surgery, requirement of tracheostomy or a gastrostomy, post-op retention of endotracheal tube, speech therapy consultation, and requirement of awake fiber optic bronchoscopy with blocks if required. The next ERAS element is a preoperative carbohydrate drink with benefits like curbing nausea and anxiety, attenuation of loss of lean body mass, reduced post-op insulin resistance and hypoglycemia, reduced protein and muscle loss, and improved patient comfort. Carbo load contains maltodextrin 47.5 grams and minerals like zinc, selenium, sodium, and potassium. On the evening prior to surgery, 2 sachets are given, and 2 hours before surgery at 6 a.m., another sachet dissolved in 400 ml of water may be given. Oral clear liquids from 9 a.m. to 12 midnight, 1 day prior to surgery, may be given. Plasma light for IV maintenance fluid throughout the night. Pharmacological thromboprophylaxis includes intraoperative heparin 2,500 units, and on post-op day 0 to 5, enoxaparin 40 units subcutaneous, and on post-op day 4, aspirin 75 mg per day. Antibiotic test dose should be given before shifting the patient to the OT. 2 vials of antibiotic like cefuroxime 1.5 grams should accompany the patient. First vial to be given before incision and the second one 6 hours into surgery. Post-op prophylactic broad-spectrum antibiotic should continue for 7 days. Pre-op steroids like IV dexamethasone 8 mg just before induction. The more patent nostril should be selected using digital examination, available MRI film and ultrasound nose, size 7 flexometallic nasotracheal tube fixed with Dynaplast and Meroseal, avoiding pressure on the ala and nasal septum, avoidance of tracheostomy and post-op ventilatory support whenever possible, intraoperative goal-directed fluid therapy using an SVV or PVI of 10, normothermia since hypothermia causes coagulopathy, increased FiO2 to increase oxygen delivery to the flap, and antiemetics. We should get the fluid balance right and in the optimal range using goal-directed fluid therapy. Since hypovolemia causes hypoperfusion, sepsis, organ dysfunction, and an adverse outcome, whereas hypervolemia also causes edema, post-op nausea, vomiting, pulmonary complications, organ dysfunction, flap failure, and an adverse outcome. Keeping in mind the ongoing opioid addiction epidemic, distressing side effects like post-op nausea, vomiting, and constipation, and also immunosuppression and cancer progression attributable to opioids, opioid-sparing multimodal analgesia should be used. Preemptive pre-incisional paracetamol and ketamine, intraoperative dexmedetomidine, incisional lignocaine infiltration, pre-reversal PCM and ketamine, post-op dexmedetomidine, and post-op morphine only SOS for breakthrough pain, and intra-op morphine and fentanyl in half doses should be used. Nasogastric tube feed should be initiated whenever the patient feels hungry post-extubation on post-op day 1. Continuous feed at the rate of 10 to 15 ml per hour for first 24 hours, increase to patient's goal rate determined by the dietitian, and then transition to bolus RT feeds. Return to oral intake as outpatients. Frequent flap monitoring by nurse and surgery resident doctor every 6 hours on first day, every 8 hours for second day, and every 12 hours for third post-op day, every 24 hours thereafter till discharge. Flap perfusion should be monitored using infrared thermographic imaging, indigo cyanine, green fluorescence imaging, Doppler imaging, pinprick, and flap sugar. Early mobilization should be done for ALT flaps on first post-op day and on fourth post-op day for free fibula flaps. On post-op day 2nd and 3rd, remove all drains with less than 10 ml discharge in last 24 hours. On post-op day 4, make the patient walk for 30 meters 3 times a day, increasing to 30 meters 6 times a day on day 7. To summarize the ERAS protocol, the preoperative period involves optimization of the patient, the intraoperative period involves stress minimization, and the post-op period involves protocolized normalization. Thank you for the patient listening. Any questions?
Hello. Thank you, Dr. Shogun ma'am, for such an informative lecture. I am
You're
Dr.
welcome.
Komal Shah, Associate Professor, chairing this session. I would like to ask the audience to have any questions. Okay. Any comments? Okay, thank you, ma'am, for such a informative lecture. So I will
My pleasure.
proceed with, yeah. So I will continue with the next lecture, Dr. Nishkarsh Gupta. For anesthesia for robot and video assisted oncosurgeries.
Ask them to ask madam to.
Hasta video.
Hello.
How many cases you
Please
did in this
change to
field
next
study?
Dr. Nishkarsh Gupta.
How many cases were studied?
Yes, for the lecture anesthesia for Robert and video assisted
In
oncosurgeries.
how many groups?
Good morning, everyone. I thank the organizers for giving me this opportunity to speak on anesthesia for robot and video-assisted oncosurgeries. This is my center. This is our Institute Rotary Cancer Hospital, part of AIIMS Delhi, and we have come up with a big National Cancer Institute Jhajjar with state-of-art facilities. Well, to start with a bit of history, so word robot was first used in a play as early as 1921. It was first actually developed by NASA for use in space exploration. In modern medicine, first surgical robotic device for stereotactic brain surgery was used in 1980. The first man-made master-slave manipulator for medical use was developed in 1991. Thereafter, it progressed and we had robotic laparoscopic camera in 1992. In year 2000, first FDA-approved Da Vinci surgical system was approved for clinical use, initially designed for use for military or for immediate operative care on the battlefield. Thereafter, we had Zeus robotic system approved by FDA in 2001. Coming from Indian data, so this is data from Indian Journal of Urology. So we had about 71 systems which were installed in 66 centers. We had about 500 trained surgeons doing robotic surgeries, and about 13,000 surgeries were performed robotically in the last 12 years. So the amount of surgeries are increasing over a period. In a recent article in JAMA Network Open, it was shown that robotic surgery has continued to diffuse across surgical specialties. Initially, it was mainly for prostatectomies. Now, complex cancer surgeries, reflux surgeries, colectomies have been done using robotic surgeries. And the hospitals which have launched robotic surgery had a broad and immediate increase in the use of robotic surgery, which is associated with subsequent decrease in open and laparoscopic surgeries. So gradually over a period, we are seeing that robotic surgeries are being increased, and over 20% of surgical procedures are basically done robotically. Benefits of laparoscopic surgery, all of us know. So it reduces the tissue trauma, it is minimally invasive, leads to reduced post-operative pain, reduces wound complications. Overall, there is an improved cosmesis, leading to faster recovery and shorter hospital stays. So if we have so much benefits of laparoscopic surgery, why do we actually need a robotic surgery? So robotic surgery, unlike laparoscopic surgery, is less dependent on the assistant. The camera is stable and directly controlled platform is there. It provides a three-dimensional view with adjustable magnification. There are 7 degrees of freedom duplicating hand movements with high accuracy. So that is the most important thing in a robotic surgery. Then it is possible to reach difficult to reach areas. The manipulation of instruments is easier, and there is possible to do a remote site surgery, which is a USP of robotic surgery. And overall, there is a shorter learning curve and easy to do surgeries even in a morbidly obese patients. Technically, there is elimination of motion reversal. The surgeon controls the tip rather than the handle, which would require movement in the reverse direction. The console will provide a 3D image of the surgical field. There is a stereoscopic vision with a depth perception, and which is very immersive, and surgeon feels he is actually doing a kind of an open surgery. And there is an endo-wrist instrument which mimics the natural kinematics of a surgeon's hand and the wrist. It allows 7 degrees of freedom, and it filters the tremors and allows motion scaling if needed. Well, this 7 degrees of freedom I was talking about include arm movement up and down in a vertical plane, side to side horizontal plane movement, forward extension to reach the object and retract backwards, rotation around the central axis, wrist extension and flexion, lateral movement to the ulnar and radial side, and opening and closing of the instrument for grasping. So this is really important and makes the difference between a robotic and a laparoscopic surgery. Now coming to the robotic systems, so we have a number of robotic systems, the most commonly used being Da Vinci. Recently, with the spirit of Atmanirbhar Bharat, we have our indigenously developed robotic system which is being used in some of the centers, and I'm sure in times to come, everything robotic system which are used will be made in India. Then coming to the parts of the robot, so we have this the endowrist instrument which I was talking about. These are the 7 degrees of freedom of robotic equipment, and this is the main console which is basically integrating the images and showing the 3D stereoscopic vision. So we have a surgical console where the chief surgeon will sit. We have a patient cart, which is the actual robot which will be docked onto the patient, and we have a vision cart which is actually integrating the images, and it is actually showing the 3D stereoscopic views of the parts to operate it. Broadly, we have a surgeon which is sitting at the control, and we have a skilled assistant at the table side which will place the trocars, connect them with the robotic arms, change the robotic instruments, and manipulates additional endoscopic instruments. So it is important that there are special restrictions due to bulky equipment, so we can see the patient is hardly approachable. So whatever the tubes, lines, monitors, and protective devices are there, they need to be secured, and we have to ensure that there is no kinking or displacement during the surgery. Positioning may alter the tube placement, so we have unintended extubations, endobronchial intubations, dislodgements, and circuit disconnections, and we need to be aware and we have to manage them if needed. Then general anesthetic concerns include, so once the robot is docked, it may not be possible for us to allow changes in patient position or any kind of access to the patient during the surgery, because any kind of movement might lead to tearing or puncturing of organs and vasculature. And if there is a delay in managing, you may have critical complications. So early detection of any problem is the key. And we need to train the surgical team to fast dedocking or detachment of the robotic system if there is an untoward emergency. Like a laparoscopic surgery, robotic surgery will need a pneumoperitoneum. There is a procedure which is a little longer, about 2 to 3 hours at least. Patient might develop hypothermia, and they might be an occult blood loss. So, and as anesthesiologists, we need to be aware of the problems associated with pneumoperitoneum, the duration of procedure, and associated problems which might occur because of the surgery itself. Pneumoperitoneum leads to decrease in pulmonary compliance by 30 to 50%. There can be decrease in FRC. The peak airway pressures and intrathoracic pressure is increased. So there can be an hypercarbia because of this, which leads to tachycardia and hypertension. Then maintenance of normocarbia and acid-base status challenge in patients with poor preoperative respiratory status is a challenge, and one needs to manage these while performing a robotic surgery. Well, complications like subcutaneous emphysema, pneumomediastinum, gas embolism, and pneumothorax might occur, and one need to be aware of these problems and need to manage them if they occur. The ideal ventilation strategies include a tidal volume of 6 to 8 ml per kg with a PEEP of 4 to 7 to prevent atelectasis. Maximum airway pressure of 35 should be targeted. Then IE ratio of 2:1 or 1:1 provided better oxygenation and lower PaCO2 and should be used instead of conventional 1:2 ratio. And epidural anesthesia along with the lower peak pressures overall enhance the dynamic compliance of the patient. We have some cardiovascular effects also. So there is an increase in SVR, mean arterial pressure, and filling pressures. There is a 50% reduction in the cardiac index, and cardiac index will gradually increase and SVR decrease 10 minutes after CO2 insufflation. So this increased mean arterial pressure and SVR, increase in oxygen demand, overall makes tricky anesthesia in patients with reduced cardiac reserve, and we need to be cautious and we need to manage them accordingly depending on the patient's cardiac status. The anesthetic technique is standardized basically, so you can use a combination of drugs as per the need. Standard monitors need to be applied. The specific monitors like BIS monitor and intra-arterial blood pressure should be applied for frequent ABG monitoring if needed, and preferably have 2 IV lines with long extension for delivering the drug during the procedure. Important thing is the positioning. So the extremes of positioning, trend-lying blank may be 30 degree or more. So to allow the gravity which allows for movement of obstructing organs from the surgical field, so it gives a better view. The patient's arms are usually tucked to the side. However, there is possibility of a sliding off, and so we need shoulder braces, which itself may lead to brachial plexus injury. So extreme positioning is important factor in a robotic surgery, which anesthetists must know. Because extreme positioning may lead to endobronchial intubation. If you put a chest band to prevent sliding off, the lung compliance is decreased. And overall, ensure that dead space ventilation and venous admixture are typically small so that optimal surgical exposure is there. A number of surgeries are being done robotically, including prostatectomy, gynecological surgeries, thymectomy, thyroidectomies, cholecystectomies, and transoral robotic surgeries. Robotics laparoscopic prostatectomy is the most commonly done surgery. Basically, it leads to blood loss of about 150 to 200 ml with about 3 hours surgery. Overall, the benefits I have already discussed. Important thing is control of cancer is comparable to open surgery. So most of the surgeries data has still not suggested that the overall outcomes are much better with robotic surgery, except that there is an improved overall recovery, reduced hospital stay, and reduced blood loss. Then we have robotic GI surgeries like gastrectomy, fundoplication, and rectal resections, and gastric bypass for malignancies. Then we have robotic transoral surgeries. So we have a patient which is 180-degree turned away from the anesthesia workstation. So constant vigilance to the patient may not be there. We need to secure the eyes with protective goggles. We need to protect the teeth to avoid any damage using a dental guard, and we need to sometimes suture the endotracheal tube so that by the surgeon so that it is not dislodged during the positioning and doing the surgery. Then we have robotic thoracic surgeries. We have esophageal cancers being operated. We have lobectomies being done, mediastinal masses being done. And like any thoracic surgery, you need a one lung ventilation. The patient has to be lateral with variations of reverse Trendelenburg or Trendelenburg position. Mediastinal surgeries will require lateral position with lateral table tilt. And we need to ensure that complete immobility is there, because if there is any movement, there can be puncturing or tearing of the intrathoracic organs, which we do not need. And there can be complications like occult blood loss, tension pneumothorax. There can be hemodynamic instability, and we need to immediately discontinue CO2 insufflation in case of a tension pneumothorax. So these complications we must be aware and need to manage if these occur. Then esophagectomies have been done using robot. So we have basically we need to position the patient with 45-degree tilt towards the prone position. The thorax should be the highest point initially for maximal robotic range and maneuverability. So this may lead to compression of the cardiac or major vascular structures, which may lead to hemodynamic instability and ECG changes. The important thing is we should avoid direct contact. So there is a constant vigilance to the robotic arms so that there is no pressure injury or crush injury. We need to monitor the camera and light source to avoid thermal injury, and we have to be innovative with respect to positioning so that overall arrangement is very acceptable and it doesn't cause any hindrance to the anesthetic management. There can be nerve injuries, so you have position injuries which may occur in 66% of patients, commonly brachial plexus and ulnar nerve injuries, and we need to ensure that degree of limb extension is acceptable, the padding is there, and what is the duration of immobility which need to be decided. The robotic surgery may lead to increase in IOP, and it may lead to ischemic optic neuropathy and corneal abrasion in up to 3% of cases. So we need to tape the eyes closed using transparent occlusive dressing to avoid these complications. Then there is a possibility of airway edema, stridor, and failed extubation. One must do an airway cuff leak prior to extubation. Patients who do not meet strict extubation criteria should remain intubated, and resection of intraoperative fluid to 1 to 2 liters should be done. Well, massive hemorrhage or cardiac arrest might require emergency dedocking, so we must communicate clearly. There should be clear role delegation and clear trigger words that emergency undock should be clearly there so that everybody in the theater knows about this and does the emergency dedocking if needed. So, take-home message is that equipment is extremely bulky in a robotic surgery and requires a considerable space. This large size of robot itself may lead to collisions with its own arms, assistant, or patients, and one must be aware. One must ensure that patient is completely immobile to avoid any complications because of robotic movement. it is difficult for anesthesiologists to quickly assess the patient during an operation. So as we have seen that there is a lot of bulky nature of the equipment, anesthesiologists may actually be away from the patient's surgical field site, and one is to be really aware of what are the things which are happening, constantly vigilant on the monitor, and if any complication occurs, one has to be quick to respond. It is impossible to reposition the patient once the robot has been stationed. So whatever things like IV lines, tubes, and important catheters which we need to position have to be really tucked in properly before the patient is positioned for the surgery. The technology of robotic improved surgical precision. It has led to better visualization and more ergonomic instrumental control. However, as anesthesiologist, it is onus on us to provide optimal patient position and know the physiological effects. We need RCTs to assess the clinically meaningful long-term outcomes like quality of life and patient satisfaction following robotic surgery to further validate that they are good for patients. For any questions, you can email me or text me or WhatsApp on my mobile number. And if there are some questions, I can take it right now. Thank you very much for patient listening, and I thank the organizers again for giving me this opportunity to share my experience.
Okay, thank you, Dr. Nishkarsh Gupta, for such an informative and a good topic. And you have almost covered everything, but I have one question. Hello?
Hello, Hanji ma'am.
Yeah, is I am audible?
You are audible.
Yes. Just a question. You told about extreme position, ma'am. Extreme position, sir. Right?
Yes.
So, up to what angle you would allow?
Actually, ma'am, there is no definite angle through which we may allow. Only thing is we have to customize to the, because surgical needs will vary. So in prostatectomy, roughly about 30 to 45 degrees is maximum, which is feasible from anesthesia side point of view. And in that position, you will have to see what are the hemodynamic perturbations, and you have to be very, very sure that patient does not slide, because initially that is a problem many a times that with gravity patient tends to slide off and you may end up in a complication. So we have to be really, really, really careful when you do that.
Okay, yes, that because I have seen that patient like during robotic surgery, but they give surgeon always want extreme position, and being anesthetist, we have to be careful on that part. Like everything, patient should not slide down and hemodynamically everything. So there is according to comfortability, right?
Definitely, and as anesthetists, it is our duty that we cannot go beyond this point. No, we have to stress that enough is enough, and you have to somehow manage otherwise. Because वो तो चाहेंगे मैम पेशेंट को पूरा उल्टा लटका दो, पर वो कई बारी हमारे लिए मुश्किल हो जाता है ना मरीज के साथ।
No, yes sir, I have seen. Okay, thank you very much, sir. It was nice topic. Yeah, thank you very much, sir. Okay. Now I would ask Dr. Jason, doctor. Hello, next is Dr. Jason. Doctor, he will be speaking on influence of chemotherapy and radiotherapy on anesthesia. So I am inviting Dr. Jason, doctor, for the next session. Yes, okay.
Rohit, you have my presentation, right?
Hello.
Yeah, madam, I'm here.
Yes.
Yeah,
okay. Yes. Welcome, sir. Yes.
Thank you. Morning, everyone. I'll be talking about the anesthesia for patients on chemotherapy and radiotherapy. The overview of my talk, I'll be dividing my talk into two parts, that is options available for cancer treatment, which includes chemotherapy and radiotherapy in predominantly pertaining to my talk. The other aspects being surgery and immunotherapy, which I will just cover in brief. And the second part of my talk will be anesthetic implications of chemotherapy and radiotherapy on various organ systems. Coming to the first part of my talk, cancer burden is increasing across the globe and is expected to rise further. It is estimated that by about 2030, we will need about 45 million cancer surgeries annually. It is vital for anesthesiologists to have insights into the basics of chemotherapy and radiotherapy and their perioperative implications and management. So this is the cell cycle, which includes the mitotic phase, the G1, S, and G2 phase. Okay, so chemotherapeutic agents can act at any of these phases of the cell cycle, and they are known as cell cycle specific chemotherapeutic agents. The other agents that are described as cell cycle non-specific agents, and their classification pertains to the place where they act in the cell cycle. Now, how does chemotherapy act? When you have healthy cells, they are well differentiated with uniform growth, but cancerous cells have uncontrolled cell division and damaged cells. When the chemotherapeutic drug is administered, it acts on these damaged cancerous cells and causing them to die, and the healthy cells remain. This is how chemotherapeutic agents act. Chemotherapy is usually given in combination because it has a synergistic action from two different drug classes. The different mechanisms of action lead to synergistic effects and will lead to better neoplastic cell kill. It is administered in cycles, usually every 2 to 3 weeks over a 3 to 6 month period, but could be longer. This period of recovery between two cycles helps in repair of normal tissues and resolution of toxic effects, side effects. The use of multi-dosing regimens helps in improving the cancer cell death because all the cells need not necessarily be in the same susceptible part of the cell cycle. There are three different timelines during which chemotherapy is administered, called as neoadjuvant, adjuvant, and palliative chemo. Neoadjuvant chemotherapy is usually given before surgical intervention. It helps in completing the tumor resection and making unresectable tumors resectable, and decreases the morbidity of surgical intervention. Adjuvant chemotherapy is given after the surgical intervention, and it helps at targeting micrometastasis, preventing cancer recurrence. Palliative chemotherapy is aimed at improving the quality of life and possible survival. It does not assure any curability of cancer. Coming to the second modality, chemotherapeutic agents are classified into different varieties of chemotherapeutic agents and classification. You need not memorize all of these drugs. Coming to the second modality, that is radiation therapy, which can be divided into three different types of radiation therapy: external beam radiation, brachytherapy, and stereotactic radiotherapy. External beam radiotherapy is given from outside the patient. Depending on the source, it can be either a cobalt unit where the radioactive substance is a cobalt, linear accelerators of protons where the charged particles like electrons or protons are used for the radiation. Brachytherapy has catheters which deliver the dose close to the tumor area and the surrounding normal tissue is spared. It is mostly used in cancers of prostate, cervix, vagina, and breast. Stereotactic radiotherapy includes administration of full dose of radiation in a limited number of fractions and by using high resolution imaging to delineate the tumor and its surroundings. Coming to the second part of my talk, anesthetic implications of chemotherapy and radiotherapy on various organ systems. Coming to the first system, that is the cardiovascular system. The prototype of drugs that cause damage to the cardiotoxic effects of the cardiovascular system are the anthracyclines, which are antibiotics isolated from streptomyces and includes daunorubicin, doxorubicin, epirubicin, idarubicin. They are used in a multitude of cancers like acute ALL, granulocyte leukemia, and metastatic adenocarcinomas of the thyroid, bladder, lung, etc. The side effect profile causes in acute conditions may cause conduction problems, myocarditis, pericarditis, and chronically it may cause dilated cardiomyopathy and congestive heart failure. The predisposing factors for anthracycline-induced cardiotoxicity are extremes of age, that is more than 65 years or less than 4 years, female gender, pre-existing cardiovascular disorders with ejection fraction less than 50%, comorbidities like hypertension, smoking, obesity, diabetes, hyperlipidemia, electrolyte disturbances, high cumulative dose of anthracycline exposure, concomitant radiation therapy involving the chest, and use of adjuvant medications, chemotherapeutic medications like trastuzumab. Mechanism of anthracycline toxicity: it causes toxic oxygen free radicals and oxidative stress, causing vacuolization and replacement of myocytes by fibrous tissue. Two different types of cardiotoxicity like type 1 and type 2 are described. Type 1 causes permanent damage and accumulation of vacuoles and replacement of the myocytes by fibrous tissue. It causes cell death. It is irreversible. Whereas type 2 cardiotoxicity causes cellular dysfunction. It does not cause replacement by fibrosis. It is not dose related, and it can cause improvement after discontinuation and cessation of the drug. These are the various drugs that can cause cardiotoxicity. Anthracyclines like doxorubicin, daunorubicin, epirubicin can cause heart failure, decrease in the ejection fraction, cardiomyopathy. Cyclophosphamide can cause pericarditis, QT prolongation, pericardial effusion. Taxanes can cause heart blocks like Mobitz type 1 and type 2 heart blocks. Vincristine can cause acute vascular events like myocardial infarction. Trastuzumab can also cause left ventricular failure, angina, stroke, and deep vein thrombosis. Tyrosine kinase inhibitors like imatinib, etc., can cause QT prolongation. And estrogen receptor modulators like tamoxifen can also cause QT prolongation, thromboembolic events, and DVT and pulmonary embolism. Coming to the preoperative assessment of patients who have received cardiotoxic chemotherapy, it is better to have patient-reported effort tolerance and estimation of maximum metabolic equivalents, 12-lead ECGs, an echo which tells you about the contractility, ejection fraction, and pericardial collection. A stress test, Dobute stress echo may also be helpful. Cardiopulmonary exercise testing and evaluation of biomarkers can be helpful in assessing the risk assessment. Risk assessment can be done using revised cardiac risk assessment, and optimization of cardiac function can be done by use of beta blockers, ACE inhibitors, and coronary interventions. This is the way to manage patients who have received chemotherapy, which is cardiotoxic. If the patient comes up for emergency surgery and the surgery needs to be done, it is better to proceed with the anesthetic. However, you have to keep a high index of suspicion for heart failures, arrhythmias, and shift to intensive care unit. If the patient is for elective surgery and has pre-existing history of heart failure, it is better to give medications like beta blockers and ACE inhibitors to improve the ejection fraction, and use invasive hemodynamic monitoring, avoid cardiac depressants, maintain normothermia and analgesia, and shift to the intensive care unit postoperatively. In patients who have systolic dysfunction, invasive monitoring is usually recommended. And in patients with QT prolongation, it is preferable to correct electrolyte disturbances and give medications which are safe and avoid any further QT prolongation. Again, coming to radiotherapy and its effects on the cardiovascular system, radiotherapy can cause a multitude of effects like pericarditis, cardiomyopathy, conduction blockade, restrictive cardiomyopathy, heart failure, coronary artery disease, and valvular heart disease. Coming to the second system, which is the respiratory system, it can also cause a variety of manifestations like hypersensitivity and interstitial pneumonitis, BOOP, effusions, chest pain syndromes, veno-occlusive disease, and in chronically it can cause pulmonary fibrosis. The prototype of pulmonary manifestations is bleomycin, the risk factors being age more than 60 years, cumulative dose exceeding 150 international units per meter square, and the total dose exceeding 360 international units, baseline deranged renal function, which can increase the toxic effects of bleomycin, severity of the malignancy, concomitant use of high FiO2 medication, radiation therapy, and other drugs, and smoking. These are the various drugs that are known to cause respiratory complications. Bleomycin causes a deterioration in PFT and DLCO and causes hypersensitivity, pneumonitis, diffuse alveolar damage, and fibrosis. Methotrexate can also cause hypersensitivity, pneumonitis, effusion, pleuritis, etc. Docetaxel and paclitaxel can cause interstitial pneumonitis. Cyclophosphamide can cause lung fibrosis, and mitomycin can cause interstitial pneumonitis and thrombotic microangiopathy and acute respiratory failure. It can also cause acute bronchospasm. Preoperative assessment and optimization. A quick surrogate pulmonary function test is like breath holding time. If it exceeds 25 seconds, it is a good indication and to identify patients at risk. Apart from that, baseline pulmonary function tests, DLCOs, FEV1, FVC, and peak expiratory flow rate, cardiopulmonary exercise testing, X-ray chest, and HRCT are also beneficial. Optimization of respiratory function by using steam inhalation, respiratory muscle training, deep breathing exercises, spirometry, cessation of smoking, and cardiopulmonary exercise testing guided rehabilitation programs are helpful. Prevention and strategies to reduce post-operative pulmonary complications are using low FiO2 and maintaining an SpO2 between 88 to 92%, use of steroids, using lung protective ventilation of 6 to 8 ml tidal volume with a plateau pressure not exceeding 30 centimeters of water, using optimal PEEP, avoiding use of hypervolemia, and preventing overzealous fluid administration by cardiac output and arterial waveform monitoring, guided fluid therapy, advocating multimodal analgesia, and using post-operative lung expansion techniques like incentive spirometry and breathing exercises. Radiation can also cause radiation-induced lung pneumonitis and fibrosis. Again, radiation can also cause airway edema, causing poor mask seal, poor neck extension, trismus, and causing difficult laryngoscopy, mask ventilation, supraglottic device placement, and emergency surgical airway device emergency surgical airway techniques. The central nervous system. Again, the effect of chemotherapeutic drugs on the central nervous system, vincristine and cisplatin are known to be causing peripheral neuropathy and encephalopathy. Methotrexate can cause aseptic meningitis, myelopathy, acute and subacute encephalopathy, seizures. Paclitaxel can cause burning paresthesia. Cytarabine and ifosfamide can cause cerebellar dysfunction and encephalopathies. Again, whenever a patient undergoes has received chemotherapy which has caused neurotoxicity, it is always better to have a thorough neurological assessment. Rapid sequence induction may be advocated in patients with autonomic neuropathy and gastroparesis. Regional anesthetic techniques are relative contraindications if there is a pre-existing neurodeficit, and certain anesthetic drugs may be used with caution, like succinylcholine can cause rhabdomyolysis in patients with myopathy or neuropathy, and tramadol can cause and precipitate seizures. CNS radiotherapy can cause demyelination, somnolence, and spinal cord electrical stimulation or electrical cord-like sensation called Lermit syndrome. Radiation can cause focal hemorrhages and CNS necrosis. Coming to the GI system, all chemotherapeutic agents and drugs cause nausea, vomiting, diarrhea, mucositis. Because of this, nutritional deficiency, because of poor intake, weight loss, cancer, cachexia, dehydration, and fluid and electrolyte imbalance are often problems which accompany chemotherapy and effects on GI system. Radiation can cause diarrhea, gastritis, mucosal ulceration, and fibrosis. Coming to the renal effects, cisplatin and platinum-based compounds are nephrotoxic. Cisplatinum is the most nephrotoxic out of them. 30 to 40% of the patients may present with nephrotoxicity due to increased renal concentration of the drug, vasoconstriction, and inflammation, and it manifests approximately 10 to 20 days after administration of the chemotherapy. It may present as electrolyte abnormalities like hypokalemia, hypomagnesemia, hypocalcemia. It may present as non-oliguric renal failure or acute kidney injury, acute renal failure which may recover or develop into chronic renal insufficiency. It is usually treated during the administration of the chemotherapy by adequate hydration regimes and adequate electrolyte supplementation. Other drugs which are nephrotoxic are methotrexate, which causes intratubular precipitation and renal damage. Mitomycin causes hemolytic anemia and microangiopathic renal failure. Ifosfamide causes proximal tubular abnormality, and cyclophosphamide causing hemorrhagic cystitis. The perioperative anesthetic implications are correction of dehydration and dyselectrolytemia, avoiding any renal hypoperfusion by maintaining mean arterial pressure, avoiding nephrotoxic drugs, adjusting the dose of nephrotoxic drugs and anesthetic drugs, and monitoring the urine output, blood urea nitrogen, serum creatine, and electrolytes perioperatively. Radiation can also cause radiation nephropathy, proteinuria, and hypertension. Coming to the hepatobiliary system, various drugs are known to be attributable to be toxic to the liver with marked altered liver function. The drugs belonging to this class are methotrexate, which can cause liver fibrosis and cirrhosis. Cyclophosphamide can cause diffuse hepatocellular damage, and Lunase can cause pancreatitis. Various anesthetic drugs and their dosages need to be modified as per the severity of the hepatic dysfunction. Coming to the last system, which is the hematological system, anemia can be a common side effect of chemotherapeutic drugs because of myelosuppression. It reduces the oxygen carrying capacity of the blood, and if blood transfusion is given, transfusion related immune modulation may contribute to cancer recurrence. That is why restricted transfusion thresholds are advocated, and preoperatively nutritional rehabilitation, use of hematinics, blood salvage techniques, and transfusion of leukodepleted RBCs should be adopted. Again, it can cause decrease in the WBC count line also. Elective surgeries are usually not performed during this period. Emergency surgeries may be performed. However, there is an increased likelihood of refractory infections. That is why you need to take aseptic precautions, and prophylactic antibiotics need to be administered in the perioperative period. Thrombocytopenia also is frequently encountered. A count of 50,000 is necessary to proceed with general surgeries. However, in closed cavity surgeries like ophthalmic surgeries and neurosurgeries, 1 lakh platelet count is advocated, and it is recommended. If the count is more than 80,000, then it is safe for neuraxial anesthesia. Otherwise, it is best avoided. Other reactions are allergies. Hypersensitivity reactions may also occur during infusion of chemotherapeutic agents. To summarize the complications of chemotherapy, cisplatin and carboplatin cause ototoxicity and nephrotoxic effects. Bleomycin causes lung injury. This is the chemo man, okay, which depicts the side effects of chemotherapeutic agents. So bleomycin causes lung toxicity. Doxo and daunorubicin causes cardiac toxicity. Vincristine causes peripheral neuropathy. Cyclophosphamide causing hemorrhagic cystitis. 5-fluorouracil, 6-mercaptopurine, and methotrexate causes myelosuppression. Coming to the last part of my talk, the immunotherapy and targeted therapies. Monoclonal antibodies like bevacizumab, trastuzumab, cetuximab, all of these have been recently been used as targeted chemotherapeutic agents and have a variety of toxicities. Similarly, tyrosine kinase inhibitors like sorafenib, imatinib can all cause pulmonary hypertension, GI bleeding, perforation, and decrease in the ejection fraction, pneumonitis. So it is best to identify what chemotherapeutic agent the patient has received and to find the side effect profile and investigate, optimize, and treat accordingly, and target and tailor make your anesthetic plan for for patients who have received various types of chemotherapy. Thank you very much.
Hello. Thank you very much, sir, for such a nice, elaborative talk. And you have covered everything almost. So I ask audience to have any questions. So we can ask Dr. Jason.
Thank you, madam.
Okay, thank you very much, sir.
Thank you.
Hello. Now I would invite Dr. Geeta Madam Joshi for next lecture, that is palliative care role of anesthetist. As Dr. Geeta Madam
Thank you, Dr.
is for the next session. So I welcome Dr. Geeta Madam for the next topic. Please continue.
Namaste. My greeting to all anesthesiologists. I am going to speak on role of anesthesiologist in palliative care. These are the two living legends, pioneers from Gujarat, who had started integrating anesthesia, pain medicine, and palliative care. As you all know, the movement for palliative care has arisen around the world as a protest against pain and as well as supporting the dying patients. And anesthesiologists, because of their two expertise, that is expertise to treat the pain and expertise of working in ICUs, are the right person to practice palliative care whenever they want. Anesthesiologists are multifaceted personalities. They act as a perioperative physician and they are expert in interventional pain management and handling injectable opioids. They are thorough with the pharmacy of sedative drugs and they have got unique skill of titrating and monitoring skills. They can work as a team in ICU. They can have interpersonal capabilities. They can manage difficult airways. Hence, they can not only secure the airway, but can also insert the nasogastric tubes in palliative care setup. Though they are expert in pain management, there are certain aspects which they need to learn if they want to practice palliative care. They are expert in pathophysiology of pain, assessment of pain, and interventional nerve blocks. But all this they practice for acute pain management, and they have limited knowledge about the chronic pain management. And regarding intervention, only 15 to 20% of the palliative care patient needs intervention. Otherwise, they are always on oral morphine. Anesthesiologists can handle narcotics like morphine and fentanyl, but of course in injectable form, and their tablet form and fentanyl patch, they have hardly used for chronic pain management and for the patients who need palliative care. Methadone is a new drug in armamentarium of palliative care physician and which is not yet used by anesthesiologists yet. Anesthesiologists can manage cancer pain, but cancer pain is not only physical pain, it has got other aspects like emotional, social, financial, spiritual, and psychological aspects, which needs to be evaluated, addressed, and treated by very good communication skill. Though I don't doubt their communication skill as far as surgeons are concerned, but they need to learn communication skill with patients and caregivers. Here are the number of interventional procedures which anesthesiologists can perform with their eyes closed, as they are expert in anatomy and blocking the nerves with their under the C-arm or under the CT guidance and all that. But as I said earlier, only 15 to 20% of the patients in palliative care setup need intervention because they are not fit to undergo these procedures. Many a times they are not able to withstand this procedure. As I said, anesthesiology in Gujarat, we have got highest number of head and neck cancer patients. And in palliative care, we get all these types of patients with abnormal airways. Anesthesiologists, being expert in airway management, can they easily put nasogastric tubes in these patients for the feeding purpose. Another most important role, I will say, of the anesthesiologist lies where the end of life care is concerned, as they work with in a high dependency unit, post-operative ward, and ICU, where any patient can become critical and is dying. They resuscitate them, they put them on ventilator and prolong their life. But before doing that, they must ask these questions to themselves and to their colleagues. Do oxygen help in all breathless patients? Do all critical patient needs to be in ICU? Do all patients in shock needs inotropes? Does cardiac arrest means always resuscitation? And do all patient needs to be put up on ventilator before they die? The answer is no. And here anesthesiologist has to learn when not to resuscitate, when not to put the patient on ventilator. For this, they have to learn the ethical principles of medicine, which we have learned in our UG level. These are the four clinical decision should be aimed, four principles of ethics. They are autonomy, beneficence, non-maleficence, and justice. So before making any decision about the resuscitating the patient or giving oxygen or putting them on ventilator, they should have this 4-quadrant approach. Will this treatment will be benefit to the patient? Will it improve the quality of life of the patient? Does this patient who is dying need this treatment? Is this treatment available? And am I justified using this costly treatment sometimes for this patient, or reserve it for the patient in future who needs it more? These are the things they have to have an introspection before resuscitating a patient. These are the few examples of practicing these ethical issues, like autonomy. Always respect the patient's informed consent, their advance directive, and accordingly you decide about the do not resuscitation, withdrawing or withholding the life support treatment. Your all action or your decision should have beneficence or improving the quality of life of the patient, and equal distribution of the resources available in your setup. And always try to give dignified death to your patient. Don't neglect them. Don't isolate them from their family. Involve family in decision making by telling them truth about the situation and about patient's condition, and always respect privacy and confidentiality of patient. Considering this, a joint position statement had come up in 2014 from Indian Society of Critical Medicine and Indian Association of Palliative Care. These two organizations, very esteemed organization, came up with a end-of-life care policy. And the aim of this end-of-life care policy is to improve the quality of dying person. And it is framed in such a way that it is framed within the ethical and legal framework, and through families' consensus. So if you follow this guideline, it will help you in deciding whether to resuscitate this patient, whether to withhold or withdraw the life-sustaining treatment. These are the guidelines, how to go. The whole process has been explained. One can go through it, and there are now number of articles are available in learning this end-of-life care process. So, important role of anesthesiologists, even if they do not practice as a palliative care physician and they practice only as an anesthesiologist, if they learn end-of-life care process and practice it, they can save so much of hospital resources. By understanding patients' needs and by understanding families' need, they can help the family, they can give the patient dignified death, and help the administration and reserve the resources for the patients who needs more. So anesthesiologists are very important person as far as a dying person is concerned. And it is not the time, during our residency, we are taught that any patient who comes serious, not breathing, comes in ICU, start resuscitating, put endotracheal tube and put the patient on ventilator. It is not that. So now one has to consider and take decision as per the patient's condition, their disease status, patient's wish, family's wish, and available economizing the available resources. There are a number of evidence and review articles which supports that anesthesiologists has an important role to play as a palliative care physician whenever in ICU or in wherever handling the critically ill patients or dying patients. So even if anesthesiologist decides to change over their specialty to palliative care, or even as not deciding, but still they can learn many new things as an anesthesiologist. First and foremost is how to prescribe opioid. And as per NDPS rule, all registered medical practitioner who wish to procure narcotic license needs to undergo basic training in palliative care. It is a 3-day training conducted at GCRI, and in last 5 years we have trained number of anesthesiologists who were willing to procure this license. End of life care and ethical consideration, it is a half-day workshop. Usually it is a part of a conference of critical care conference or anesthesia conference. Communication skill, though it was not, we were not taught at UG and PG level, it is very important as if you wish to be, or wherever you are practicing. Change in attitude to empathetic attitude is required whenever you want to practice as a palliative care physician. And one can learn this all subject as a new subject and upgrade their knowledge, their experience, and their skill. Here I am going to briefly present a case study of Department of Pain and Palliative Medicine, Gujarat Cancer and Research Institute. This has come up with the pioneering efforts of 3 anesthesiologists, myself, Dr. Preeti Sanghvi and Dr. Bhavna Patel, who chose to give up their anesthesia practice and change over to palliative care physician. And with that effort, now this department has started MD in palliative medicine, and it is a nodal center for training of all doctors and nurses in palliative medicine. How we change over our attitude and our practices, that is interesting. By studying this one block we used to practice a lot in the beginning. As I said earlier, we get number of patients of head and neck cancer patients. Almost 60% of our patients are head and neck cancer patients, and they have got moderate to severe pain. So we started practicing sphenopalatine ganglion block. Being an anesthesiologist, firstly we used to try this block. But with the extensive work by Dr. Preeti Sanghvi, we change over this our practice. So we started practicing sphenopalatine block, but soon we realized that it is not possible for all the patients to come very frequently to the department to take up this block. So she devised a very simple technique in which she uses a swab stick introduced into the nostril of the patient, and over it Isacon is instilled drop by drop. We started practicing ourselves, then we started teaching this to caregiver, and they used to do this block at home whenever patient has severe pain. And we realized that it decreased the amount of morphine used in the patient, and even the duration of analgesia increased as the block was repeated. This work is published in Indian Journal of Palliative Care. This is one example how anesthesiologists, by changing over the attitude, empathetic approach, and considering the patient's view and patient's condition, how we change over from interventional specialist to a person who has simplified the procedures which can be done at home, and patient need not come to hospital very frequently. These are our patients who used to do the blocks at home. Even NMC has recognized, identified these 7 specialities. These specialists are eligible to become a palliative care physician, and their specialty is recognized for starting MD in palliative medicine. Anesthesiologists are on topmost over there. The palliative care need in Gujarat is huge, and which is not possible that we can have so many palliative care physicians. So anesthesiologists, by learning few techniques, few drugs, and few practices, can practice as a palliative care physician wherever they are. As you know, the Gujarat population is almost 7 crores. And as per Global Atlas of Palliative Care, 1,064 person needs out of 1 lakh needs palliative care. So as per this figure, in Gujarat, 8 lakhs population need palliative care, and in Ahmedabad, 97,000 people need palliative care. We have about a dozen of palliative care centers with nodal center at GCRI. And with this type of services, we are able to cover only 12 to 15% of palliative care needs in Gujarat. So you can understand the demand is very huge, need is very huge, and all anesthesiologists, by learning few drugs, oral medication, oral morphine, or practicing end of life care in wherever they can contribute a lot in palliative care services of Gujarat. These are various centers across Gujarat with GCRI as a nodal center. And these are the leaders in across India. Of course, most of them are anesthesiologists who have contributed a lot in making palliative care turning it into the palliative medicine, a postgraduate subject, a specialty. So at present in India, we have nearly 5 centers where MD palliative medicine course is going on. And recently we have DNB in palliative medicine is also started, and 5 centers are in pipeline to start this course. So this is the progress of palliative medicine. And anesthesiologist has contributed immensely, not only in Gujarat, but in India, to bring up this specialty up to the level of post-graduation. Thank you very much.
Thank you very much, ma'am, for such a nice talk. And I have no questions after this lecture because you have covered everything. And thank you very much once again. I would ask the audience if you have any questions regarding the same.
Thank you.
Okay, thank you. So we are closing this session.
Organizers, is there any
हाँ
बेटा इधर बैठ के बनाओ चप्पल मैं बनाती हूँ बोलने वाली क्या बात है चप्पल पहनो पहले पहले चप्पल पहनो मैं रखूं वापस वापस रखूं क्या ऊपर आओ फिर बैठ के शो नहीं करना आप तो बड़े सुंदर सुंदर बना रहे हो पहले ये बना लो ना ऐसा बनाओ आ गया
Hello. Finish. Hello. Ankita Rajnish, please turn off your mic. Ankita Rajnish, please turn off your mic.
फोन के नीचे फेंका आपका दिमाग तो नहीं खराब हो गया कहीं मेरा फोन क्यों नीचे फेंका पहले ये बताओ मुझे लगा के लग गया चाचू आ गए
Ankita Rajnish, please turn off your mic.
चाचू आ गए
Hello.
Welcome back.
Am I audible?
Good afternoon, all of you. Now, I
Hello. Am I audible?
Yes, you are.
Okay. Good afternoon, all of you. Welcome back. Isacon 2021. Now we are moving forward and start our next session. That is panel discussion. For this session, I invite Dr. Murali Joshi and Dr. Nandita Mehta as the moderator. Topic is opioid sparing strategies. So, and I request to moderators please introduce panelists and continue this session. Dr. Murali Joshi, are you there?
Dr. Nandita is there.
Yes, yes. Another moderator, that is Dr. Murali Joshi.
I don't think he's coming.
Okay, then continue. Dr. Nandita Mehta, please continue this session.
But I don't have the slides of all the panelists.
Yes,
Are we
yes.
sharing? Can you share
Technical
the
team,
slides?
please. Technical team.
next session चालू करेगा.
Hello, technical team, please. Just a second, madam.
No issues. No issues. Take your time.
Yes, sir.
Hi, Nandita.
Hi, how are you?
Had lunch?
No. I thought I'll finish off this first and then have my lunch.
Hi, ma'am.
Hello, Dr. Hi, Sandhya. I can see Dr. Ruchi also. Yeah. I don't know, there are some technical issues here.
Yeah.
Just a throw 3 minutes. Technical team is arranged this.
Welcome
Please.
everyone. We are
Hello.
Good afternoon, Saraswati ma'am.
Good afternoon, Nakamahadevi.
Hi, good afternoon, Dr. Saraswati.
Yes, good
Hi,
afternoon.
Ruchi.
Hi.
You are in the war still?
Yeah, my work still running. Pain clinic is still running.
Oh, hi, Ruchi.
Hello, Ji.
Hi.
Hello.
Yes,
How are
yes.
you?
Nice to see you all.
Thank you.
Yeah, same here.
ಅವತ್ತು ಹಂಗೆ ಅನ್ಕೊಂಡು ಅದಕ್ಕೆ.
Dr. Sukhdev is present physically over there.
Yes, it's already gone.
He is already there. Yeah.
Today since
Hello,
morning,
technical team.
today since morning I'm doing blocks in palliative last and stage care. I'm doing blocks.
Okay, great.
What blocks you did, Ruchi?
I did sciatic nerve along with the caudal And then I did femoral with the, dry needling, ultrasound guided dry needling. Then one I gave epidural.
Oh, quite a lot.
Tunneling with it. So another patient, I'll go after the panel. After the panel discussion, I'll come.
You're doing a lot of.
I think on Saturdays we should start cutting down. Yeah, I don't put procedures on Saturday, Baba. I don't feel like.
The mindset is like that. No, the weekend starts only from Saturday itself.
And in the US, though, Thursday itself, their celebration starts. Thursday evening itself.
I think now they are starting.
Yeah.
Hopefully they start in time now.
Correct.
Okay, we have with us the slides of Dr. Guru Santhya. And she's working as an associate professor and at Tamil Nadu at Coimbatore in Kumaran Medical Center.
Madurai.
Yeah. The next slide, please. We have with us Dr. Ruchi on the panel. She's a senior anesthesiologist and a pain physician. And she's working at Shri Guru Ramdas Institute of Medical Sciences, Amritsar. We have Dr. Sukhdev Nayak with us in the panel. He is working at AIMS Bhubaneswar and he's got 40 years of experience, even more than that. And he's got many awards to his credit. Dr. Akama Devi is sitting with us. She is professor of anesthesiology, head and neck pain and palliative care at Mysuru JSS Medical College. And she's a fellow of Indian Academy of Pain Medicine. And she is doing palliative care, a lot of palliative care. Can I have Dr. Saraswati's introduction, please? Dr. Saraswati is another panelist with us, and she is a senior person. I don't know why her slide has not been projected.
My slide has gone to hall C.
Oh, okay.
They have presented in pediatric anesthesia.
Okay. So she's working at Kidwai Medical Center and she's in Bangalore right now. And she's a senior pain physician and a palliative care. She has volumes to her credit.
Yeah.
Now we'll start with the panel discussion.
Yes.
About opioids and opioid sparing strategies. Good afternoon, everyone. This is a very interesting topic, opioids and opioid sparing strategies. It's a very interesting topic for panel discussion. And we have our esteemed panelists, Dr. Saraswati, Dr. Akka Mahadevi, Dr. Ruchi Gupta, Dr. Sukhdev Nayak, Dr. Guru Santhya, and Dr. Jyoti. I hope I'm not missing out on anybody. And I'm Dr. Nandita, your moderator. Yeah. So, as you all know, opioids are an integral part of all pain management, whether surgical, preoperative, perioperative, postoperative, and acute and chronic pain. They have well-known short-term and long-term adverse effects, both for the patient and for the society. The long-term side effects are responsible for the ongoing epidemic of opioid globally. Especially in our country, the drugs are being misused because of so many reasons. they are mainly, I mean, the epidemic is mainly related to the oral opioids, and yes, injectables are also the culprits, which are being used for the chronic pain management, and then people are misusing them. So this all happened in US. The Congress declared 2001 to 2011 as a decade for pain control in research. So what happened was liberal opioid was used to and encouraged so that the people had good satisfaction of pain, being pain free. But this resulted in a misguided effort by the pharmaceutical companies saying that this opioid is good and you can do it for this reason, this reason. And so what happened was all this led to overprescription of opioids. And with a limited oversight, nobody knew that we are heading for an epidemic of opioid misuse. So now, with this, several studies have also shown that there's a disconnect between the prescriptions provided to the patients and the opioids actually required to manage the pain. So the onus lies on us to prevent this kind of a situation. So I would like to ask Dr. Sukhdev to enlighten us about the Narcotic Drugs and Psychotropic Substance Act, and then basically the salient features of the act, so that we can proceed with the discussion after that.
Yes, thank you, Dr. Nandita. Narcotic drugs have been in use for ages in India, and there are certain issues with drug trafficking in the late 80s and late 60s and 80s. The government of India enacted this 1985 NDPS Act. There are lot of penalties, lot of severe problems, because they thought the drugs is going. They didn't differentiate between the drugs used for medical use and drugs used for enjoyments or trafficking, because the government has to encourage the medical use of and research use of morphine or narcotics and prevent the illicit use. So the government has two roles. They have to encourage the medical use and deter the illegal use. But government, they wanted to stop it, so they wanted severe punishment, so many things. So the narcotic drugs use drastically came down after the 1985. So then the IAPC was formed in 1994, and cancer pain was very severe, and they thought the IAPC had a group. Dr. Saraswati was also involved with that, and they formulated, and Dr. Rajagopal and Dr. Joranson from America, they lobbied the government of India, and the Narcotic Drugs Psychotropic Act has been modified 3 times: 1985, 2001, and 2014. So the 2014 Act is much simpler, but still there are a lot of complications. But the problems associated with the 1985 have been very largely resolved in the 2014. It is much simpler, and they have coined 2 terms. One, essential narcotic drugs. 6 narcotic drugs have been named as essential, and one more thing, they have also coined a term, recognized medical institutes, RMI. So these 2 things are very salient features. Any government hospital is automatically become a RMI. So it's easy for any of us working in a government hospital to get us declared by as RMI. However, the private sector also can be a RMI, recognized medical. They have to approach the local drug controller of the state, and they have to give some very simple data like how much patient they are seeing, how much chronic patient they are seeing, how much non-cancer or cancer patient are seeing, and what is the amount of drugs or whether morphine is available or not. And then the private hospital also can be designated RMI. Once you become RMI, all these license things are not required. The RMI, the designated medical officer, can straight write to the supplier, and after the approval of the administration or authorities, they can straight get the morphine. So if you have your own morphine, a lot of problems of data also is also avoided, because in a normal, if you write a medical prescription for any opioid, you have to have 3 copies. 1 copy for you, one copy for the patient, another copy for the drugs. So if you have got your own morphine, one prescription is sufficient. You need not have these three. So that's why I always recommend, I always request all of us to declare ourselves a RMI. It's very simple. If you are a government hospital, very simple. And if you are private also, it is also not that difficult. So if we have got our own morphine in our own hospital, the record keeping, the prescription writing, it becomes much easier. Only one prescription, that to the patient, and your hospital pharmacy does it. Kidwai Hospital has been doing it for ages, and many of our government hospitals are prescribing oral morphine for cancer and chronic pain. So I again take this platform, all of us should take efforts to declare ourselves as RMI, recognized medical institute. Then we can stock these 6 ENDs, essential narcotics, but out of these all are not available. Morphine, fentanyl are available, methadone is also available. These 3 drugs I think are more than sufficient to tackle the chronic pain and cancer pain. And I again say this, with this 2014 amendment, things have become much easier. The oral morphine use, oral opioids use which has declined after the 80s to very low, abysmally low level, again has picking up, and in the coming years, so the cancer patients are getting morphine, and I think all of us should take. I can share after this session the document, the links that is required to get one hospital recognized as RMI, and we all can have oral morphine. So this taboo that cancer is not available, a lot of record keeping, data keeping is required, that is dispensed, and this 2014 is really welcome. And I must congratulate the IAPC, Dr. Rajagopal's team, to ensuring oral morphine freely available in India.
Thank you. Thank you, Dr. Sukhdev, for enlightening us regarding the NDPS Act. So my next question goes to Dr. Jyoti. Dr. Jyoti, do you think opioids are being overused for the management of pain, like after the availability of opioids? What is your take on this?
Good afternoon, ma'am. Thank you for asking me for this question. Ma'am, basically it depends on the context we are talking about. So if we talk about, I just want to stress upon one point. If we talk about the Western countries and especially for the chronic pain, definitely yes. This was the point from where the opioid use and overuse has all started. So there was an easy availability, a relaxing prescription guidelines, and basically the force of the feel good factor for the patient. That has actually led to the opioid overuse. So, but if we talk about India, as sir has already said, the scenario is different. There is an access is guarded for all of these stakeholders: the patients, the physicians, the pharmacists, the transporters, the manufacturers. We are already, we have discussed about the NDPS Act. The opioid prescriptions for chronic pain, cancer pain specifically, is in fact less than is required, because this has been guarded at all the points. So now coming on to the perioperative and the post-operative use. There is not much data about the post-surgical opioid use. There is a huge knowledge gap between us. So the point is that the anesthesiologists and surgeons have a shared responsibility for the patient's outcome. The first challenge and post-operative anesthesia. Now, secondly, it comes that we have to minimize or prevent the opioid-related side effects, specifically the respiratory depression. Now, the anesthesia patient safety foundation has highlighted the importance of post-operative respiratory depression. It is approximately, the data shows that it is up to 0.3% to 17%, depending upon the severity, requiring the use of naloxone. Okay, now coming on to the intra-op and post-operative opioid use. There is a lot of knowledge gap between the, specifically in India, there is not much research on it. So the point is that there is a shared responsibility between the anesthesiologist and surgeons for the patient's outcome. First challenge is that there should be an adequate perioperative analgesia as well as the postoperative analgesia. Second is we have to minimize or prevent the opioid related side effects, specifically the respiratory. There is a soaring volume of opioid prescription and the patterns, basically opioid abuse, overdose, and addiction. That comes from one point is we have to stress on that is basically the prescription overdose, and that prescription overdose is not for the patients. The drugs which are not used, unused drug from the prescription overdose is basically distributed to the family and the friends. That is causing the main epidemic, that is the opioid epidemic we are all concerned about. So, we have also seen that in the past we were using ultra short acting opioids or short acting opioids. There have been a lot of data which shows that if we use short acting opioids intraoperatively, it increases the requirement of postoperative analgesics. And most of the times we prescribe opioid in the postoperative analgesia in such patients. So,
very rightly said, Dr. Jyoti. My next question is to Dr. Saraswati, who's had a vast experience of using tons and tons of opioids in her career. And she's a senior person who is into pain management and especially palliative care for a long, long time. So I would like to know about her experience about the opioid tolerability and addiction. What is her and how she tells us how to manage this situation.
Good afternoon, Dr. Nandita. Thank you so much for inviting me. See, there are two concepts involved here. One is tolerability or tolerance, then is the addiction. See, opioid tolerance is not our main concern because most of our patients or majority of our patients are maintained in long periods on a stable dose of morphine. See, we are in a cancer center, is Kidwai Cancer Institute, and we have treated around more than 60,000 of cases. And tolerance on long-term patients, there are two things. One is maybe because of the disease progression. First one, if the disease progresses and patient requires more amount of opioids, we can increase, or otherwise the patient might be because of the tolerance. Just to escalate the dose of morphine is the only, or otherwise rotation of morphine. That is the only two things for the issue of tolerance. Next thing, we come to addiction. Am I audible to you all?
Yes, clearly audible.
Is addiction. Addiction means only when addiction comes, only when we use or on long-term basis or chronic usage of opioids causes addiction. But that can occur only with malignant pain. Usually in cancer patients with severe pain, we use on long-term opioids, and that might cause, that was the main concern in the initial phases of our palliative care life. But now there are two types of actually opioid dependence also we can call. One is physical dependence and another one is addiction, psychological dependence. Physical dependence is not at all uncommon with long-term usage of opioids. Only when it manifests is that is mainly because of due to when we withdraw opioids after radiotherapy or when the disease is treated, the patients complain of physical dependence. That is usually they may complain of abdominal pain, diarrhea, or excessive lacrimation. This type of things usually they complain of. The treatment is we slowly go down on decreasing the dose of opioids. Then comes our addiction, psychological dependence. Psychological evidence-based medicine or our surveys show that psychological dependence or addiction is extremely rare. According to our literature, there are 4 cases in 12,000 patients. We had seen around 3 or 4 patients of addiction in Kidwai Cancer Institute in our 48,000 of patients. The main thing is addiction is when they take on long-term opioids, when they escalate the doses, sometimes Unsanctioned dose escalation. Usually when we prescribe about 60 milligrams 4th hourly, sometimes the patients who are drug users, they may escalate the doses. Those type of patients we know, and we always take signatures and we always give it to a caregivers also. And report of theft we had seen. We had given for 15 days to a patient, and report of that some patients may take, the bystanders can use the opioids which are prescribed to a patient. These are the two things, but addiction is extremely rare, and medical purposes, when it is used orally, when it is titrated against pain, when it is given for moderate to severe pain in oral doses, opioid addiction is very rarely seen. That's
Thank you, Dr. Saraswati. Dr. Akka Mahadevi, I would like to ask you something about the rationale behind the opioid rotation.
Am I audible, Nandita?
Yes, you are.
Yeah, good afternoon, and thank the organizers for this opportunity. See, first of all, we have to understand what opioid rotation is. So as we all know, the rotation of opioid is changing the opioids from first line of therapy to probably the second line of therapy. And more often it happens because the patient might be suffering the adverse effects. See, he's getting good analgesia, but the adverse effects he cannot just tolerate. It could be that, or it could be the increased need for the dosage of the opioids, escalation of the dosage of the opioids to get analgesia, but then there are side effects of it. So these are the reasons why we might have to need opioid rotation, see, from one group to another. The thing being, we cannot go on increase the dosage of morphine, which can cause, it is said that the morphine equivalent dose of more than 100 can definitely cause mortality. So we do not want to do that. So, and also the studies have shown that 20 to 40% of the patients might need the opioid rotation to get, the relief of around, say, 40 to 80%. Okay, and sometimes it is the convenience of the patient which might require opioid rotation, because he might not be able to swallow, he might not be able to take the tablet. Okay, then we can switch him over to fentanyl patch. Okay, so such are the situations when we need to do the opioid rotation. And then why do these patients develop tolerance? See, tolerance, as we know, the cancer pain or the chronic pain, it's a dynamic thing. It keeps on changing, right? So there can be neural adaptation. That could be the reason why the person is developing tolerance. Or there could be, we must have heard about the pharmacogenetics, right? Each person's genes respond in a different way to individual drug. So there could be resistance, tolerance to the medication. And also sometimes it so happens that the NMDA receptors get activated. Right? The NMDA receptors cause resistance to the opioids. That is when our conventional morphine and such things. That is when we might have to require some NMDA receptor antagonists like methadone, etc. But then I got a very beautiful reference, a systematic review of opioid rotation in cancer pain treatment by Michael Schutner. What he says is the evidence favoring opioid rotation is controversial. See, in Germany and in some other countries, they have very weak recommendation regarding the opioid rotation. And what they substantiate, what they argue is, they're saying that there is no use of the new drug that is introduced is not causing efficient analgesia in the equianalgesic doses. Is one thing that you need to really increase the dose too much. And yet another what they say is, they're saying that the side effects did not come down at all. But then in this systematic review, finally what he says is opioid rotation can improve analgesia and patients satisfaction. That is what he says. So ultimately, you might have to do the rotation. It all is all left to your clinical judgment, and do the rotation to improve the quality of analgesia. See, and how do you do that? Shall I tell about how it is done, Nandita?
No, I think that will be beyond the purview
A
of
little too much. Yeah. But one beauty of methadone you wanted to ask me.
Methadone
Methadone.
basically is a new drug which has been introduced into our kitty, and I know many of the institutions have still not started using methadone. But it is a beautiful drug, and if you have any experience regarding the use or
I have only heard my friend using it. See, the beauty of methadone is it's being used for de-addiction. That is one thing, and it has NMDA antagonist activity, which will really help the resistant pains. And there are some, it's a high potent drug, and the duration of activity action is longer, and the half-life is also longer. So it has to be done under the supervision of an expert, okay, who will, and there are chances of toxicity even after a long time because of the prolonged half-life. So one has to be trained in using it, and under supervision the methadone has to be used. That is what I understand by my friend's experience in Bangalore. I do not have personal experience.
Dr. Sukhdev wants to add something. Let us see what he has to say. Please unmute yourself, Dr. Sukhdev. Please unmute yourself.
I fully support Dr. Devi's views about methadone. Yes, it is a very good drug. We have been using for the last 2 years, only syrups. And recently they have introduced tablets, and we have not yet got the tablets. We will be getting it very soon. It's a very nice drug, very potent. But as he told, you have to be cautious because prolonged use again will accumulate. Then we have to reduce the doses, and cardiological toxicity, we should keep repeated doing ECGs. QTC intervals are really bad thing. So otherwise it's a very good drug, and dose is very small, and the patients feel. And main thing that we can also give to children because it's a syrup is available. But it's a good drug, and hopefully it will spread across India, and it's a definitely good drug in our armamentarium. Thank you.
So the message is clear, like methadone is to be used, only after getting a serial ECG done, and during the use of methadone also keep a check on ECG because it prolongs the QTC interval. That is what Dr. Sukhdev wants to say. Now, Dr. Ruchi, I would like to ask you something. Whether chronic cancer pain or non-cancer pain cannot be managed without opioids. Is it a myth or a fact? What is your experience?
Thank you, Dr. Nandita. We are actually in a state, Punjab state, where there's a lot of restriction on opioid use because of the lot of addiction and misuse over the state, especially in our part of the state. Absolutely, we have been trying for years together now to get morphine and other drugs, which we have not been able to get. And there is just one chemist who dispenses morphine. He also usually doesn't keep these tablets because he also gets now and then, probed up by the administration. So we have to deal with the cancer pains and everything. That should not be a limitation that we don't have morphine. So we cannot deal with these patients' pain that we don't have morphine or pethidine or methadone or all these drugs. So, but what we get in cancer pains is a patient's for post-op pains like scar neuralgias or unresectable malignancies or recurrences, or we get a palliative care patients. So in first category, if the pain is little milder, then of course we use the WHO letter. But usually the patients who come to us, they have already been given the drugs like PCM and NSAID combinations. Or even, if they have not been given, we start with the combination of these NSAIDs with tramadol. But we like to supplement them with the nerve blocks. And we also add tapentadol in these patients and start the pregabalin. Nerve blocks remain one of the, although it is in the last in the category of WHO letter, But we have to start it because we don't have the morphine category with us. And similarly for palliative pain, most of the patients who come for just the palliative or end stage life pain treatment, they are already getting tramadol or buprenorphine or fentanyl patches. Those are available with us. So we start them with Lyrica, which is an enantiomer of pregabalin, and give them tapentadol. We rely more on tapentadol because morphine and all other drugs are not available with us. And they got quite a good relief in patients. But as we recently, they said that it's a dynamic disease process. So their requirement keeps on increasing near the end stage. So we add up buprenorphine patches or fentanyl patches if they were not getting already, or they had some issues with the oral acceptance of the drugs. And now, since we have a ultrasound guided, we use a lot of peripheral blocks and other celiac plexus blocks and stellate and other blocks. We rely more on blocks, peripheral nerve blocks or central axial neuroaxial blocks for relieving them pain in that, because a drug should not be a limitation to treat pain. And we do pulsed radiofrequency ablation of nerves whenever or wherever it is possible. And in addition to this, we do take care, we have a team, so we do take care of social, spiritual, and emotional aspects in addition to the physical pain. And very, very rarely we use IV ketamine infusions, IV lidocaine infusion in these patients. But we do not let anybody go without being treated for pain.
Thank you, Dr. Ruchi. The message is that go for blocks early. Although it is on a very late stage in the WHO ladder, but in case you feel that this patient will be helped with blocks, then give good pain relief with blocks. And then obviously if you don't have opioids, then tapentadol again is a good drug, and other things, it's a multimodal approach. But yes, you can manage. In case you don't have anything, then it's not to deprive the patient of pain relief. It is better to give something.
And pregabalin really helps in these patients, especially Lyrica. It is, it has worked very well for our patients.
Dr. Sukhdev wants to add something.
I just want to add that most of us think without morphine, we cannot have a palliative care clinic. I'll just give an example of Dr. Abhijit Dham. He's from Ranchi. As you know, Ranchi, Jharkhand is not that well developed about the morphine and other things. Morphine is not available regularly there, but he has been continuing the hospice for the last almost 10, 11 years. And so he doesn't use in morphine. He has got a lot of cocktails, ketamine, so many things he uses blocks. So I think we should have, if you are getting morphine, well and good. If you don't get morphine, there are many other armaments we can give, and patients really enjoy the. That's
I agree with Dr. Sukhdev. He only came and gave us palliative care training 3 years back. So that was a time when we started full-fledged with the palliative care. Before that, we were a little hesitant because we didn't have morphine and we were trying for morphine. So he came and he trained us that morphine should not be a limitation for treating palliative care.
Yeah. Can I add one more point in this?
Yes, ma'am. Please, Dr. Saraswati.
Yes. Earlier, initially, when we started palliative care in 1989-90, we used to think morphine is the mainstay of cancer pain management. But later on, we have other drugs are available, and we used to titrate morphine. Now we have tramadol, fentanyl is available. And these are the drugs, though it is patches. We have the breakthrough pain is the one thing which is very important. That can be treated by, you have fentanyl lollipops and fentanyl patches and fentanyl, many other preparations of fentanyl. So with other pain specialists now, I think pain is extensively studied in our country. I think we can use, there are many ways to reach Rome. So nothing that morphine is not the main panacea of chronic pain relief. Yes. That depends on the person. Everything looks like a nail when you have a hammer.
Yeah, that's right.
And we deal with, more for the nerve blocks because even our patients can't afford fentanyl patches or buvalar patches. They're pretty expensive. And tramadol is also become Schedule H drug and it is not easily available. So with a lot of limitations, but at least no patient should go without pain management, whatever way we can help them.
Yeah.
It's a message.
So the next, again, I would like Dr. Sukhdev to tell us something about the major barriers, what the doctors, you've already covered this, but again, like what are the major barriers the doctors are facing and even the hospitals are facing in procuring morphine? Like Dr. Ruchi said, in Punjab, it's not there. You said in Ranchi also, it's not there. And what is the situation right now in our country regarding the availability of morphine for cancer patients, basically?
The major barrier faced by doctors that we don't know the rules. We don't try to read the rules. What are the available legally? We don't. We have not. How many of us has seen what is the amendment in 2014? We just see no. Itna bahut lamba hai. It's a lot of 200 pages. I don't have to read. So we must read. I'll share the links just after this the panel discussion. We must read what is really available. The government of India has already modified the Act 2014, and morphine, methadone, codeine, hydrocodone, oxycodone, and fentanyl. These are the 6 drugs which are declared essential narcotic drugs. Of course, hydrocodone and oxycodone are not yet available, but morphine, methadone, codeine, and fentanyl are freely available. So we must, if I want, I must make myself declare as an essential narcotic drug. I must declare myself RMI, and we should go. Actually, I don't think there is any real barrier unless we want it. I know our administration, our store, they don't want to keep it the record because there's a lot of hassles. But the hassles are much simpler if we are an RMI. So we must, actually, I will say that there's no barrier if I really want the morphine to be in our armamentarium. But we are always afraid. We are afraid of the foreign, the Western literature that morphine, there is overproduction of morphine, there is all dependence. And one more, the most important barrier is that our theory class in physiology, all of us went in the physiology class in the first MBBS, that morphine causes respiratory depression. So that sits in our mind that if I give morphine, patients will die of respiratory depression and he will die. But I again reiterate here that if there is pain, there will be tachypnea. The respiration rate will be somewhere around 35-40. So if I give morphine, the 35-40 will come down to 20. So that sits in our mind, our MBBS teaching that don't give more. I have given morphine in the terminal stage, and patient is distressed, sweating, anxiety, and he calms down. Actually, Rajgopal's picture, he has been shown around India and abroad. That picture that somebody's in that position, and then with only 10 milligram morphine hits, and he says size of relief. So our mind that morphine is respiratory depression, that must go away. Second point is that morphine causes constipation. That also again deters us. No, the pain of constipation will be much more than the pain of the cancer or the chronic pain. So if you adequately treat the constipation, if you train the patients and their relatives about the use of laxative, use of sufficient fluids, waters, and roughages, vegetables, then they will have a good normal evacuation. So that constipation, fear of constipation also sits in our mind. Then one more thing, diversion. If I give to the patient some morphine, if somebody is a drug addict or uses it for enjoyment, he can divert. But Dr. Rajagopal has done a study in the late 90s, and there more than 1 lakh tablets were traced, and not a single tablet, each tablet was counted, and they couldn't find any diversion in that big study. So that diversion also sits in our mind that I don't want to, that is another barrier. And one more big barrier, especially in the oncologist, not anesthesiologist, the oncologist, the surgical oncologist, the radiation oncologist, they think if you give morphine, patient will die early. That means you will reduce the patient's life. But actually, there have been studies in India and abroad where if you start morphine, even at the earlier stage or the late stage, the actual duration or the length of the patient's life is increased, and he has got a better quality of life. Morphine really adds, it never delays death, but it gives good quality of life, and the patients live longer with much more satisfied and no painless nights. And one more recent study in the last 5-10 years, it's coming up that morphine causes the spread of the cancer. The metastasis increases after if you use morphine. But all these studies are animal experiments. Not a single study is on human beings. So that data, many of the oncologists ask me, why are you using morphine? Morphine causes spread of the disease. It causes early metastasis. But you must all understand here, the genetic pool of animals and genetic pool of human beings are different. So what is happening in the animals may not happen with us. So morphine doesn't interfere with the progression of the disease. Morphine has been used for more than 50 to 60 years in cancer pain. Not a single report says that it really hastens or it really increases the metastasis. I think Dr. Saraswati will also support this. So we should not follow the Western data blindly. We should have our own data. We should have our own study that whether morphine is really helpful to our cancer patients or chronic patients. And I think if you study well, if you, to our resources, our what is available materials for the India, I think barrier will go away.
Thank you, Dr. Sukhdev. Now, like Dr. Saraswati, you have again used morphine a lot. What is your experience regarding the hyperalgesia with morphine? He's been talking about all the side effects of morphine, which he says are over written and over exaggerated. What do you have to say about hyperalgesia with morphine, its incidence, and if at all you have seen patients, how do you manage?
Dr. Nandita, this is a very good question. I'm audible, no?
Yes.
Hyperalgesia is the one which is extensively nowadays spoken in all the national and international conferences. Actually, hyperalgesia, paradoxically, morphine producing hyperalgesia, usually we were not accepting it earlier days. When we started morphine in 1992-94, when the patient complains of diffuse pains and allodynia and generalized body pains, I always used to think only in our country they complain of pain after starting a profound painkiller. But after that only, when I went to Hopkins and then when we were using morphine and this hyperalgesia topic has come, probably this must be because of that, because we didn't have knowledge about hyperalgesia at that time. But now we had seen quite a few means maybe around 18 to 20 patients we had seen now with complaining of hyperalgesia with long-term opioids, especially when you increase from 10 milligrams to 20, 60, 40, 90, 1,200 milligrams fourth hourly we have patients. When we escalate the doses to a higher level, those patients will be complaining of hyperalgesia. Hyperalgesia per se is not the main problem for us, but when we come to know that it is hyperalgesia, then we have to treat promptly. The main mechanism of this hyperalgesia is it activates the 3-morphine glucuronide. That is one of the morphine active metabolite, increases the spinal sensitivity. That is central sensitization and NMDA receptor activation. When it does that, the patient complains of pains. So the treatment of morphine-induced hyperalgesia is you can rotate the drug. First one is stop the drug and go to another drug. Rotation of opioids is a compulsory in hyperalgesia. Second thing is you can second line analgesic, that is NMDA receptor antagonist, definitely works out well. In all our 20 patients, we started on low dose NMDA receptor antagonist, that is ketamine. Then along with non-opioid analgesics, and definitely not use the same drug morphine, and you can always use the other drugs like fentanyl and methadone, which has a less neurotoxic effect. So this can be used for hyperalgesia in morphine.
So my next question is to Dr. Guru Sandhya, who has been listening to all of us since a long time. How do you manage acute pain? I mean, what is your strategy, opioid versus opioid sparing strategy?
Good afternoon, ma'am. Thank you for this opportunity. Am I audible?
Yes, you are.
Yes. According to me, acute pain management, we always follow the WHO ladder, wherein it is a 4-step process in which it is divided into mild pain, mild to moderate pain, moderate to severe pain, severe to very severe pain. In case of mild pain, we usually treat it with the NSAIDs or a non-opioid strategy with or without an adjuvant therapy. The non-opioids can be a selective or non-selective NSAID, or it can be paracetamol or aspirin as used in Western countries. These adjuvant therapies, depending upon the acute pain, the cause of acute pain, if it's neuropathic, then we can start them on gabapentin or pregabalin. If it is like, we can also use antipsychotics or antidepressants like selective serotonin reuptake inhibitors or selective noradrenaline reuptake inhibitors or tricyclic antidepressants in case of a neuropathic pain. If the pain is mild to moderate pain, then we can start them on a weaker opioid as per WHO guidelines, which may include tramadol, codeine, or dihydroxycodeine, with or without an adjuvant agent. Usually, these mild to moderate pain, I like to manage with a multimodal approach with paracetamol, tramadol round the clock. In case of moderate to severe pain, we can use a strong opioid, which goes for morphine. And personally, I've used only morphine and fentanyl for as a stronger opioid, rather than I've not got my hands on oxycodone or so. And have used morphine and non-opioids and an adjuvant therapy. In all steps of ladder, if at all the pain can be relieved by peripheral nerve blocks as discussed earlier, or in case of acute perioperative pain, opioid sparing approach is what I would like to personally use to avoid or mitigate the effects of opioids personally. And we have nowadays moved more onto a peripheral nerve blocks before the onset of the surgery, like a preemptive analgesia, which has helped us a lot better in managing the perioperative and the postoperative pain. If at all the pain can be mitigated with an epidural or continuous nerve block infusions, as in case of total knee arthroplasty with a adductor canal block, we go for that and mitigate the pain. In case of severe to very severe pain, we can go for interventional therapies like neurolysis or peripheral nerve blocks with or without an adjuvant agent and an NSAID.
Thank you, Dr. Gurusantha. Now, my next question is for Dr. Ruchi. What are the opioid sparing strategies that you use in your patients, and do you think those are adequate? And we are running short of time, so we'll all have to be a little brief. So please, Dr. Ruchi.
Thank you, Dr. Nandita. Since we have already discussed a lot of things but in our surgical patients, we use a multimodal. Since I said, we don't have opioids mainly. The opioids which are available with us are tramadol, butorphanol. These are the two opioids which we have. So we use these for if in a opioid limited anesthesia, if we say in one word. But otherwise, we use NSAIDs and other adjuvants. We use a lot of adjuvants in which ketamine, gabapentinoids as a pre-medication, dexmed, clonidine, midazolam, and also steroids. Some people have used IV lignocaine and IV ketamine, but we have not used for routine surgical patients. And of course, regional anesthesia, epidural, spinals, as all of us know, brachial plexus block, TAP block, PEG block, all depending upon the type of surgeries. But peripheral nerve blocks, we were using landmark technique initially, then ultrasound, now mainly ultrasound guided blocks we are using. And this has increased our horizon. Like we have now added up genicular nerve block, adductor nerve block, saphenous nerve blocks, lumbar plexus nerve blocks, and other nerve blocks, which we were not doing it earlier. They all have been added up now in our routine surgical anesthesia practice. And the second question, do you think your patients have adequate analgesia? Yes. We have acute pain service, which is a team which does rounds twice a day, and they're on call throughout the day. So any patient requires it. And we have seen there's a very, very good, because of the multimodal regimes, there's a very good analgesia. And very few patients, yes, there was one observation which we made in our set of patients was that ropivacaine was not very good in relieving post-op pain, as is recommended in the various studies and this thing. Our patients behaved better with the bupivacaine. So we stopped giving ropivacaine and we shifted to bupivacaine. That was one thing which I wanted to add from our clinical experience of
this post-op rounds. And that's how we know that our patients do get good, adequate pain relief.
Yes, in fact, in our institution, we are also having a study, a research project is going on the use of non-opioids. Like they are making a cocktail of lignocaine and ketamine and non-steroidal anti-inflammatory drugs, and they are giving, and I think the results are pretty good. So they don't require a opioid for that. So I fully support your and endorse your opinion about the non-opioid strategy. Now, the next question is for Dr. Jyoti. Enhanced recovery after surgery. How do you manage? Because nowadays is the concept of fast tracking, especially in older patients. This started with the colorectal surgery, and this concept has gone into other surgeries as well. So, how do you manage pain in such patients?
Yeah, thank you, ma'am. I'll not go much into details about the enhanced recovery after surgery. We are lagging short of time. So basically, this is a very upcoming thing. What is stressed upon is the pre-operative period, basically. So in the pre-operative period, what we do is we talk to the patient, we counsel pain which the patient is going to have, and basically interact with the patients, and we look for the we identify the high risk patients on high risk, which we do the scaling for the pain scales, the anxiety scales, the depression scales. We look into that matter, and the mental health professional are also involved in that. Basically, in ERAS, we have a multidisciplinary approach. So if we have sorted out the perioperative period well, then the patient already knows how much pain he or she is going to have post-operatively, and the pain pathway, what we say is the perception. The perception is taken care of. And then in the intra-op and the post-operative period, we follow multimodal regime, which ma'am has already told. So sparing the opioids, gabapentinoids are much into use, which have shown good effect on that, and other drugs also for the multimodal analgesia. And the other factors like the post-operative, the nausea, vomiting, or whatever the side effects the patient is going to have are taken care of with the preoperative counseling. So with that, the outcome is good.
Thank you, Dr. Jyoti. This was pretty quick. Now, Dr. Guru Sandhya, is it really justified to use fentanyl and buprenorphine patches for the management of post-surgical pain? And if yes, what is the dose in an opioid naive patient?
Ma'am, fentanyl and buprenorphine, of late there has been studies showing fentanyl patches and buprenorphine patches being used in post-surgical pain, as in total hip arthroplasty or total knee arthroplasty or any open abdominal surgeries. Fentanyl patches are usually available at the dose of 12, 25 mics, 50 mics, 75 and 100 mics. And the onset is usually 12 to 24 hours, and the steady state is reached only after 24 hours. So if at all we are using for the perioperative pain, then we have to stick it to the patient in the chest at least 12 hours prior to surgery, which may be the day before surgery, the night, or 8 p.m. or so that it is the onset is proper. In the multimodal analgesia, sticking the patients with fentanyl patch may help in abating the postoperative pain and reducing the use of postoperative analgesia with the opioids, because it may act as a preemptive analgesia as well. I had personally used up to 25 mics for post-surgical patients. Personally, have not gone or looked upon with 50 mics, more than 50 mics dosage, because this may, because of the narrow therapeutic index, the patients may have respiratory depression as well, and they have to be monitored. And dose adjustments can be made once in 72 hours, and these patches can be worn for 3 days. So that is the better goal, because even if the patient doesn't have an IV access, that does better. And in case of buprenorphine being an agonist and an antagonist and more potent than morphine, I personally used up to 5. The available doses are 5 mics, 10 mics, and 20 mics. I personally gone up to 10 mics per hour. And even in the perioperative period, it has helped my patients to reduce the dose of multimodal analgesia or any other opioids being used. Those opioid doses have come down pretty much because of the preoperative application of such patches in the perioperative population concern. One thing to be noted is even if the patch is removed, the action can be lasting for 24 hours in fentanyl patches and up to 36 hours in buprenorphine patches. So any side effects which we are looking for, we ought to be careful with using such patches, and patients have to be monitored. And these are patient friendly because it is just stuck and it doesn't hinder the patient anymore with an IV line. In opioid naive patients, I've gone up to 10 mics of buprenorphine.
Okay, this is for the post-surgical pain. But do you recommend using fentanyl and buprenorphine patches for post-surgical pain, or do you think these are better for managing chronic pain?
Personally, I've not been into chronic pain, but I have used for post-surgical pain. The other panelists may be better. Like those who treat chronic pain may be better persons to answer. In post-surgical patients, I've used buprenorphine and fentanyl patches also. That works pretty much well.
Okay. Dr. Saraswati.
Akka Mahadevi here.
Oh, okay, sorry. Dr. Akka, yes.
Yeah, see, my personal opinion is it's better not to use fentanyl and buprenorphine patches for post-surgical pain. See, the idea being the onset of action itself, yeah, pre-op if you put, that's okay. The onset of action itself takes 10 to 12 hours. And the more problem is you don't have control over the drug. Once you put a patch, if there is any side effect due to the patch, even if you remove it, the effect will be there for another 10-12 hours. See, you don't have a very good control over the drug, medication, serum level of medication. So it is, kind of better and safer not to use. That is what is my opinion for
I also endorse your opinion, Dr. Akka Mahadevi, because basically I was a strong supporter of fentanyl patches, and in fact I have used for myself in the post-op period. It really does provide you very good pain relief, and you're mobile all the time, but then it requires good amount of monitoring as well.
Yes.
Because the patient is going to go back home and the patch is going to be there for 3 days. And in case the patch gets heated up because of some reason, the blood levels will increase. So it's a risky proposition. So
Yes.
I think Dr. Guru Sandhya wants to add something.
I have specifically used in patients where I was not able to give like an epidural for a postoperative analgesia because of cost constraints. In such patients, we have used and monitored for 3 days and so on. Then we discharge. Only for such patients, we are like where we cannot give an epidural because of their cost constraints or the patient is not willing. Such patients, we have gone for patches now.
Yeah. So, in fact, I was a strong supporter of fentanyl patches till one of my friends got very dysphoric and she had lots and lots of nausea. And then I started reading about these patches and I realized I was overusing them. And so I stopped using them for the post-operative pain relief. Now, my next question goes to Dr. Akka Mahadevi. Is it really necessary to undergo the certification course for prescription of opioids for chronic pain patients? Like so many people are prescribing opioids without knowing the exact doses and for how much time to be given, how to give it. So do you think anesthesia people, especially for them, is the certification course really mandatory for them?
Yeah, see, Nandita, what I feel is some kind of a course, okay, whether you certify them or whatever it is, some kind of certification course or otherwise, the training is very much essential when one has to prescribe opioids, whether it's for cancer pain or for chronic pain. See, when it comes to that, most of the people, some of the oncologists I have seen, they give immediate release morphine 3 times a day like that. And sometimes the patient will be taking only at night. So that by clog, by mouth, and for the patient, depending on the renal conditions and the hepatic conditions, how much is to be given. So the prescriber won't know. and also the side effects of the opioids. So whether it is nausea or vomiting, how long does nausea vomiting exist? How long does the constipation exist? So what are the the other medications that have to be prescribed? And if you have to do a opioid rotation, change from one to another, what is the equianalgesic dose? See, all these things, and more importantly, the documentation, the registration, the prescription, all those, since it is a controlled drug, all those things have to be, taught to the person who prescribes. So prescriber plays a very important role. And coming to the chronic pain part of it, as we said, that decade from 1999 to 2010 or whatever, there were a lot of overdose of the morphine because of the use of these opiates for chronic pain patients. Okay, then there were many deaths because of that, more than 2 lakhs deaths in the US. So what they thought is they came up with this CDC guideline, that is Center for Disease Control guideline, and these days, those people who practice over there in the US or the Western countries, they have to, take an app which talks about all these things, or they have to go through a training, especially when they have to prescribe these things for the chronic pain patients, because they should assess the risk of that person going into addiction. So where is the need? Is there any need? So the trend is moving more towards non-opioid therapy for chronic pain also, as was discussed now. Whether it's acute pain, maybe initially for a few days you can start them and then taper and stop it. On cancer pain, yes, the chances of addiction are very less. Okay, continue with them. But in chronic pain, it's better. We have to go through the guideline, and there are several things which are given under the guideline. So that training or going through the app is very essential. And in our country, as far as I know, if Saraswati ma'am and Sukhdev sir can tell us, I think we go through IAPC courses, we go through Pallium India courses, and many of the, the recognized universities are running the courses, and I suggest everybody has to go through some kind of a course before giving prescription. Yeah, Nandita.
Thank you, Dr. Akamadevi. I think this was a very nice discussion on opioids. Now I would like to wrap up this session, and take home message is that opioids should be used for specific indications only. So avoid using medications which bind to opioid receptors for the treatment of chronic painful conditions. Their use for acute pain or terminal pain is well accepted, but for chronic pain, you should avoid using them. Abuse, physical and psychological dependence, like everybody was discussing, is a big issue with opioids in the management of chronic non-cancer pain. So for chronic non-cancer pains, there is a big no to opioids unless actually indicated. If it becomes intractable, try to avoid opioids. Switching opioids or routes of administration may be very helpful in order to avoid the side effects like Dr. Akka said. And opioid sparing strategies are advisable for management of analgesia in perioperative, especially post-operative period, and also in the chronic non-cancer pain patients. So we as anesthesiologists owe this to the society to decrease the burden of the opioid addiction. So we can play a big role in this. And we should avoid, like Dr. Akka Mahadevi, that we should avoid opioid patches for the management of post-operative pain, especially if the patient is going to be unsupervised. Certification course, yes. It is very important for prescribing opioids, as most of us do not know I mean, we don't have a thorough knowledge of the doses and how to write a prescription now, which drug to add and which not to, with opioid, what is to be done. So I think it's a very good this thing by the government that they have started with the 3-day certification course. At least all of us become well versed with the use of opioids. And it is our duty to ensure the availability of opioids for cancer patients. So Dr. Sudhir rightly pointed out that people are not doing their duty. They are not creating these RMIs, and they are just scared of using the ENDs, like the narcotic drugs. So it is very important that we should all be doing this duty of trying to procure opioids for cancer patients at least. Thank you so much. Thanks a lot for your valuable time.
Bye. Good job.
Thank you. Is there any questions to be taken? Dr. Nandita?
I think there are no questions. I cannot see any questions in the chat box. I think we have covered it so nicely that people are spellbound and they don't have any questions. So,
Or they understood very well.
Yeah, that's what. Or they are all opioid addicts now already.
I know. Thank you so much, Dr. Nandita, and the audience for having
Thank
given
you,
us
everybody.
opportunity. Thank you so much.
Bye,
Thank you. Thanks a lot. Thank you so much. Thanks, everyone.
Thank you, Ruchi, Nandita. Bye-bye.
Bye-bye. Bye.
Bye-bye. Thank you.
हाँ जी बच्चे देख
Rahul is here. Vikas is here. Initial the follow that. Okay, the genetic modification of follow. How do we manage it? Non-medical surgeon rescue, evacuation, reduction of radiation, and dosimetry. Quarantine them, isolate them, trial them, site cleanup and reconstruct. Medical management is life-saving measures, decontamination, reproduction and decompression, and radioactive waste management. This is again very important thing. Site, person, and hospital all have to do. I have finished my presentation. In the Rohit. Where is Rohit? Rohit.
Okay. Hello. Am I audible? Hello. Okay. Am I audible? Am I audible?
Yes, Rohit, you are audible.
Yeah, you are audible.
Okay, so we are moving forward and start our next session. That is DSA, Defense Society of Anesthesiologists Forum. For this session, I like to invite Maas Jain Rashmi Datta, Brish DK Srinivastav, Society of Anesthesiologists Vinder Singh, and moderator and point contact Brish Vikas Srivastava as a chairperson. Hello. And moderator Maas Jain Rashmi Datta, are you there?
Yeah, I'm there.
Okay. Brish DK Srivastava, are you there? Mass Jen Rashmi Datta. Okay, I request the chairperson, please continue this session.
I'm here as well.
Okay, invite speakers and continue this session.
I'm here as well.
Karuna.
Hello, Rohit. I can't
Start
see
video
my
abhi. अच्छा मेरी शक्ल नहीं दिखाई देगी लेकिन हाँ करो फिर जरा उसको ऑन
तो अगर वो मेरे को ना
हाँ नहीं मेरी शक्ल नहीं आई अभी तक
फोन आ जाएगा। अच्छा
हाँ वो श्रीवास्तव सर आएगा और मेरी दिखाओ स्टार्ट माय वीडियो ओके ओके हाँ वो श्रीवास्तव सर आएगा और मेरी दिखाओ स्टार्ट माय वीडियो हाँ प्लीज दिखाओ start my video good afternoon everyone can you hear me hello
Yes, sir.
Yeah,
can you hear
Dhaval.
me? Okay can you hear me? Okay, good afternoon everyone. My topic is transcatheter aortic wall replacement.
Yes, sir.
Next slide. Okay, next slide.
Who is our host?
So aortic
Ma'am,
stenosis,
why
as
don't you
you
just
all know,
take
is
over?
a progressive narrowing of aortic wall.
Host.
Ma'am, he's handed it over to us. Ma'am, why don't you?
Hello, can I start, sir? Okay, aortic stenosis is progressive narrowing of aortic wall. So most important thing for us to know is what's the wall area and mean gradient. Aortic stenosis is progressive narrowing of aortic wall. Hello. And severity is hello. अरे कुछ हो ही नहीं रहा मेरा आ ही नहीं रहा अभी तो मैं नेक्स्ट स्लाइड बोलूंगा तो आप स्लाइड चेंज करोगे ना या हेलो okay. Aortic stenosis is progressive narrowing of aortic wall. And severity is based upon, I can't hear it. And severity is based upon wall area and mean gradient. So as far as we are concerned,
Naresh, you're not audible.
No, I'm audible, sir. I'm audible.
Now you're audible, yes.
Okay, sir. I'm just starting it, sir.
Yeah, start. We
Yeah.
have to finish this session. Sorry to sound this. I have to finish this session at 4 o'clock because of the meeting that we have.
Sir, I'll rush through my slides. I'll just say next, then
I think there are
next
technical
slide can be
glitches, but
flashed.
we'll start off. Yeah, we'll carry on.
Okay, so aortic stenosis is progressive narrowing of the aortic wall. As far as we are concerned, we have to know what is the mean gradient, and it is more than 40, and very severe, it's more than 70 millimeter mercury as far as we are concerned, because the this diagnosis is already made by cardiologists and cardiac surgeons by looking at transthoracic echo, transesophageal echocardiography, and CT angio. Next slide, please. Next slide. Okay, there is an entity known as low flow, low gradient AS. Why I'm mentioning this entity? Because of the severe LV dysfunction in which the ejection fraction is less than 50% in some of the patient, the actual AS is masked. So we subject these patients to dobutamine stress test. If the gradient increases with the increase in contractility, then that means the AS is actually there and it is severe. If the gradient does not increase with increase in contractility, that means the AS is pseudo-severe. And if we subject this patient to surgical aortic wall replacement, then mortality is high. Next slide, please. Next slide. So what is the management? One is we treat the comorbidities, but what the gold standard of management of aortic stenosis is nothing but surgical aortic wall replacement. But what about the patients who have got multiple non-cardiac comorbidities? Next slide. Next slide, please. So pathophysiology, we all know there is a hypertrophy of the ventricle will leave here only, and patient has got high intraventricular pressures, systolic and diastolic dysfunction. Next slide, please. Next. So just to overcome severe aortic stenosis, which cannot be subjected to surgical aortic wall replacement, a Benul aortic valvoplasty was introduced by Dr. Caribia, but the chances of restenosis were very high. So now the thing is that we have got logistic Euroscore system in which the mortality increase after open cardiac surgery if the score is more than 13%. So to subject patient to transcatheter aortic wall replacement, we have three scoring system. One is logistic Euroscore, which should more than 20%. One is STS, that is Society of Thoracic Surgeons score, more than 10%. And when to select, if the predictable risk of mortality scoring is more than 10%, and we subject these patients to surgical aortic wall replacement, then the mortality is 16.4%. And then, as you can see, in TAVR, the mortality is just less than half. Next slide, please. So a brief thing about history, I'll not go much into detail. I'll just say there was a concept that if we create a wall by porcine aortic wall by creating a leaflets on a metallic stent, and we just inflate this stent into the aortic wall, so which is analogous to a coronary stent. So it was ultimately performed in Rouen by Dr. Alan Caribbean, a 57 years old man. And now the clinical trials are saying that even in the patients who have got low cardiac risk of open heart surgery, we can subject these patients to transcatheter aortic wall replacement. That means if the Euro score is less than 10% versus more than 20%, even less than 10% patients can be qualified for transcatheter aortic wall replacement. Next slide, please. So these are certain outcomes which I have compared surgical aortic wall replacement versus transcatheter aortic wall replacement. Gentlemen, we should know this, that if don't offer some kind of surgery or some procedure in symptomatic aortic stenosis patients, 75% of the patient will die 3 years and 50 to 60% of patients will die within 1 year. So as you can compare, only thing which I want to highlight is for other things, the mortality is low in TAVR, except the major vascular injury, which is 10 to 15%. Major vascular injury is more in TAVR it is less in surgical aortic valve replacement. It is only 3%. Next slide, please. So we have got two types of wall. One is Edward Sapiens wall, which is a prosthetic is crimped onto expandable balloon and positioned via retrograde arterial approach at the level of aortic annulus. This is actually the framework is steel or cobalt chromium. We have used, in my experience, we have done 92 cases in entire armed forces, but we have done not more than 5 to 6 of such kind of walls. So will not speak more on this wall, but the next wall I will be talking more about it. Next slide, please. Next slide. This is the Medtronic core wall. Medtronic core wall is Evolute R wall, which we are using. We have used most number of these TAVR walls in our patients. This wall has got a tissue attached to a flexible, self-expanding nickel titanium retinol frame for support. Please understand nickel titanium because it has got its attribute. Because when this wall is cooled, it gets crimped. But when this wall takes the body temperature, it expands by itself. So it is self-expanding core wall. And it has got two anchoring points by which you can reposition it or retrieve the wall. Next slide, please. So these are the indications of TAVI. As I said, patients who are having multiple comorbidities, like suppose patient cannot be subjected to open heart surgery because of advanced lung disease, COPD, pulmonary hypertension, liver disease, prior stroke, CKD. If the patient has got porcelain aorta in which the chances of strokes are very high, severe kyphoscoliosis, cirrhosis, or extensive mediastinal radiotherapy, the term frailty is just added recently. And the previously replaced mitral valve, which was mechanical in nature, we cannot subject these patients for surgical aortic valve replacement. The mortality is very high. For these patients, the TAVR was devised. Next slide, please. So what are the anatomic evaluation and why should a cardiac anesthesiologist should get involved in all this evaluation? Because of the inherent complications. We can say, yes, the severity of AS is assessed by cardiologist and cardiac surgeon. Yes, that's true. But why should we get involved when they are assessing a CTO angio which has got a TAVR protocol? The CTO angio is a gold standard as far as our institution practice is concerned, in which we'll see the wall anatomy. It is bicuspid. Initially, it was contraindicated to do TAVR in bicuspid because the aortic annulus is elliptical, not circular, which is there in the tricuspid aortic valves, which we see in degenerative type of AS. So we also see whether the vessels are small, from which we are going to take this wall. If the vessels are small, there are chances of vascular injury. So we have to be prepared. What is the nature of ostia, where they are lying from the aortic annulus? If they are lying low, like in old ladies, like in small stature ladies, the aortic or the coronary osteas are lying low into the sinus. So there are potential for coronary osteal occlusion. So we should be prepared and we should have a combined assessment of the patient with the cardiologist. Or patient has got basal septal hypertrophy, so there are chances of malpositioning of the wall. And what is the severe of mitral valve disease? Next slide, please. Next slide. So what are the indication of TAVR? First, most important contraindication, if you don't have a open cardiac surgical care unit in your hospital, don't attempt TAVR even if you have a cath lab. If the patient has got a small aortic annulus, less than 18 millimeter, or patient has got congenital bicuspid aortic valve, it's a relative contraindication because we have done sizable number of cases of bicuspid aortic valve in AHRR. And if there is an untreated CAD, it is again relative. Like you can place a TAVR, you can do TAVR, and you can stent a vessel. Or there is a mechanical aortic valve in situ. Obviously, you cannot do TAVR. But if there is a bioprosthetic valve, which was surgically replaced previously, we can do a wall-in-wall procedure. If the patient has got severe MR, severe PH, AS with AR. Now again, AS with AR is a relative contraindication because now or they are contemplating putting TAVR in AR patients also. Mind you, I just said AS patients need to go SAVR or TAVR, or patient has got intracardiac thrombus and dialysis dependence is also a relative contraindication. Next slide, please. So what should we do? All the carry home message, as far as I am concerned, I will look at CT angio sitting with a cardiologist, because other measurement, the wall people who are providing the wall and the operator, it is their baby. But I am looking at the vessels, I'm looking at the chest, I'm looking at the patient's airway, and I'm looking at the vascular axis. So we should be having some sort of imaging modality before procedure or intra-procedure, like transthoracic echo or TEE. Next slide, please. Next slide, please. So these are approaches. As you can see, you can go from femoral route, or if the vessels are tortuous, they are laden with calcium crystals, then obviously you, or vessels are very small, then you go by subclavian or axillary route, or you can go by transaortic or direct aortic route, or transapical, which is most invasive, which is the highest mortality. Next slide, please. Next slide, please. So consideration are these. One important thing is patient has undergone CABG, patient is subjected to TAVR. If this patient crashes, we have to have CT of the chest so that surgeon can decide which route to take for cardiopulmonary bypass. Then we have to do LFT, KFT, hemoglobin, PRBC. Obviously, all these things will be somehow deranged. That's why this patient is being subjected to TAVR. So careful airway evaluation, ECG, just to see there is any rhythm abnormality or not. Because patient with severe LVH, they have got stain pattern, they can have LBBB also. So we don't want our patient to have complete heart block on table. So we should be knowing everything. Prophylactic antibiotic, aspirin and clopidogrel. This practice varies from institute to institute. Next slide, please. So more than our ability to provide anesthesia, that is general anesthesia in severe cases, or local anesthesia with dextromethorphan, that is monitored anesthesia care, our managerial skills are at the stake in the hybrid operation theater or cardiac cath lab. I'll just show to you. I'll show it to you one of the slides in which you can yourself appreciate how difficult it is to approach the patient in case of emergency. So we have to work as a team, but as I said, we are working out of the box and we are working in a claustrophobic spaces. And mind you, if these patients crash, this is very difficult to resuscitate this patient because it's a fixed orifice lesion. No amount of CPR will bring about the patient. There are serious complications like hemorrhage, vascular rupture, cardiac arrest. There are cases in which annular rupture can take place. There are cases in which you can have retroperitoneal injury. There are cases which wall can migrate into LV cavity, valve can migrate into the aorta. It can lead to severe cardiac stunning. So everything has to be prepared beforehand. Or obviously there should be a facility for FEM bypass if the ejection fraction is less than 20%. That is protected. One of the way to give some support to the heart if patient crashes. Next slide, please. Next slide, please. Next slide. Next slide, please. Yeah. Most important thing here is, which I wanted to show, which I that previous slide was just missed. I wanted to show that you have to have a very long infusion lines. You have to have all your vasopressor inotropes prepared. All the lines will be placed. Like we will plan as patient will crash and will do surgical aortic valve. So I take my patient the way I do it. I consider every patient is going for a surgical aortic valve replacement. Patient will crash. Ultimately, we'll have to take this patient to operation theater, which is on the same floor. So what we'll do is we put 3 lines. One is a 3-lumen right interjugular line under local anesthesia. Then we put a 8.5 millimeter sheet also. Through that, a temporary pacemaker implant will be done in right ventricle. and we check that. Then we put defibrillator pad on the chest. We see the ECG. Yes, ECG has to be there. And then we put a right radial line, and then sometime we put a sheet in left radial artery also to facilitate the cardiologist so that they can have a shoot at the coronary artery. They can do it independently. Then when you will give this patient the general anesthesia or local anesthesia plus dexmedetomidine. Gentlemen, we started from general anesthesia. Every patient, my initial 3 or 4 patients were intubated. After that, we came to LMA. And after that, 70 to 80% patients, I will say we have done under local anesthesia with dexmedetomidine. And few of the patients, maybe 3 to 4% patients were converted into general anesthesia because the inability of patient to keep immobilized on the table when they are doing the shoots and where they are implanting the wall. So next slide, please. Next slide. So keep cross batch blood ready. They bleed like hell. The international rate of transfusion is 14 to 16%. Our rate of transfusion is 25%. And we also anticoagulate this patient. We have to keep ACT more than 300 seconds. Intermittently, we give heparin, unfractionated. CPB standby, avoid CIN. Next slide, please. Next slide, please. LA versus GA. I mean, whatever you do, it is up to you. How bad is patient? If the patient has got very poor LV, then obviously I'll go for GA beforehand. If the patient is having some degree of MR borderline, I am comfortable putting this patient under GA and then taking this call, because as such patient will be ventilated in ICU. Next slide, please. Next slide. So technique is same. The another advantage of GA that you can able to put a transesophageal echocardiography by which you can measure the paravalvular leak, which is a very important complication of this procedure, because if the leak is more than 20%, you have to do a procedure or the patient will deteriorate. So we use less narcotics in this patient because we are not subjecting them to CPB as yet. So less narcotics will be used. Any technique is used for induction. Make sure that you maintain the goal. Keep them where they live. What is their pre-op hemodynamics are there on which patient is comfortable. Please attain those goals on table. Next slide. So there are 3 stages. One is procedural stage, in which nowadays we don't require a vascular surgeon. The operator takes a micro puncture, see the contralateral vessel. From there, he is going to take his sheet in. And here the liberal dose of local anesthesia agents are required, like lignocaine with bupivacaine, I prefer. And we are giving in intermittent doses as per the calculation. So 20 ml of lignocaine and maybe 15 ml of bupivacaine without adrenaline can be safely used in this patient. And at this stage, patient can hemorrhage, dissection, or vascular rupture when they are taking the sheet in. Next slide, please. Balloon valvoplasty. This is very important step by the operator, in which they inflate the balloon. So at some point of time, there is actually no cardiac output. So at this time, patient can have convulsion because hypotension. There is a severe hypotension, but it's not very long lasting. It is only for 3 to 4 seconds only, or intermittently they can expand. But most important is,
Brigadier Dhawan, if I may interrupt, you'll have to hurry it up because we have 3 more speakers to go, and we have.
Sir, I'll just next slide.
Please,
next slide.
yeah, please just wind
Okay,
up.
sir. Next slide, please. Sir, I will just talk about this for a minute because this is the most important procedure during the entire course of putting a patient to TAVR, because we subject these compromised hearts to rapid ventricular pacing. Gentlemen, please appreciate the blood pressure which we are aiming is 70 millimeter of mercury. And in our institution protocol, we aim even to 50 millimeter of mercury, because this rapid ventricular pacing is required for one thing. One is balloon valvoplasty. Second thing, when you are placing the aortic wall. Otherwise, if there is a jet of blood from the aorta, so there are chances of wall malposition, there are chances of rupture, there are chances of wall migration. So this step is very important. So generally, it is indicated that for core wall, which we use, the rapid ventricular pacing during the wall placement is not required, but as an institutional protocol, we always subject our patient, because this is the time the heart is most stunned. So please tell the operator, sir, abhi thoda chhod dijiye, let the heart recover, because this pacing is done at 160 to 220 beats per minute. Next slide, please. So, as I told you, at this time, coronary ostial occlusion can take place, arrhythmia, AV blocks, asystole, perfused ventricular activity can take place. And most important is paravalvular leak if the wall is underside. Next slide, please. Next slide, please. Post-deployment, there will be hypertension. So you treat with vasodilators. And 3 to 7% patients has got permanent pacemaker implant. We are also get 5 to 6% patients require permanent pacemaker implant. So we have to keep TPI for at least 2 to 3 days in the patient. So other complications are like cardiac tamponade, hemothorax, and retroperitoneal vessel injury. So keep your perioperative care extends from cardiac cath lab to the CCU now. So at least for 48 hours, you have to look after your patients. Next slide, please. Next slide. Next slide, please. I already explained paravalvular leak. Next slide, please. Extubation you can plan if the patient has a tumultuous course in the cardiac cath lab. He was subjected to many attempts of rapid ventricular pacing. Best not to extubate this patient. Let the patient recover in CCU under your guidance, under monitoring, under anotropic or vasodilatory support, and some degree of sedation. Next slide, please.
Naresh, you may have to hurry up because of the GBM.
This is the last slide in which I will just say, I will not read much about this slide. I will just say
okay.
the TAVR was
the GBM
devised.
is there.
Okay, ma'am. Okay, next slide, please. Next slide. Thank you. I hope I was able to give some insight into this entire procedure.
I'm sure that this presentation will actually not allow for any other questions left. So thank you so much, Naresh. You did a great job.
I must
next speaker, Surgeon Captain Vidhu Bhatnagar.
Okay. Right.
To go on with her topic, which is culture of quality in anesthesia education, which is extremely important these days, what with all these medical colleges which have come up all across the country. So Vidhu, please go ahead and enlighten us on your topic.
Good afternoon, sir. Thank you for this kind words. Would you my screen, sir?
I would request the organizers to please play the presentation.
Thank you so much.
Tech team, please play the next presentation.
Afternoon. A warm welcome to everyone from the land of spices, God's own very country, Kerala. I bring warmth, rain and sun from my hospital, NHS Sanjeevani, Kochi. First and foremost, I would like to thank the organizers for giving me this opportunity. For next 12 minutes or so, I'll be speaking about culture of quality in anesthesia education. The scope of my talk is as follows. I'll be talking about objectives of quality assurance in medical education in India, why culture of quality is important, and how to inculcate culture of quality in individuals. If metaphors are drawn, anesthesiologists are like pilots. They function as a part of a high-performance team with high stakes, use technology with great skill and accuracy, and have complex and unpredictable work environments. There is definitely no room for errors. Checklists, cockpit drills, monitors, safety protocols are an integral part of our lives. Functioning in a team, detailed plans, backup plans, and sometimes even backup to backup plans are actually a day-to-day functioning for us. Quality assurance is defined as an organized process that assesses and evaluates health services to improve practice or quality of care. The objectives of quality assurance are risk reduction and continuous quality improvement through rigorous self-examination, ensuring a high standard of anesthetic care with focus on patient safety during perioperative period. Important indicators to measure the quality of anesthesia in modern clinical practice are safety, effectiveness, and patient's experience about the whole anesthetic procedure. Internationally, World Health Organization and World Federation of Medical Education have established joint policies on improvement of health system performance through improvement in education of health professionals. Various initiatives have been taken internationally for quality assurance in higher education, establishing accreditation standards for basic medical education, postgraduate medical education, and continuing professional developments of medical doctors. In India, National Assessment and Accreditation Council was established in 1994 by University Grants Commission. The mission to assess and accredit higher education institutions in the country. Although NAC has addressed the issue of accreditation of health science institutions, not all medical colleges are eligible for external review by NAC. To remain in competition with global institutions, the medical education institutes in India needs to catch up with international accreditation standards based on WFME global standards. I ask you, ladies and gentlemen, as a patient, what quality levels would you accept from your health services? Is it as low as 90% or as high as 99.9%? You can take a second to think about it. If 99.9% is acceptable to you, then your heart fails to beat 32,000 times each year. 500 surgical operations are performed wrongly every week, and 9,000 babies are dropped by doctors at birth. In our profession, ladies and gentlemen, there is plenty of space, but no room for error. There are no second chances. Therefore, quality is of utmost importance, and quality has to be 100%. Medical Council of India Vision 2015 document mentioned overall goal of medical education in India is to prepare a competent health professional who is capable of serving as a physician of first contact while being globally relevant. Most of the points have been met. However, one aspect that is partly addressed is self-evaluation and monitoring. The National Medical Commission Act 2019, number 30 of 2019, came into force on 8th of August 2019. This is an act to provide for a medical education system that improves access to quality and affordable medical education, ensures availability of adequate and high quality medical professionals in all parts of the country, amongst other objectives. After advent of COVID-19 pandemic, when the medical education really suffered and online education and assessment became a norm, National Medical Council also introduced module on online learning and assessment in 2020. Quality assurance is a process that requires transparency and dissemination of results to all stakeholders. Striving for quality means entering a circle where continuous quality improvement is required. Thus, quality education is responsibility of all teachers, students, administrators, and management of the institution. The ultimate goal is to improve the quality of healthcare And that will happen only if we take care of the quality of medical education. But any system is as strong as the weakest link. The systems are in place, the processes are in place, but are they effective enough? The individuals, are they motivated enough? Are they motivated enough to follow these processes and be a part of the systems-based practice? Anesthesia, ladies and gentlemen, is a specialty which facilitates care but seldom cures. However, this does not diminish our role at all. Our technology, training, and skills make possible radical interventions and near miraculous cures. But because anesthesia seldom cures diseases, the challenge of precisely defining anesthesia quality is inherently difficult. There are other problems. The risk of anesthesia is impacted by many other variables like patients' comorbidities, the surgical process, equipment. Thus, the questions are, what standards to determine success or failure? What strategy of care produces the best outcome? And what is the quality in anesthetic care? Anesthesiology was one of the first medical specialties committed to a systematic, widespread, and statistical understanding of quality. ASA Physical Status Classification, which was first proposed in 1941, is such an example. This system was to correlate the relationship between result, the operative procedure, and the patient's operative condition, and it was not designed to estimate operative risk. However, its use over more than 50 years has proven it to be an excellent predictor of overall surgical mortality. Our commitment of quality is also because of advancement in anesthesia techniques, availability of newer drugs and newer monitoring gadgets, increased awareness amongst the patient population, implementation of newer medico-legal laws, and professional competitiveness. So, what is the way ahead? How do we maintain this commitment to quality? What we need to do is to have a competency-based education in post-graduation too. Education, which is outcome-based, evaluates knowledge, skills, and attitude. Learning is individualized, and learning mostly occurs in the workplace. Our residents need to fill the gap from novice to become an expert. The journey from competent to proficient to expert moves from acting with direct supervision present in the room to acting absolutely unsupervised, and some may even move forward to provide supervision to others. Most of our skills are entrustable professional activities, and we need to build these entrustable professional activities. The airway techniques, regional anesthesia, central venous cannulation, most of them are entrustable professional activities in our specialty. They not only need to be built, but also need to be assessed at regular intervals with OSCE, directly observed procedural skills, simulated patients, simulated charts, simulations. Psychomotor skills are not only to be built, but also the effective skills like interpersonal communication, professionalism, leadership, following system-based practice also needs to be inculcated and assessed. Quality determination requires a prior knowledge of what is efficacious. The establishment of quality should rest upon a firm foundation of efficacy. We need to know what right is before we can determine whether the right thing was done and whether it was done the right way. Kolb's cyclic reflection tells us about what happened, analyze what happened, do a reflective observation, make generalizations in abstract conceptualization, and move on to plan future action. So reflection needs to be taught and followed. Audit, be it internal or external, has to be practiced. The audit can be done for inputs, processes, and outputs, and thus individual systems and processes can be audited, problems can be solved, and suggestions can be made for improvement. Checklists need to be meticulously followed. Institutional protocols have to be framed and followed, and standard operating procedures also need to be framed and followed depending on the efficacy. So I conclude my talk, ladies and gentlemen, with this fact that quality is a teamwork. one person can never do quality. And self-assessment is the best assessment for any kind of improvement. So building a culture of quality in anesthesia education is the way ahead for our generations to come and to show that we always maintain 100% quality. Thank you, ladies and gentlemen. These are my references.
The topic is now open for any questions.
Yeah.
Since there aren't any, and Vidhu, I'm sure you'll be able to answer them on the other forum. So we go on to, I'll request my co-chairperson to please call the next speaker.
Thank you, sir. Thank you so much.
Thank you so much.
Thank you, Brigadier Shivendra. I now invite Lieutenant Colonel Shibu Shashidharan to deliver his talk on combat regional anesthesia for combat trauma. Shibu is a young bright star of our anesthesia protagonists on a UN mission. He is going to be enlightening us on regional anesthesia for combat trauma, which is very much burning topic, and I think we will all be benefited from his deliberation. So, Shivu, over to you. Please take charge. Thank you.
Thank you so much, sir, for that very kind introduction. May I request for the video to play, please? Good afternoon, everybody. At the very outset, I'd like to thank the Scientific Committee of Isacon for giving me an opportunity to share my views and thoughts on the topic I'm going to talk about, and also compliments from Chandimandir for holding this first hybrid conference. So today I will talk to you about regional anesthesia for combat trauma, and I will share my experiences of administering anesthesia under these situations. So since we are talking specifically about regional anesthesia, let's quickly jump into how the statistics of it stands better than a general anesthesia. Medical literature is replete with instances and evidences through a lot of randomized controlled trials that the effectiveness of regional anesthesia stands because it causes at least 25 to 30% reduction in pulmonary complications and death. There's another study that says that regional anesthesia lowers mortality, hospital stay, and ICU admission. And in a very recent paper that was published in 2020, they say that spinal decreases adverse events, operation room time, and facilitates discharge home faster. So let's now talk about the Indian Armed Forces. So, ladies and gentlemen, as you're already aware, the Indian Armed Forces are the military forces of our country, the Republic of India, and it consists of 3 professional uniformed services, the Indian Army, the Indian Navy, and the Indian Air Force. So, unlike what popular belief makes one think that the number of cases of trauma in the military hospitals are much more than the civilian counterparts, is actually not true. But the cases that we get are actually mostly trauma cases in young serving population. So the injuries that we see on the combat zone are either penetrating, blunt, environmental, or blast injuries. And in case the injury is caused by an explosive, then all the above 4 injuries come together. This is a particular study that we got from the defense data, which was published in the year 2006, that shows the basic distribution of injuries that is generally found in a combat zone. The kind of injuries that we get on the combat zone is the same for all militaries. And so as you can see in the picture, the injuries that we get for the extremities is much more than the injuries that we get anywhere else in the body. So the goals of combat medicine are very clear, is to get the number of people who are injured back to the combat zone as fast as possible. That is, we need to restore their health as fast as we can to save life, to save limb, and to save the eyesight. The peculiarities of the combat zone is pictured in this particular frame that I've shown with you. This is a medical setup that we have in Siachen, where every night the snowfall actually covers our medical establishment there, and in the morning we actually dig it out every other day. So the austere environment, the accessibility, and the resource constraints, along with enemy operations, make working in such situations very, very difficult. The most difficult thing is the second point actually, is in case we get stuck, the accessibility to replenish the resources becomes very difficult in austere environments. So what is actually the role that regional anesthesia plays in all of this? The most important thing is, as soon as the patient gets injured, the thing that bothers them the most, quite imaginably, is pain. So if the pain part of the injury in a combat zone is not taken care of fast, it leads to a sequelae of problems. So what actually happens at a physiological level is pain involves activation of complex interactions between the autonomic, peripheral, and central nervous system, and also the endocrine and immune system. And this the persistent nociceptive stimulation causes various changes in pain physiology, leading to a very specific entity called as pain sensitization. So the cellular changes in the periphery and central nervous system result in peripheral and central sensitization, which subsequently leads to chronic pain. So acute pain, if not treated properly, it leads to chronic pain, and it can also subsequently lead to something called as PTSD, which is post-traumatic stress disorder. And unfortunately, around 15 to 35% of patients with chronic pain also have PTSD. So pain is something that we need to address at the very earliest. So there is a concept called as block on arrival, which is very famous internationally, and lately it is being practiced in a lot of states, even in India. This particular concept was spearheaded by a hospital called Ganga Hospital back in Coimbatore in Trivandrum, where they started giving regional anesthesia to all cases of trauma that reported their hospital. Presently, this technique is being followed in a lot of hospitals in the military as well, because it allows for a pain-free initial examination. It facilitates use of tourniquet to control the major bleeding, and it also allows to get good radiographs even without having to take it with a bandage on. All these things generally make the patient in so much of distress because of the pain on moving that affected limb. So the advantages are very simple. It is a much easier procedure to conduct. It is safer because even if the patient has got a full stomach, you can go ahead, give a regional block and go ahead and do the anesthesia. It does not tamper with your normal physiology, which happens in the case with a general anesthesia. It is much faster. It allows to have a patient interaction. You can keep having interaction with the patient, as in even it helps you to take a consent for particular procedures when you're going having the patient undergo the surgery in regional anesthesia. It is a cheaper alternative, and it helps on saving resources, because even in a post-operative care, if the patient is having relief from pain, that helps the patient, it helps you. And most importantly, it helps you to give lesser drugs, specifically narcotics, because narcotics subsequently also causes drowsiness in the patient. That is one of the side effects of giving narcotics. During the COVID scenario, of course, the situation was very difficult for all of us, because as a rule, we stopped doing all the elective cases, but in the combat zone, that was not an option. So we had to take care of all the cases of the trauma that came to us. So this particular technique helped us to actually conserve manpower, conserve the drugs. It reduced our operation time. It could bypass the PSUs, and the patients could directly go into the ward. And it allowed us to stay away from intervening with the airway, which was an aerosol generating procedure. And it also gave us time and space to keep patients of COVID who actually required it in our ICUs. So when a patient comes to us, the basics are basics. We first take care of the A, B, C, D, E of ATLS, in which a very important thing that we need to take care is to actually document the D part, the disability, because since we are doing a procedure that is perineural, we need to make sure that no deficit which is noticed by the patient at the end of the surgery is attributable to the technique per se. So as the ATLS is being done, make sure to document any neural deficit which is either seen because of the open injury or which has been elicited by an examination. It is very important while doing a neural block. The methods to give regional anesthesia is, of course, either by doing the anatomical method. Now, this is more of a traditional method which is not practiced so much more these days, only because of the advent of peripheral nerve stimulator as well as ultrasound guided blocks, which we use more frequently now. But in case of a situation where we do not have peripheral nerve stimulators or an ultrasound available with us, of course, anatomical blocks are still used. I'm not going to get into the specifics of what block is given for what particular part of the body and the kind of the procedure that is involved with the blocks because of the pure paucity of time. But as you're all aware, regional anesthesia can be given to practically any part of the body, right from the upper limb, from where you can start blocking from your brachial plexus all the way down to your ring block, where you can specifically target the end nerves for giving anesthesia. Moving to the lower limb, where you can anesthetize both the limbs. Now, when you're giving anesthesia for the lower limb, one particular thing which has been taught to me also when I was a resident, and subsequently what I teach my residents as well, is to be very, very aware when you're giving blocks to a patient with a proximal fracture of the tibia, because it is very, very prone to having a compartment syndrome. So when you suspect that the patient might go into compartment syndrome, especially in cases of proximal fracture of the tibia, make sure to keep monitoring the patient very, very carefully. Look for his peripheral pulses, look for the temperature of the skin, look for the, if there's any swelling that is developing. And in case it does, a fasciotomy has to be done at the earliest. So this particular diagnosis is one instance where there is a slight, there's a slight confusion as to regional anesthesia has been given. Has to be given or not, but all other cases, regional anesthesia for the lower limb is very frequently practiced. Till not very long ago, regional anesthesia was not given for the chest, only because of the complexities which arise because of the structures that are there in the thorax. But lately, the rectus spinous plane block, the PEX block, which is the pectoralis plane blocks, and also the serratus area plane blocks have come so much into vogue and are very frequently practiced. It is easy to administer and it gives excellent pain relief. Another blocks that is given in the thorax are, of course, the paravertebral blocks and the thoracic epidural, which can be given for both unilateral and bilateral side of the chest pain reliefs, respectively. In the abdomen, there are many blocks, but nothing compares to the transabdominal plane block, which is given where local anesthesia is installed between the internal oblique and transverse abdominals, and it gives fantastic pain relief even for laparoscopic procedures. Awake craniotomy requires the patient to be awake, so there are few blocks that we give for that. The picture is there on the screen. So a regional anesthesia can also be given for such an invasive procedure like an awake craniotomy. When do we give a peripheral nerve stimulator blocks? Obviously, it is when you do not have the availability of ultrasound blocks. But the only disadvantage, the bigger disadvantage of using a peripheral nerve stimulator block is the fact that you cannot, you have to give slightly a higher dose in volume of the drug, just because you cannot, you don't know how close you are, how perineural you are where you're depositing the drug. So slightly a greater amount of drug has to be delivered. Apart from that, since it is a blind procedure, there is a chance of intravascular extension of the needle, which can give the needle and cause systemic toxicity. A lot of times when I'm giving a peripheral nerve stimulator aided block, I choose to give lidocaine with adrenaline, and the moment adrenaline gets into your bloodstream, and there is a increase of basal heart rate more than 15, you know that it is a intravascular extension of the drug, and that is when you withdraw the needle and stop the procedure. Different adjuvants have been advised. Dexamethasone, dexmedetomidine, and buprenorphine are the drugs of choice. There are a lot of studies, a lot of RCTs that gives the supremacy of all these three. Adrenaline and magnesium also figures in the list, but the drug of choice, and especially in combat trauma, where a lot of times when you are receiving the patients are from the periphery, that is where the doctors are giving the block. Subsequently, the patients are shifted to higher medical centers where vascular and reconstructive surgeons are available. They like to choose dexamethasone because giving steroids gives three major advantages. One is it increases the duration of the block to around 8 to 12 hours. Second is the fact that it if a general anesthesia is given subsequently, it reduces PONV, and most importantly, steroids are known to reduce the inflammation, so it has a effect on that level as well. Mixing drugs is a very common topic which we talk about, whether we can mix bupivacaine and lidocaine, can we mix bupivacaine and ropivacaine. Mixing of drugs is not advised because it is thought to have a synergistic effect on each other, and the systemic toxicity chances are believed to be much worse. There are a lot of articles on this regard. Last slide of mine, and the last topic that I'm discussing is local anesthetics induced systemic toxicity. Make sure that you have intralipid available with you, so that in case of any toxicity, you can handle it very well. Anesthesia is a fantastic way to take care of patients in combat as well as in regular trauma, and one of our main tasks is to alleviate pain. So no pain to any of our patients. Thank you so much.
There is no audio.
The audio is there.
It has come now.
Yes, sir.
Yeah. Proceed.
Good afternoon, esteemed chairperson. At the outset, I would like to express my gratitude to the organizers for giving me this opportunity to share my views and experience with the august audience. I'm a neuroanesthesiologist, and I would be shedding some light on how the present pandemic, which is still raging, has affected the practice of neurosurgery in general, how the neurosurgical teams across the world in general, and India in particular, change their practice patterns, devise protocols to tackle this pandemic, and how this practice changes have affected the final outcome. It would be an understatement if I say that the world was underprepared to meet the challenges faced by this pandemic. All the elective surgeries came to a standstill, be it neurosurgery or any other subspecialty, as all the available resources and manpower was directed to tackle the pandemic head on. However, the emergencies kept on coming in, and there was a felt need to at least cater to these emergencies. But there was a shortage of manpower, there was a shortage of equipment, there was shortage of personal protective equipment in the initial phase. Hence, the various neurosurgery societies, neuroanesthesia societies formulated broad guidelines to face this pandemic. Now, these guidelines which were formulated by the various societies were not validated. They were based on the experience gained from the earlier H1N1 pandemic of 2009 and the MERS pandemic of 2012. They were more beyond third-party experiences, and they still needed validation. The main goal of the guidelines was mainly twofold. First of all, to prioritize the patients coming for the neurosurgical interventions into those who require immediate surgery, those who require emergent surgery, and in those who surgery can be postponed. This was the first goal. Second goal was to devise protocols so that the neurosurgical teams could be prevented from contracting the virus. Now it's difficult to say prevent, to minimize the chances of spread of the virus from the patient to the caregivers. So how to go about managing, how to hone the neurosurgical protocols, how to devise the neuroanesthesia protocols, what PPE to wear, what interventions to take, what protocols to follow. These were the second main objective of these guidelines. So these guidelines were the torchbearers for formulation of the protocols in the various individual institutions across the world. Now, these guidelines had to be validated. This is one of the first studies which has come out of US, which delved into the actual effect of the SARS-CoV pandemic on the operative volume of cases. What the investigators did was that they investigated the total cases from March to June 2020 and compared and analyzed with a similar subset from a same time frame in 2019 when the pandemic was nowhere on the horizon. There were two things which are noteworthy. There was a definite decrease in the neurosurgical volume. But what is striking is that the investigators did not notice any change in mortality or morbidity during the initial COVID pandemic. This retrospective study coming from Brazil recruited one of the largest subjects. The methodology was the same. They compared the total patients coming admitted for neurosurgery from February to June 2020 and compared with a similar time frame from the yesteryear, that is 2009. So no marks for guessing it right. There was a decrease in the total volume of cases, but what was noteworthy is that they definitely found a significant increase in the mortality. In the year 2020, with the pandemic raging in the backyard. This study, this observational study from Brussels in Belgium, following the same methodology, almost brought out the same thing. Though there was a reduction in the total volume, it was the reduction in the elective cases which contributed to the decrease in the total cases. The COVID positive patients did not do well, and COVID positive patients subjected to surgery had the worst outcome. We at INHS Ashwini, one of the premier institutions, also penned down our experiences, which have been published in World Neurosurgery recently. The aim of our study was to validate our COVID-19 protocol and analyze how the present pandemic has affected the pattern and the volume of surgery and the final outcome. We also followed a similar methodology. We enrolled all the patients admitted in between March to September 2020 and compared with a similar cohort from the earlier time frame, same time frame. And what we analyzed was a pattern of disease, the techniques of anesthesia administered, the COVID-19 status, and the final outcome of these patients. We prioritize our cases into three categories: priority 1, priority 2, priority 3. Priority 1 cases were those who required immediate surgery within 24 hours. Priority 2 cases could wait for a week, and priority 3 cases were those who had come for routine surgery, and all routine surgery was postponed during this pandemic. Of priority 1 cases in whom we could not wait for the RT-PCR result, for example, a rapidly expanding extradural hematoma which had to be evacuated immediately, the surgery was undertaken with full COVID precautions and protocol, including the full PPE, complete PPE as per the national guidelines. Other priority 1 cases in which we could wait for the TrueNet result to arrive, or we could undertake a computed tomography of the chest, the same was done. Priority 2 patients were closely monitored and were operated once they turned negative. The operating room staff, the neurosurgery OT, was screened daily with periodically subjected to the RT-PCR test to rule out any asymptomatic infection. A designated COVID OT was dedicated, which had separate entry and exit and with isolated donning and doffing areas. Since a negative pressure OT was not available, we installed 2 split air conditioners of 2 tons each in this COVID OT. And all cases in this OT were done donning the complete personal protective equipment as per the national guidelines. Most of the cases we tried to undertake under monitored anesthesia care, and in the initial period we even used the aerosol prevention box, which was designed in-house by the naval dockyard. All our intubations we tried to do inside this aerosol prevention box in 2020. The surgeon avoided all surgical aerosol generating procedures like use of CUSA, bone drilling, and a barrier tent was erected so that only the operative area was visible, and rest of the patient could be isolated. This is a picture of a operation theater in Ashwini, where you can see the entire staff is donning the appropriate PPE. The barrier tent has been erected. I would like to bring two things to your notice in the result. If you see, since we were not undertaking any elective spine procedure, that's why there's a significant reduction in the total spine surgeries in year 2020. But there has been a significant increase in the stroke and hydrocephalus in the year 2020 compared to the yesteryear, that is 2019. As I've already pointed out, since we had not undertaking any priority 3 cases, so there was a 57% decrease in the total workload. However, if we compare the priority 1 and 2 cases across the 2 time periods, there is no significant difference, or I would like to say that the surgical load for both priority 1 and priority 2 cases is comparable across the 2 years, that is 2019 and 2020. Another thing to note is that compared to 2019, in the year 2020, we administered monitored anesthesia care to nearly 50% of our cases. Coming to the outcome, all the patients who were COVID positive did not do well. But what is more striking is that all the COVID positive patients subjected to monitored anesthesia care did well vis-a-vis those who were subjected to general anesthesia. We already shown these, that the reduction in the total volume, surgical volume, was because we had not undertaken any elective spine procedures during the COVID pandemic. A word about awake craniotomy. As they say, necessity is the mother of all inventions. So the arrival of pandemic on the Indian shores gave us a rude awakening and actually forced our hand to operate all supratentorial craniotomies awake craniotomies. And what we found out was actually quite interesting and highlighting. It gave benefit to every party involved. For the patients, there was a less variability in the outcome. We reduced intensive care stay and the total hospital stay. The scalp block, a good scalp block, forms the cornerstone for any awake craniotomy. What we use in the institution is a volume of 1 to 1.2 ml of 0.5% bupivacaine to block each of these nerves on both sides. We rarely have to resort to an invasive monitoring of the IBP or central venous pressure. A routine standard monitors for most of the times is more than adequate for the day. Dexmedetomidine practice has actually helped the monitored anesthesia care and awake craniotomy quite a lot. If we're using propofol, then we either use entropy or this monitor.
तो मोहब्बत है ये उनका है काम, महबूब का जो बस लेते ही ना, मर जाए मिट जाए हो जाए बदनाम तो दुजाने दुआ हम ना ये जो मोहब्बत है.
Now the surgeon is operating around the vernix area. So it is very important now the patient is singing. So once we told the patient to sing, he was able to comprehend and initiate this singing.
Next.
मंत्र मंत्र बोलो, गायत्री मंत्र आता है तो गायत्री मंत्र बोलो। संजय गायत्री मंत्र बोलो।
ओम भूर्भुवस्सुः ओम भूर्भुवस्सुः तत्सवितुर्वरेण्यं भर्गो देवस्य तत्सवितुर्वरेण्यं.
Now, what I would like the audience to appreciate is that the surgeon, the neurosurgeon, is operating adjacent to the Broca's area. Now, this is the most important aspect of awakeometry. You all can appreciate that the patient is not able to articulate. When he was told to recite the Gayatri Mantra, he was not able to recite the Gayatri Mantra. So this was a warning sign that the surgeon had to stop, and he stopped immediately. And this is the final outcome of the same patient. So the same patient, when the surgeon was adjusting the Broca's area and he started showing difficulty in articulation, has now been operated and the surgeon is closing. And now if the patient had not been subject to awakeotomy, you all can imagine what could have happened in the final outcome. So just to conclude, the surgery, elective surgery, should be deferred for at least 7 weeks if possible for following the COVID. And employment of monitored anesthesia techniques can go a long way in facilitating the outcome in these patients. Greetings from my institute. Thank you.
ETV 2019, they are in the booklet, and on ISA website also. And other corrections. Initial please.
Hello.
Yes. This was held.
So I think with that, we come to the end of the session. And on behalf of Major General Rashmi President of SDA,
Placed here.
And my co-chairperson, I'd like to thank all the speakers. Actually, we are sitting in the JBM, that's why it is muted tone. And I'd like to thank Sergeant Captain Rahul Yadav, Brigadier Naresh Dhawan, Sergeant Captain Vidhu, and Lieutenant Colonel Shibu, and my co-chairperson along with me, Brigadier Shibu. Just 1 minute, if ma'am would like to say something, just hand over to ma'am. She's next to me. Okay, so ma'am has conveyed her best wishes to each participant, and right now we are so it was successful. And also great thanks to Brigadier Vikas Srivastava for coordinating the entire session. So with this, we now break off, and we are sitting in the audience here to with a very important agenda in the GBM, and that is which is already begun, and that is getting our SGA ratified. So wishes all the best, and we will be sharing the good news with you all maybe in 2 hours time. Thank you all, Jai Hind, and long live SGA. Take care. Bye-bye.
Thank you, sir.
Minutes of the special AGBM held on 20th December 2020 from 5 p.m. onwards. This was as per our towards the inputs that we have to and renewal of the registration that we have to pass our audited statement. So this was held
Thank you all for joining today. We can conclude the session now. We'll meet you tomorrow.